angio or FFR, and they excluded patients who had indication for beta blocker continuation. These patients were randomized to beta blocker or placebo, and the primary endpoint being composite of all-cause death with a follow-up of 3.5 years. This is the baseline characteristic of the patients. Generally, they were nearly 65 years of age, and 1/4 were female. 2/3 had non-ST elevation MI, and 1/3 had ST elevation MI. They had received primary PCI, and they had undergone revascularization 99%. Similarly, beta blocker received by group who were on beta blocker had metoprolol, and 1/3 received bisoprolol. Now, this is the primary endpoint, which does not show any difference between no beta blocker and beta blocker group, and individual endpoints like death from any cause and new myocardial infarction also not different. What is different here is hospitalization for, this shows the death is not different. Now, see here, the event rate in placebo group, primary endpoint is very low, 2.5% per year. Death rate is 0.5% per year, which is much lower risk than post-MI patients with low ejection fraction. Moreover, it is because of the fact that they were all revascularized and all were on statin. So they concluded that patients with acute MI who underwent early revascularization with PCI and had a preserved ejection fraction, long-term beta blocker did not lead to a lower risk of composite primary endpoints. Next trial is beta blocker interruption or continuation of myocardial infarction. That is a BEAST trial. This is again investigator-initiated, supported by French Ministry of Health, large population of post-MI, and they had a hard and soft endpoint. Soft endpoint being hospitalization due to CV causes. The background is that there is a lack of consensus on duration of beta blocker therapy, and once written, majority receive it for lifelong. But recent registries have questioned the benefit. In fact, the ESC guideline says that there are some observational studies suggesting that clinical benefit of beta blocker is restricted to the first year after the index event. And ACC has said that continuing beyond 1 year has a class 2B indication. So they answered the question, is stopping beta blocker post-MI harmful? In a probe design trial, which included patients with prior MI on any beta blocker and excluded those who had ejection fraction of less than 40%. Nearly 3,700 patients were randomized to continue or interrupt the beta blocker on follow-up of 3 years, and the primary endpoint being composite of death, non-fatal MI, and hospitalization for CV causes. This was a non-inferiority trial, and the boundary of non-inferiority was set as 3% confidence interval. This is the baseline characteristic of these patients, age being 63 years, and females were underrepresented. 2/3 had ST elevation MI. Again, more than 95% had undergone revascularization with PCI, and more than 98% were receiving statins. One can see here that the event rate is 21.8% in interrupted group as compared to 19.3% where beta blockers continued. The event rate difference was 2.5%. It did not cross the boundary of non-inferiority of 3%. So they concluded that beta blocker interruption was not non-inferior to beta blocker continuation. Not non-inferior would mean that it is probably inferior to beta blocker continuation. And this interruption or the inferiority came because of numerical increase of hospitalization due to angina and following revascularization. Further, the quality of life, which was supposed to be improved with beta blocker interruption, didn't happen. Now, if we take these two trials together, we can say that beta blocker therapy is not advantageous routinely in terms of saving life or reducing MI in patients where ejection fraction is preserved, and beta blocker interruption is not associated with increase in major cardiovascular events. Both these trials were open design, that is a limitation. However, with these two trials, there are many other trials ongoing which will certainly answer these questions by 2025 or 2026. Another trial is invasive treatment strategy for older patients with myocardial infarction, that is senior RETA trial. There's again an investigator-initiated, sponsored by a medical hospital of England. It's a large population trial and endpoints are very hard. CV death or non-fatal MI. We know that in younger individuals, invasive therapy is superior to routine pharmacological therapy in patients with non-ST elevation myocardial infarction, but in elderly evidence is lacking. It is because the non-ST elevation MI in older age is a heterogeneous group. The meta-analysis of small trials did not show reduction of composite endpoints. And in fact, ESC guidelines in 2023 says that in absence of evidence, decision regarding how to manage older patients should be individualized based on patient characteristics like ischemia or bleeding risk or comorbidities or frailty or cognitive functions. So it's a heterogeneous group and it needs some answers. The question here was, is invasive therapy in non-ST elevation MI beneficial in elderly? And they included patients more than 75 years of age with NST-MI and excluded patients with ST elevation or cardiogenic shock. They went on and did patient assessment of frailty on various scales. They assessed the comorbidity also and cognitive assessment also on point score system. They were randomized to invasive strategy with revascularization within 3 to 7 days of the randomization or no PCI. The hard points, as discussed, were composite of CV death and non-fatal MI at various small endpoints. This is the baseline characteristic of these two groups. One can see that 3/4 were more than 80 years, frail, and 1/3 were really frail. 2/3 of them were having cognitive dysfunction, 1/5 were having renal dysfunction. That means they are truly representing the elderly which come into us in our day-to-day practice. And not only this, they were having dual antiplatelet therapy in majority. Anticoagulation received by 1/4 of these patients. They underwent angiography by radial axis and PCI was done in half of those with angiogram. And this is the result. There is absolutely no difference in primary outcome between a conservative strategy or invasive strategy. So, but one can see here that the coronary angiography or coronary revascularization rates are higher. In fact, there is 4-time increased risk of future angiography following and coronary intervention, percutaneous coronary interventions. So they concluded that among elderly with non-ST elevation MI, routine invasive strategy is not superior to conservative strategy. And this effect is irrespective of the frailty, comorbidity, or cognitive impairment. So clinically, one can say that as a physician, our belief that the patients, all patients of NST-MI should be managed with the invasive strategy may not be true in elderly and they can be kept initially on the initial pharmacological strategy. Next trial is finerenone in heart failure with mildly reduced or preserved ejection fraction, that is FINE-ARTS trial. It is sponsor-initiated by Bayer, large population, endpoints are hard as well as soft. They have considered total worsening heart failure events along with cardiovascular death. Now we know that steroidal MRAs have significant event reduction in heart failure and reduced ejection fraction, but their role in preserved or mid-range ejection fraction is not established. Finerenone is a different non-steroidal MRA, and they tested it to see the event reduction in patients with heart failure and ejection fraction of more than 40%. They included patients having age more than 40 years with an EF of 40% who were symptomatic and they had structural heart disease evidenced by echocardiogram, followed them up for 2.5 years. Endpoints were composite of fatal heart failure events and death. They also went ahead to check the change of total symptom score and NYHA class change as secondary endpoints. This is the patient characteristics. One can see that this is a truly aged population, more than 70 years. They were overweight, 30 kg or more per meter square. 70% were NYHA2. And this is the end result. What it showed is that the composite primary endpoint is significantly improved by finerenone as compared to placebo. And this is driven by the total worsening heart failure event reduction by death from cardiovascular causes not different. So they concluded that in patients with heart failure and mildly reserved or preserved ejection fraction, finerenone resulted in a significantly lower rate of composite endpoints, which is driven predominantly by heart failure admissions, while there was no difference in mortality. There was no difference in NYHA class, but Cancer City questionnaire score was significantly better. Now, another trial was TopCat trial, which took similar patients and used another MRA, that is aldactone. However, TopCat was NHLBI sponsored. It showed combined event reduction, which was non-significant, 11%. No mortality difference was seen in both trials, and both trials were driven by significant 17 to 18% difference in heart failure events. In TopCat, the difference is that the time to first event was monitored in TopCat, while in Fine Arts, total number of events were monitored. So one can say now that addition of MRA, finerenone, may be beneficial to reduce heart failure event, probably by their diuretic effects in symptomatic patients with ejection fraction of more than 40%. Coming to another trial, Assure DES, aspirin monotherapy versus no antiplatelet therapy in stable patients with coronary stents undergoing low or intermediate risk non-cardiac surgery. It is investigator-initiated, sponsored by South Korean Ministry of Health and Family Welfare. It has a large population of stable CAD with deaths, and it has hard endpoints of death, MI, stent, and stroke. We know that 20% of patients with deaths need non-cardiac surgery within 2 years, and continuation of aspirin perioperatively is common practice as well as guided by the recent guideline, European guideline 2022. However, there has been questions, and the question which is being answered here by this trial is, can aspirin be stopped preoperatively in patients who are having deaths? They took all patients who had at least one death, at least 1 year prior to the planned non-cardiac surgery, and they excluded acute coronary syndrome or low ejection fraction patients. The endpoints were assessed from the time of stopping the aspirin, that is 5 days prior to surgery, and endpoints we have discussed, hard endpoints, composite of all death, MI, stroke, and stent thrombosis. This is the scheme, we have already discussed that. Randomization was done 5 days prior to surgery, and the events were analyzed till 30 days. They were randomized in 2 groups, aspirin continued alone or no antiplatelets. So this is the patient characteristic of these 900 patients. They had nearly equal stable coronary artery disease and acute coronary syndrome. 85% had low or intermediate risk surgery. Mean stent implant duration was more than 5 years. Remember, they had planned 1 year only. And average 1.6 stents were received with a diameter of 3 mm and length of 42 millimeters. And this is what happened. The even primary outcome was very low. Major bleeding also was similar, but minor bleeding was slightly more in aspirin monotherapy group. So they went on to conclude that in these subgroup of patients who had disimplantation 1 year earlier, stopping aspirin 5 days prior to surgery is not associated with high perioperative CV risk. The clinical implication is that it is safe to start aspirin in perioperative period in patients who had at least 3 mm of diameter stent implanted roughly approximately 5 years ago. Now I'll rapidly go to 2 more trials which I find very interesting. Fasting or no fasting prior to catheterization laboratory procedure. Guidelines still recommend that at least 6 hours of fasting for solid and 2 hours for liquid should be advised. So what they did is that this was a multicentric investigator-initiated non-inferiority trial. They randomized 716 patients to fasting or no fasting. And the endpoints were composite of aspiration pneumonitis, hyperglycemia, hypotension. And see, this is what actually the results are is that time from solid food intake in those who were kept on fasting, in fact, was 13 hours instead of 6 hours. And time from liquid intake, in fact, was 7 hours. And see the result, composite endpoints in no fasting group is 12% as compared to 19.1%. In fasting group, a whopping 7% difference. So they went on to say that patients who are undergoing cardiac procedures, no fasting was non-inferior. In fact, it it was superior to fasting for primary composite outcome of pneumonitis, hypotension, or hypoglycemia. And patient satisfaction score were significantly better with no fasting. So clinical implication is huge. No fasting should be recommended to patients undergoing cardiac catheterization and related procedure. And there's another trial, last trial probably, continuation versus discontinuation of renin-angiotensin system inhibitors before non-cardiac surgery. Stop or not a randomized trial. Again a question, whether RAS inhibitor should be continued or stopped prior to surgery. It is unclear. Various guidelines are giving different opinions. So this is a government-funded investigator-initiated trial. The group randomized 2,222 patients to stop RAS inhibition 3 days prior or continue till surgery, and they had the endpoint, hard endpoints, death and major perioperative events. And this is what they found. There was absolutely no difference in major events, all-cause mortality or major post-operative complications. In both groups, it was 22%. However, episodes of hypotension were significantly higher in patients where ACE inhibitor was continued, but it did not result into any major or minor post-operative complication. So they went on to conclude that among patients who underwent major non-cardiac surgery, a continuation strategy of RAS inhibitor before surgery was not associated, and in fact it's safe. So clinically, one can say in future that a patient who is in RAS inhibition need not stop the drug prior to surgery. So what the 2024 trials tell us, reduce MI trial tells us that beta blocker may not be mandatory in post-MI phase if ejection fraction is more than 40%. AIIMS trial says that beta blocker may be interrupted in MI where ejection fraction is normal. Seniorita trial tells us that elderly patients with non-ST elevation MI do equally well with invasive or conservative strategy. Fine arts trial tells us that finerenone may be another drug which can be helpful in patients of mid-range or with ejection fraction. Assured death trial tells us that aspirin may be stopped prior to non-cardiac surgery if disimplantation has been 1 year. SCOFF trial tells that fasting is definitely not required prior to procedure, and stop or not trial tells that ACE inhibition can be continued prior to cardiac surgery without any harm. Thanks a lot for patient time and attention.
So the session is open for questions. Anybody in the audience can ask.
Good morning, chairpersons. I hope I am audible.
Yes, I am Professor Vijay Achari, Professor and Head Department of Medicine, Patna Medical College, and thank you, Professor Dwivedi, for your excellent presentation and illuminating us about the most recent trials. One question about the fine arts trial, and which is something, an educative exercise for all of us, is that till now we knew about finerenone that is useful in diabetic and cardiovascular protection, in cardiovascular and renal protection in diabetic patients. But now this shows that it is useful in non-diabetics as well. And the second question is that from the trials, from the Swedish trial and from the AIIMS trial, would you say that after 1 year of beta blocker therapy following ACS, we can discontinue a beta blocker, although the AIIMS trial showed that it is non-inferior. I mean, in non-inferiority was not shown.
Yes. So second question first. Yes, if the patient has been revascularized and the ejection fraction is more than 40%, then beta blocker probably is not required during the hospitalization. There have been various registry data which have been telling this for long, but probably the older studies had ingrained in us that beta blocker is life-saving after MI. But in those era, the revascularization was not there, statins were not there. So their beta blocker will lose their class 1 indication or even class 2A indication for starting in hospital after MI if the ejection fraction is preserved. And in AIIMS trial, yes, what happens is that you advise beta blocker and patient keeps on taking beta blockers for lifelong, and we also don't stop it. Now, what they have said is that practice of continuing the beta blocker, suppose you come across a patient who is already receiving beta blocker, it is already more than 6 months, then you can stop beta blockers if ejection fraction is not. So that will also come in practice. So I think these two trials are the death nail in the coffin of beta blockers after post-MI, provided the patient has been revascularized, ejection fraction is normal. And as far as the fine arts trial, yes, finerenone had been actually with the other MRAs like eplerenone or eldrectone, the renal dysfunction was not safe. This led to renal dysfunction. However, finerenone has been shown to be renal protective as well. Now, the TopCat trial also showed that heart failure hospitalization is reduced, but somehow it was the post hoc analysis and not in the main analysis, probably because the group of patients, there were a lot of black patients there. If you isolated Americans from them, that was certainly beneficial, but it died early. Finerenone has just revived MRAs. Careful MRAs will reduce the hospital admissions. Now, it is simple. The drugs, they are reducing the symptoms, and symptoms are because of volume overload. So if you go to the drugs which have come recently in heart failure management, SGLT2 inhibitor in large trial did not reduce mortality but reduced heart failure. Similarly here as well, a diuretic, SGLT2 has diuretic action as well. Here again a diuretic will reduce symptoms because that is its job. So I think for heart failure hospitalization, finerenone has earned its place in patients who are having a moderate or mid-range, let's say, preserved ejection fraction.
Thank you. So, I mean that expands the role of finerenone in cardiology, apart from diabetics.
One question from me. I am Dr. S.S. Chatterjee from Patna. I want to know what's the status of finerenone in preserved or mid-range heart failure patients who have got an estimated GFR of 30 to 60% and a serum potassium level of 5.
So what they did was they have used two doses, 20 and 40 milligram. 20 milligram they had reserved for the eGFR of less than 25. So there also it was irrespective of the finerenone, irrespective of the eGFR, the finerenone did reduce hospitalization in a lower dose. The dose was lowered.
Thank you.
Thank you so much, sir. Any further questions from the audience? So we'll proceed.
Thank you. Thank you very much.
Thank you, Patna. Thank you, Anupam, because she only called me. I'm from Hyderabad Apollo, and she used to work with us, such an excellent cardiologist, and I love her for her work and for her dedication. And now she's organizing secretary. I gave her full 200 marks for organizing so well this conference, and I'm sorry I could not attend yesterday because of some work. I would like to come next time in a full-fledged manner. Thank you so much. We can call the next speaker. First one, yeah. That is innovation in heart failure. Device therapy. Innovation in heart failure, device therapy, CRT or CSP, by Dr. Nirav Kumar, Head of the Cardiology, Apollo Spectra Hospital, Patna. Dr. Nirav Kumar.
Very good morning to all of you. So my topic is innovation in heart failure therapy, CRT or CSP. This is a new burning topic. Everybody is talking, every cardiologist is talking about it. Where should be the site of depolarization in the heart? So normally when there is a depolarization wave comes from septal to lateral, hardly it is 40 millisecond, and the heart contract simultaneously right or left heart because of rapid conduction through Purkinje fiber. When there is LVVB, there is delayed in lateral wall contraction, particularly in left ventricle, and that is because the slow conduction. So when there is LVVB, the rapid depolarization takes place in right ventricle. That's why there is early right ventricle contraction, but the depolarization of left ventricular wall takes place through cell to cell. That's why it is get delayed and QRS get wide. So the contraction of left and right ventricle is asymmetrical. The RV contract first, and LV contract later. Particularly in LV, lateral wall contract later, and that's why there is asynchrony. The cardiac output get down. Other than that, diastolic filling pattern will get altered. There is delayed contraction in the papillary muscle also. So that everything, the physiology of heart get disturbed because of LVB, and all the cardiomyopathy, almost 30% severe LV dysfunction or moderate to reduce LV dysfunction, there is LVB pattern. So there is LVB is responsible for cardiomyopathy, or cardiomyopathy is responsible, and degenerative heart disease is not still clearly known. So the other thing regarding the RV pacing, when we pace RV, that is contrary to normal depolarization. Normal depolarization takes place from base to apex. Here we depolarize the heart from apex to base. So RV depolarization takes place early, so RV contraction early, then there is LV depolarization, particularly lateral wall of the heart is depolarized late. So there is a dyssynchrony between RV and LV, and because of this dyssynchrony, the cardiac output is not, because cardiac output depend upon the synchronous contraction of RV as well as LV, and the septum is an important part of it. So the contraction did not take place properly, cardiac output will get down, and in long term, if particularly the pacing load is more than 20%, and if it is more than 40%, the incidence of the pacemaker induced cardiomyopathy is around 23%. So if RV pacing takes place predominantly more than 20%, it is harmful for the heart, and in long term the LV dysfunction will take place. So this is non-physiological, and that's why there is talk is going on what should be the site of depolarization in the heart. So asynchronous electrical activation lead to perfusion defect, the mitral regurgitation, decreased DP and DT, decrease in stroke volume, pumping function will decrease, and EF will decrease. So that is the problem of depolarization at the wrong place. So in David trial, in Dennis study, in all the study, the RV depolarization leads to deterioration in the cardiac output as well as lead to pacemaker-induced cardiomyopathy. That is the term for it. If B pacing is more than 40%, then this takes place. So how we can avoid it? We can do the conduction system pacing anywhere from hinge to apex. We can pace the heart, or we can do the biventricular pacing. One lead in RV apex and other lead in the coronary sinus. So that restore the synchrony of the heart, and that improve the cardiac function. So this is a new definition of cardiac physiological pacing. It is defined any form of cardiological cardiac pacing intended to restore or preserve the ventricular synchrony. CPP can achieve by engaging the integer conduction system via whether hinge bundle pacing, left bundle pacing, or CRT. So these are the cardiac physiological pacing. So during the CRT, we pace the heart from the lateral side of the heart as well as right apex. So simultaneous contraction is possible, and that depend upon the interval. We can set that interval. So that will improve the heart. That was the initial theory for the CRT therapy. So this was the first trial, the Maastricht trial, that proved that this theory is right, and there was improvement in NYHA class and everything. The next trial was the companion trial. That was the last trial, and there was benefit with this therapy. So in this trial, it was seen that RV pacing was deleterious for the heart, and this is the miracle study again show the same thing. So there are large data in support of CRT therapy, meaning by one pacemaker in lateral part of the heart, the other is an RV apex, and that improve the heart function, that improve the motility, decreases the chances of arrhythmia, and reverse the MR also. So there is benefit, there is no doubt about that, and these are the last trial like companion trial, the MEDIT CRT trial, in which it was seen that even ICD addition in the CRT that also improve the motility. So there is large evidence, large study since 2001. So there is benefit with the CRT therapy. Is there any other possibility? So we can pace the heart from bundle of His, we can pace the left bundle branch, we can pace in fascicular level also. So first to understand the bundle pacing, we should understand that there is a triangle of Koch, and that the AV node is at the apex of the triangle of Koch. Then it penetrates into the His bundle. It's come from left to right side, and then it goes. Here you can see. Here you can see the right bundle. The right bundle is coming early. Then there is left bundle, and then there is division in the heart. So this is the 3D model. You can see the heart from the right side. So this is the posterior fascicle. This is the septal fascicle. This is the anterior fascicle, and this one is the right ventricular fascicle. So majority of time this is the thickest one, so that this is the site where depolarization likely to takes place more, and this is the bundle of His. This is a smaller area, and the initial euphoria was to pace this, because this is more physiological. If you pace the heart over there, the fascicle will depolarize naturally. So this is from the right side. Here we can see from the superior. So this is the right bundle. This is the posterior, and this is the anterior fascicle. And here we are seeing it from the right side of the heart. This is septum, and these are the fascicle. It look like this is AV node, the bundle of it. So these are the site, or these are the target where we will put our lead to depolarize the heart. So, and the other thing is the septum, almost in the ventricular side is located. This is the inner right side portion, this is left side portion. That's why we have to go deep in the septum to target this area. So this is the usual radiological feature. So where we can the pace, we can pace here the proximal His bundle or distal His bundle. So important thing is this is the most physiological form, because it will depolarize all the fascicle, but this area is covered by the membrane, so high threshold is required, high output is required, and the battery get deflated much early. The other thing is the question of stability, because this is the U-turn, and the stable, this is not the stable position, and later on the instability, and there is interference from the arterial depolarization also. It get depolarized because of the get inhibited because of the arterial impulse. So this is because of this, the His bundle is not very favorite nowadays. The other thing is we can pace it, and we can place the upper lead over here. This area is left bundle area. So LVV pacing or fascicular pacing or septal area pacing is left bundle area pacing. The other thing is it can pace the right bundle. That is not physiological, that is not true. But if you are putting your lead, it can hit the right bundle also. So these are the area where we can do the pacing. So the options are, if we can do the CRT pacing, we can do the His bundle pacing directly, and whole heart will depolarize. The question is of stability. We can do the hot CRT plus His bundle pacing. This is also new idea, and the QRS narrowing is much better with this. The other thing is regarding stability and the threshold, because His bundle is not a very good area for depolarize. The other thing is we can depolarize the left bundle. We can do the lot CRT also, CRT plus left bundle pacing. So these are the new innovative ideas going on throughout the world. So the strong point in favor of His bundle pacing is it is physiological. The drawback is narrow target area, resulting in lengthy procedure. Fluoroscopic timing made HBB more anatomically difficult. High threshold is required, low sensed R wave amplitude, and there is interference that I cell. The left bundle pacing, the strong point are, this is the wide area. We can push lead anywhere. The low and stable threshold is there, so battery depletion is much low. High success rate is there. So other thing is, if we are pacing anywhere, it will depolarize the heart simultaneously. So there will be a QRS narrowing also. So this is the new debate, which area should be paced. The other thing is the specific pacing and non-specific, specific pacing and non-specific pacing. So non-specific pacing, the depolarization immediately get started, and you can see the delta type of wave. The specific pacing, there is isoelectric point. So if your lead is at right place, you will get the isoelectric point that is absent because of the myocardium is also involved. So this is so debate is going on whether we should do specifically the conduction system or we can do the non-specific pacing also. So these are the evidence, these are the trials. There are many trials, and the result is there. So in all the trial, you can see all the trial is, majority of trial is observational study. There is no randomized trial. These are the trial, and there is evidence in favor of LVB or CSP pacing. So these are the trial. There are many trials, and this is the trend. That there is increased trend regarding the LVB pacing among the cardiologists. So these are the trial, and this is the ECG. This is important to understand. The ECG, when you are the LVB pacing is when you are pacing the LVB. The second is positive, the AVL, AVR, there is discordant, and the narrow QRS is norm in all the condition. The other thing is, if you are pacing the posterior fascicle, usually the first and AVL will be positive. If you are facing anterior fascicle, the inferior, the second, third, and AVL will be positive. The other thing is LV80, the left ventricular activation time, it should be less than 80 milliseconds. So these are the ECG, and with the depolarization and LV potential, if it is more, then it is LVB pacing. If it is less, then it is septal pacing or fascicular pacing. And here you can see the best, the less QRS you can see in a lot CRT condition. These are the criteria, and this is the largest observational study, the MELOS study. 2,500 patients they did, and these were the complication. Their observation was that heart failure success was less with, the implantation success was less in heart failure patient, better with the bradycardia because of the fibrosis and thickness of the septum, and these were the complications. The important complication is acute coronary syndrome. This was observed in this study. If you are putting a lead in the septal area, it can hit the septal artery. It can cause spasm also, coronary spasm also. So that is the problem with this thing. And then there is trapped or damaged helix. The perforation is also, if you are pushing too much, it can go into the LV also. So important point in this trial, we should understand that this was the dedicated trial for coronary septal pacing, and in this trial only 9% time the LVB pacing was done. Only 9% time. Ideally we are talking about the hitting the LVB, so only 9% time it was possible to hit the LVB. In majority of time the fascicle area and almost 21% time the septal area was paced. So even the dedicated trial, the hitting of LVB left bundle was not there. And conclusion was that so these are the and if we can shift, if CRT pacing is failed, we can shift to the LVB pacing, and these are the point in favor of that, and these are the guideline. So still the guideline is not in favor, except in some condition, like LO1 is a 2A indication. So in some condition, if LVSP is less than 50% and the ventricular pacing is expected more than 40%, in that condition this is 2A. HBB and LVB pacing is 2A. Similarly, on all the conditions, the BRV pacing, the CRT pacing, biventricular pacing is indicated. So in majority, if you want to revise reverse the pacemaker-induced cardiomyopathy, in that condition, this is class 1 indication, the biventricular pacing, and this is 2A. This is the recent appreciation for the bundle branch pacing. So evidence is lacking because all the study or a smaller study from 40 to 60, 80, 100 like that. So larger randomized trial is required to establish this phenomena. The other thing is the appropriate side. What is the appropriate side? There is no doubt that his bundle side is no more the hot spot. So we can do the left bundle branch pacing, we can do the fascicular pacing or septal pacing. So which side is appropriate? Normally when we fail, we remove the lead, we put it on another side, so we make a 2 or 3 hole. So if we are making a hole inside the septum, that will heal by the scar. So what will happen in future, nobody knows. In perfection, what should be the site? If it is septal site, we can do it comfortably, but if it is a specific site, then there is problem. So complications are there, as I discussed, and dedicated device is required. Thank you.
Hello. Yeah, thank you very, very much, Dr. Neera. It was excellent and very detailed, and for the postgraduates, I think this was very good, and for the fellows also, and those who are practicing electrophysiology, but the hall is not that much. But I must ask you one question, that in a dilated cardiomyopathy, we do see simple left bundle branch block with no conduction defect or any other problem, and patient is almost normal. The QRS widening is more than 140 millisecond in such asymptomatic patients, because just to narrow the QRS complex and increase the viability and whatever longevity, and clinically they are normal. So what shall we do in such cases?
If some patient has LV dysfunction less than 35% and NYHA class 1, there is no evidence in favor of even CRT. So if patient is symptomatic NYHA class 2 and onward, in that condition the biventricular pacing is an option. But if some patient has LBBB and he required pacing for some bradycardia indication, in that condition definitely we should do the biventricular pacing or left bundle branch pacing.
One more question. In this type of pacing, you rotate the lead many times, and this may lead to damage to the septal leaflet of tricuspid leaflet, because this is going in a U-shaped term. So what is the incidence of tricuspid regurgitation, significant tricuspid regurgitation after this type of pacing?
This is important. If you are doing the RB pacing, the TR is a rule. Tricuspid regurgitation is a rule. But if you are doing septal pacing, there is gap between the anterior leaflet and septal leaflet. So through the commissure it is going. Majority of cases there is no TR. So this is one of the good point for LBB pacing. If you are doing the septal pacing, the area between the commissure between the septum and anterior wall, that's why there is no TR and a minimal TR.
Dr. Neerab, one question from me. Provided there is no constraint of affordability, and we are the operatively confident with both the conventional CRT as well as lot CRT. As you have just now enumerated that the CRT is class 1 indication and lot or recent CSP is 2A indication. So which should be preferred if there is no question of affordability or operator issue?
Yeah, this is an important question. In CRT, 30% patients are non-responder. Even you are putting the lead, the non-responder rate is 30%. The other thing is almost 8 to 10% per time you will fail because of coronary anatomy. You are not putting the lead because of high threshold. In that condition, the LBB pacing is an option. There is no doubt about that. And lot CRT is, the evidence in favor of lot CRT, very small study, 60%, 40%, 40 patient study. So there are in favor of lot CRT. If you are doing both, the QRS tethering will be least and the benefit will be more. But these studies are very small. We cannot make our judgment on this based on this.
Now, I have one question for
I
you.
think this is the last question.
Dr.
The organizers have stipulated that there will be only 2 questions per speaker.
Okay.
So this should be the last one, please.
What is your experience at AIIMS Patna regarding CRT, conventional and the newer techniques?
Sir, I am from AIIMS. We are doing it regularly, and the CBC Chandravanu Chandan is perfectionist. He is putting lead every time unless until he get the LBB branch. That's why there is fight between me and Chandravanu. What is the appropriate side? How much time we will try? So we are doing it regularly in our institute, and there is benefit. There is no doubt about that. There is narrow QRS. There is improvement in ejection fraction. So we are doing it, and this is new fascinating area. That's why we are doing it with more than our head is there, Dr. Ravi Vishnu. He did the first a lot of Patna, so that the result was very good.
So now we move on to next session, and the next section will be topic is worsening of heart failure therapy beyond four filler. So speaker will be Dr. Ravi Vishnu Prasad, Head of Department of Cardiology, AIIMS, Patna. Please.
Good morning, everyone. First of all, I would thank the organizing committee of Cardicon 2024 for inviting me for this talk. I will discuss the worsening of heart failure, the therapy beyond four pillars. Unlike many cardiovascular diseases, the journey of patients with the heart failure remain unique. And as you all know, the heart failure is a progressive disease which is characterized by the periods of clinical stability and disrupted by the episodes of worsening signs and symptoms. And there are many episodes of decompensation. Once in a life, patient is diagnosed of the heart failure. So now coming to the diagnosis, once the diagnosis is made, the heart failure carries the significant intrinsic clinical risk factor, and this intrinsic clinical risk factor is decreased by starting the guideline-mediated directed medical therapies. And once the patient is the residual risk has been reduced, then patient is always at the residual risk, although it may encounter with the worsening heart failure in his lifetime, and later on leads to the advanced heart failure. This is the clinical course of the heart failure, all heart failure patients. So this repeated worsening of events leads to the reduced ejection fraction, reduced cardiac function, and ultimately to the death. And this worsening heart failures portends to be the poor prognosis in the form of the recurrent hospitalization in the, especially in the older adults, and carries the in-hospital mortality, and even 3 years and 5 years mortality is around 65%. Now coming to the definition of the worsening heart failure. Worsening heart failure, if you see all the guidelines, there is no dedicated practice guidelines over this worsening heart failure. It was first coined in the ESC guideline in 2021, and it defined as the worsening symptoms and signs of heart failure requiring the intensification of treatment, generally the IV diuretics, and it may occur at any level, either in the OPD, IPD, but it excludes the new onset heart failure, any episodes with the concomitant comorbid conditions, or when the heart failure present with the precipitating causes. And also the 2022, the ACC guideline, there is a special distinct phase of the stage C. Now, till now, we have the four main pillars of the heart failure, and these four pillars have decreased the recurrent heart failure events, reverse the ventricular remodeling, and extend the meaningful survival. And these four pillars are the fantastic four pillars are the ARNI, the beta blockers, the MRA, and the SGLT2 inhibitors. And whenever you start the quadruple medical therapy, there is a residual risk of heart failure. Always there is residual risk is there in the patient with the reduced ejection fraction. So before moving forward, the first step should be we have to restore the pillars. First, and if there is any residual congestion, we have to manage the congestion by giving the diuretics. We should increase the dose of diuretics or give the IV therapy, and all the pillars should be stabilized. We should initiate the pillars of the GDMT and try to fill the gaps. And if you see the strong HF trial, which was the major trial, we showed that if you start all the drugs in the small dose and with the rapid sequencing, it shows the better results as compared to the conventional sequencing. And the new timing is that when the patient is before going for the discharge, this is a peri-discharge phase, and this is a critical timing. You start all the drugs even in the low doses before discharging the patients. Now coming to my topic. This topic is beyond the Fantastic Four. What are the drugs, interventions, and device treatment for the heart failure patient? And the ACC guideline has also recommended that you can consider that additional therapies once the GDMT is optimized. The first drug is the ivabradine. It is an old molecule, and if you see, when the patient is on the beta blocker, even after they are maximum tolerated doses of beta blocker, and still the resting heart rate is less than 70, and NYHA class 2 and 3, we can add the ivabradine in these patients. And this was proved in the SHIFT trial, which was published in 2009, and they have significant reduction in the form of CV death and hospitalization if the patients were given the ivabradine as compared to the control group. And this was the class 2 indication, and level of indication is P. Now coming out to the new molecule is the vericiguat. Vericiguat is a new approach, a new molecule, and its mechanism of action is different as compared to the other 4 pillars. Basically, if you see, it basically it acts on increases the activity of soluble guanylate activity, which increases the cyclic GMP, and this cyclic GMP leads to the increased production of the nitrous oxide, and this nitrous oxide is decreased in our heart failure patients, and this has a positive results over the heart and the blood vessels. So due to the availability of this NO receptor, this soluble guanylate cyclic GMP pathway, we have to, there is a new modality to improve the outcome, and this was established in the Victoria heart failure trial. And in the Victoria heart trial, they were taken the symptomatic patients with chronic heart failure patient after the worsening heart failure event, and they were all stabilized patients with the BP more than 100 millimeter of mercury, and they were off the IV treatments for more than 24 hours. And around 5,000 patients were taken, and they were compared with the placebo versus the drug, and 2.5 milligram OD was the initial dose, and it was titrated to 5 milligram to maximum 10 milligram within 2 to 4 weeks. And the baseline characteristic was they were taken the high-risk patients, all the heart failure patients within 3 months or 3 to 6 months, or taking the IV diuretic, and even the class 3 and class 4 patients were also there. So vericiguat improved both the primary and secondary outcome, and even after the baseline NT-proBNP was high, it has shown the better results. And also the side effect in the form of symptomatic hypertension or syncope was very less, and there were no clinical significant difference in the EGFR, creatinine or sodium potassium level over the time. And as I already told, the patients were enrolled within the 6 months of the worsening heart failure events. So it was recommended by both the authorities, the AHA and the ESC, the class 2B indication in the patient with heart failure with reduced ejection fraction with worsening heart failure is already on the GDMT. Since it was based on the Victoria trial, because it was a very short trial, around 5,000 patients were taken, and the 1-year follow-up was there. So it is a 2B indication. Another trial is the Victor trial, which will be published in next year, which will take the chronic heart failure patient who have not experienced any recent hospitalization. The vericiguat is also a very good drug. You cannot put the ARNI in the patient, because in the elderly patients, the multi-morbid conditions for patients who are frail, because it requires the once administration, safe, well tolerated, and no need for routine monitoring. Another drug is the intravenous iron therapy. As you all know, the intravenous iron deficiency is a strong and independent predictor of outcome, and all the recent trials in the 5 years from the AFFIRM trial, Ironman and Heart FID and the meta-analysis, they have given the class 1A indication for the intravenous therapy in the patient with the heart failure with ejection fraction. Digoxin is a very good molecule, but it has lacking the contributory data, but it improves the symptoms and reduces the risk of hospitalization, and it has a definitely role in the rate control for the AF patient who have a low BP. These are the various interventional drugs which are going on. I will discuss only the omecamtiv. Omecamtiv is a very unique molecule. It acts on the myosin. It binds over the myosin and the actin, and which leads to the increase the systolic time without affecting the diastolic time. So there is a less oxygen consumption. And the collective HF is a small trial which has shown some benefit in reducing the heart failure events. Now coming to the device interventions in the heart failure, once the patient is on the GDMT for more than 3 months with the EF less than 35%, you can put on the CRT or the LVP pacing as told by the previous speaker. And once the heart failure patient, when they require the revascularization, when the coronary activity is suitable, you can put on the PCI. You can do the PCI or you can do the surgical revascularization as is quoted in the STIS 10-year data or Revive BCIS trial. And these are the various innovative ideas, the ventricular restorative devices to improve the ventricular synchronicity. Cardiac robotic sleeves are in the pipeline, and this is the catheter metal watch H2H repair is in the pipeline. It is already the FDA approved, and also the pulmonary artery hemodynamic monitoring devices to tell the heart failure in the advance, and the interarterial shunt devices just to decongest the left atrial pressure and the pulmonary congestion. So this is the flow chart which shows that the transcatheter H2H valve repair is in the pipeline. It is indicated in the moderate to severe or grade 3 and grade 4 MR with the EF between 20 to 50%, and the left ventricular dimension should be less than 70 mm, and it excludes the pulmonary hypertension. And this was proved in the COPT 5-year data, and recently presented in the ESC, the RESAVE HF2 trial, that the TER is the better for reducing the CV death and the heart failure related hospitalization. And this is the invasive devices for the hemodynamic various devices. The only approved by the FDA is the CardioMEMS Abbott system devices, the PAP sensor, and this is class 2B indication, and this is guided by the Champion trial, Guide HF trial, MEMS HF trial, and they all decreased the hospitalization when they were implanted. This is the HeartMate 3 magnetic LV assist devices which have proven the third edition is the better than the second edition, and this was seen in the momentum 3 to 5 years outcome. Now the most important is that when we discharge the patient, the digital communication between the patient, between the doctor, between the hospital and the hospital staff is very important. So we always digital in the communication in the digital era. Now this is the flow chart, and now this is my last slide, second last slide. When the patient comes to with heart failure, always check for the congestion and give the diuretics with the 4 pillars: manage the comorbid conditions, treat the iron deficiency, treat the MR, treat the AF, and if still the heart rate is more than 70 and the patient is sinus rhythm, add the ivabradine. CRT and the devices should be added. And the new molecule Verisugat is also, if the patient cannot put on the ARNI, then you can add this molecule. So to conclude, the worsening heart failure event is considered as a time to optimize the heart failure therapies and add the novel drugs. And GDMT and devices should be offered to all the patients, and always start the 4 pillars as early, even in the low dose, and simultaneous rapid sequence should be followed within 1 to 2 weeks. Thank you.
Dr. Ravi Vishnu. So any questions from the audience?
There is no question. I just have a comment, Dr. Ravi Vishnu. All the 4 pillars of the drugs, they actually address the different manifestations of heart failure with reduced ejection fraction, like the adrenergic or neurohormonal or RAS system. All 4 pillars are addressing only to these 3 things. But the basic thing is the contractibility. None of these drugs are actually acting on that aspect. Only omnicardium is coming up, but this the galactic heart failure trial has also shown only a very minimal improvement in the heart failure patient, and that is also a smaller trial. We are forgetting digoxin. Digoxin, I mean, you have mentioned about that, But even the 21 AHA guideline or ESC guideline, they are mentioning that when the patients are not improving, digoxin should always be tried, and it is unfortunate that our younger colleagues are now not using digoxin. Probably they have just forgotten that there is a drug called digoxin which can be used in heart failure as well, especially in those patients who have got a cardiomegaly, a CTR ratio of more. Ejection fraction less than 25%, a cardiomegaly, and a class 3, a class 4 status. And when the blood pressure is low, say 90 millimeter of mercury, where you cannot start the 4 pillars straight away. So this is just to remind our younger colleagues that you don't forget digoxin, especially. Two trials on digoxin are being done. It has not been forgotten. It has been forgotten in the country where it is required the most. But two trials, international trials, are going on digoxin, especially in Europe. One is the decision trial. And you have the results for that. So only thing is that digoxin should not be forgotten by our younger colleagues when the patient is not improving or when the patient cannot tolerate on any of those 4 pillars. And I was very happy to see the slide when you have shown the 4 pillars, but the roof is diuretic, and nobody mentions about the diuretic as an essential part of it. So the roof is always diuretic. Without diuretic, we cannot treat a patient of heart failure. Thank you very much.
Sir, diuretic has definitely the role in the decreasing the rehospitalization. It is forgotten by the pharmaceutical company, but it is in US, it is the insurance companies are promoting this digoxin because the recurrent rehospitalization in the hospital, their burden is increasing.
No, diuretics are not decreasing.
For digoxin, sir.
Yeah, for digoxin, yeah.
Sir, one thing I would like to ask that you have told about that LVAD. LVAD, is it a bridge to transplantation or it is a definite role of, because I have heard in some conferences that LVAD is going to protect the heart for the 10 to 12 years. So is it that much or it is just a bridge to transplantation we are giving?
This new LV, this
HeartMate 3.
HeartMate 3, it is just a treatment, not bridge to transplant.
It is a treatment. So till now, from your ideas, how much prolong we can do that?
No such
data is not available.
Because momentum trial was started in the 5 years back, and they are still continuing the outcome because the patient's volume is very less in these trials. So they are not giving any comments from this, but this device is definitely the better than the previous, and this is the treatment. Not
working as a treatment. Okay.
Just a very brief comment.
My question from one of my questions from you. You have mentioned in your management that IV iron therapy can be used for the worsening of the heart failure. So I just want to know that what is the protocol of using this? Should we use this IV elemental iron in every patient, or those patients in which the iron ferritin load is low or hemoglobin is low?
No, there is a criteria, sir. Once the ferritin level is less than 100 milligram per deciliter, or it is between 100 to 299 with transferrin saturation less than 20%. Then you can start.
I think we should not use this elemental iron in every patient.
Not in every patient. Once the ferritin level is low, less than 100, then you can start this elemental iron.
Okay. Thank you.
I have just one comment. You did mention that after guideline-directed medical therapy, usually we wait for 3 months before going further the additional therapies that we do. in the case after ACS, I think we usually wait 40 days. I think that is probably giving time for remodeling.
40 days for device therapy.
Yeah, we can stop this. We are already late. Please, in the next. Thank you, Doctor.
Thank you.
As Dr. Meherwal is not here, the final topic of this session will be Management of Cardiogenic Shock, an update by Dr. Anup Singh, Assistant Director, IGIC, Patna. Please.
Good morning and thank you to organizer for giving me opportunity to deliver the lecture. My topic is management of cardiogenic shock and update. Cardiogenic shock is a life-threatening syndrome which is defined by peripheral hypoperfusion and organ dysfunction due to primary cardiac dysfunction. The most important cause is acute myocardial infarction. Other less common causes are fulminant myocarditis, RV failure, Takashima syndrome, postpartum cardiomyopathy, and severe valvular heart disease. In spite of optimal medical therapy, even in current scenario, the mortality is very high, approximately 50% after 1 month. So, cardiogenic shock is defined as clinical and biological evidence of tissue hypoperfusion secondary to cardiac dysfunction. And although widely accepted definition is systolic blood pressure less than 90 mmHg, despite adequate filling pressure and sign of organ hypoperfusion. The most of the definition is centered around the cardiogenic shock associated with acute anterior valve, acute MI. So these are the three important classification. SKY classification, which is widely accepted all over the world. Second one is hemodynamic classification, and third one is phenotypic classification. Among the SKY classification, that is Society of Cardiovascular Angiography Intervention classification, it divides into 5 stages: A, B, C, D, E. A at risk, B beginning, C is the classic, that is definition fits into definition of classic cardiogenic shock, D deteriorating, and E extremis. A at risk, it means patient at this stage, patient having no hypotension, no tachycardia, no any feature of hypoperfusion. In stage B, there is hypotension and tachycardia, but still having no sign of hypoperfusion. See, at the classic stage, these are all hypotension, tachycardia, and hypoperfusion persist. So at this stage, intervention required in the form of volume resuscitation, vasopressor, inotropes, or maybe mechanical circulatory support. Sometimes patient improves and goes down to category B and A, but sometimes did not improve and patient deteriorate gradually and jump down to stage D. And finally, in stage E, if not controlled, patient go into cardiac arrest. Second one is hemodynamic classification. It is based on the volume status and peripheral circulation. Volume status either wet or dry. Wet or dry depends on the condition of the lung, either lung congested or not. That first, there are total 4 combinations. First combination of cold and wet is categorized as a classical cardiogenic shock. Here wet means lung is congested, PCWP, pulmonary capillary wedge pressure increased. Cold means peripheral vasoconstriction due to the increased systemic vascular resistance index and decreased cardiac index. Second one is dry and cold. Here the lung is not congested, so pulmonary capillary wedge pressure is normal, but there is peripheral vasoconstriction and peripherals are cold, so there is decreased cardiac index with increased systemic vascular resistance index. Third is warm and wet combination. It is mainly mixed shock associated with sepsis also. Here periphery is warm. It means systemic vascular resistance decrease or approx normal, and cardiac index is also decreased, but PCWP is increased because lung is wet. And final is dry and warm combination. It is mainly present in non-cardiogenic shock like thyrotoxicosis and here periphery is warm. It means systemic vascular resistance decreased, cardiac index increased, and PCWP decreased. So sky shock is most widely accepted, but it applies only in acute presentation. It is not applicable for chronic cases, and sometimes patient may respond to therapy and stabilize, and sometimes deteriorate. Here we see that patient may deteriorate from stage A to direct stage E. Any patient can go from stage 1, A, B, C, D to directly E if any catastrophic event occurs. But patient cannot go directly from stage A and B to D, because it has to spend some time at stage C for intervention. So A, B, C, D directly go into the stage E, but A and B cannot go directly into stage D. It has to spend some time in stage C. These are the three axial model predictors of mortality and evaluation and prognosis of cardiogenic shock, phenotypic and etiology, shock severity and risk modifier. Shock severity, staging of sky, metabolic derangement. Phenotypic etiology and etiology are acute versus acute and chronic, cardiac versus cardiopulmonary failure, clinical etiology, right versus left ventricle failure. And risk modifier like non-modifiable risk factor is cardiac arrest with coma and systemic inflammatory response, etc. First, we have to assess the patient and diagnosis, and the fit the by clinically examination. We have to fit the within the definition of the classical cardiogenic shock, that is systolic blood pressure less than 90 mmHg, feature of in-organ hypoperfusion in the form of cold extremities, mental confusion, oliguria less than 30 ml per hour, acidosis in the form of increased lactate level more than 2 millimole per liter, and decreased cardiac index less than 2.2 liter per minute per meter square. So after fitting into classic definition of cardiogenic shock, we have then assess the either LV predominant or RV predominant or biventricular predominant cardiogenic shock, or then either lung is congested or not. After that, we have to identify the etiology. Most of the common etiology of cardiogenic shock is acute myocardial infarction, and others are cardiac arrest, arrhythmia, conduction disorder, sepsis, etc. After the identification of etiology, we have to focus on some important investigation like ECG, echocardiography, some lab tests like TROP-I, ProBNP, sepsis profile like procalcitonin, thyroid profile like T4-TSH, and sometimes ultrasonography and CT scan is also required for pulmonary embolism. Even after that, if there is any difficulty in diagnosis and management during the cardiogenic shock, we have to also go for invasive hemodynamic monitoring like arterial catheter and and also pulmonary artery catheterization. So transthoracic echocardiography is the most useful basic monitoring modality in cardiogenic shock patient. But the transesophageal echography should not be the first line for monitoring of unstable patient. Also, gas analysis is also important. Pulmonary artery catheter is an invasive method and should be carried out by expert and in cardiogenic shock centers. It measures pulmonary and cardiac pressure as well as central oxygen saturation. It measures the cardiac output, pulmonary capillary wedge pressure, right atrial pressure, mean pulmonary artery pressure, and others parameter also. These are the biomarker. I have already discussed about the lactate level, oxygen saturation, blood gas analysis, serum creatinine, CBC. In cardiogenic shock management, it is divided into three parts: etiology, optimizing hemodynamics, and management of organ dysfunction, that is complication. First, etiology. After the diagnosis of etiology, like coronary artery revascularization in case of acute myocardial infarction in the form of PCI, primary PCI. Second, valvular disease management by the valve replacement arrhythmia and conduction disorder in the form of medical therapy or RFA, radiofrequency ablation, or pacing support. Second, optimizing hemodynamic. It is divided into two parts: improve tissue perfusion and improve pump function. Improving tissue perfusion, if there is increased venous pressure or pulmonary congestion, use diuretics, and sometimes renal replacement therapy is needed. If blood pressure is low, use vasopressor in the form of noradrenaline. And in case of sepsis-induced cardiogenic shock, control the sepsis by proper antibiotic. Second, improve pump function. If decrease RV or LV contractility, use inotropes in the form of dobutamine and milrinone also. Manage heart rate by reducing the supraventricular and ventricular arrhythmia with the drugs. Improve heart rate or conduction disorder in the form of isoprenylene or pacing. If RV filling is inadequate, volume expansion, decrease extrathoracic pressure because RV thickness is very less, approximately 6 mm. If increased RV after load, then improvement of LV function decreases pulmonary capillary pressure and also decrease intrathoracic pressure also as well. If LV filling is inadequate, optimize intravascular volume and decrease transfer pressure, so blood can flow easily from pulmonary artery to the LV. If increase after load, then peripheral vasodilatation should be used, and also reduce obstruction if patient having stenosis. In spite of this, if patient present in cardiogenic shock for long periods, other organ dysfunction may occur. So we have to treat by ventilation as well as mechanical support, renal replacement therapy, etc. So primary PCI is recommended as a first line therapy. Culprit lesions always treated during the during the acute myocardial infarction, and rest of the coronary disease should be treated after stabilization of the patient. And the duration after which it should be treated, it is matter of debate. And some non-revascularizable by PCI, the best treatment is bypass surgery. So also incidence of arrhythmia is also high in 20% in F and approximately 10 to 20% of BF, and no specific recommendation exists. But rhythm control, try to restore the sinus rhythm. If not rhythm controlled, at least try to control heart rate, so it decrease the myocardial oxygen demand, and amidone is one of the best drug. Electric storm should also be treated by deep sedation, intubation and RFA. And the definition is...
Anup, we are already late, so please try to finish it.
Okay, sir. And valvular disease management, cardiac surgery by valvular replacement. These are the inotropes. Norepinephrine is the vasopressor of choice, and dobutamine is the inotropic choice. Other drugs are milrinone, levosimendan. Mechanical ventilation, positive pressure ventilation. It should not, non-invasive ventilation should not be used in cardiogenic shock with unconscious patient. And renal replacement therapy, because 50% of the patient having acute kidney injury and up to 20% of the patient go into. These are the mechanical circulatory support as a bridge to recovery or bridge to transplantation or bridge to bridge or decision therapy. These are the IABP, Impella, tandem heart, VA ECMO, ECMELA, combination of ECMO and Impella, and the duration is more or less approximately 14 days for all except IABP. We can put up to 30 days. And these are the therapeutic strategies in cardiogenic shock, like volume fluid resuscitation, hemodialysis or diuretics, NORAD, vasopressin, and also newer drugs like levosimendan or mecarbil. These are the future aspect. This is the last slide. First left one is show, that is a photo of a stethoscope and hemodynamic graph, and this is monitor, accessories of monitor and echocardiography. First assess and diagnose the patient of cardiogenic shock, then put the patient into the staging of the sky shock, and finally treatment according to the guideline. And newer artificial intelligence as well as omics having emerging role in the management of cardiogenic shock. So summary, the management of cardiogenic has significantly advanced in recent decade, but still mortality is very high. So rapid recognition with multimodal evaluation by various equipment should have better outcome and better stratification. Still in acute MI, primary PCI of the culprit region is the choice. And finally, mechanical assist device may have an important role in cardiogenic shock patient, but still data does not show, and implantation timing of such techniques remains to be defined according to expertise of heart team. Thank you.
Yeah, 2 questions are allowed from the ordinary side. And if there are no questions, thank you, Dr. Anup, for a very good talk. Of course, it needed a lot of time, I understand, but still it has given a very good impression. Thank you. Thank you all for this time.
Thank you, sir. Thank you, Honorable Chairpersons. Could I request all the chairperson and the panelists to kindly present the memento as a token of appreciation to Dr. Anup? May I request Dr. Professor Ravi Vishnu Prasad to kindly come on stage, also requesting presence of Dr. Neerav Kumar.
Moving to the next session.
Thank you so much, esteemed dignitaries. May we move on to the next session, that is session 2 on impactful trials and recent practice guidelines of the year, what is hot and what's not. May I request the presence of Dr. Gyan Prakash, Senior Consultant Cardiologist from AIIMS Patna, to kindly come on stage. Dr. B.B. Bharti, Chairman Scientific Committee, who's not here, I guess. Dr. H.N. Ray, Senior Consultant Interventional Cardiologist from RIMS Ranchi. Dr. P.C. Sinha, Senior Consultant Cardiologist from Patna. May I request the following panelists to kindly join us on stage. Dr. P.K. Ojha, Senior Consultant Cardiologist from Patna. Dr. Chandrabhan Chandan, Interventional Cardiologist from Department of Cardiology, AIIMS from Patna. Dr. Piyush Kumar, Interventional Cardiologist from Begusarai.
May I request Professor N. Rai sir from Gaya, please join us as a chair, and Professor Dr. A.K. Gupta sir from Darbhanga, please join us as a chair.
The timing for this session has been changed to 15 minutes for the speakers with no questions or interactions. Also, there is a slight change in the session in the order and the seriatim. The first is Dr. Mrinal K. Das. The second presentation will be by Dr. UN Singh. The third will be by Dr. Vipin Kumar. And the fourth presentation will be by Dr. Professor D.S. Chadda, which was initially scheduled in the session third. We'll be shifting the presentation of Dr. Chadda to this session. And last, we'll have Dr. Ashish Kumar Jha. Over to you, sir.
Should I start?
Good morning, sir. And Dr. Mrinal Kanti Das is a well-known figure and a very senior intervention cardiologist, and he is the ex-president CSI India, and he has a very good work in the lipid management in Indian patient. He will speak on the Indian guideline on lipid management. How are they different from the Western patient? This is a very important topic.
Thank you, chairpersons and organizers, for giving me the opportunity to speak on this very, very important topic, that is the Indian guidelines on lipid management. How are they different from Western guidelines? I'll focus more on the former rather than the latter. However, I'll give some of the slides to highlight the differences or similarities. The thing is that when I was the president of Cardiological Society of India in 2020, that time we decided that we should have a guideline on lipid management comprehensively, considering the heterogeneous background of our country, and that was long overdue, and it took 4 years to have this kind of guideline, which was presented in the last annual conference, and I'll just and also published in the Indian Heart Journal, so I'll give some of the glimpses of those. You are all aware that India is labeled as the cardiovascular disease capital of the world, and CAD forms the #1 killer amongst the all NCDs. One of the most important preventable risk factors is dyslipidemia. And very peculiarly, the dyslipidemia in our country is a little bit different from the other countries or Western counterpart, where LDL cholesterol is rather on the lower side in most of the patients, and HDL cholesterol is also low, and triglyceride is high, and there is one more factor, that is the LPA, which might be very much high, implicating the cardiovascular illness. And this is the heterogeneity amongst the different parts of the country related to the hypercholesterolemia, high LDL or low LDL level. You can see that the high LDL level is not there in many parts of the country, whereas the low LDL level is covering most of the parts of the country, and hypertriglyceridemia is another problem. Algorithms for lipid-lowering therapy for secondary prevention have been well documented in contemporary guidelines. Some of the consensus documents from India circulating amongst many of us have been unrealistic and not founded on fundamental data or trials, are prerequisite for giving the guideline or consensus documentation. I am a little bit strong in my words, don't mind for it, because we are scientific people, we must focus on science rather than emotion. Chasing the low LDL cholesterol to unrealistic level is not only unwarranted, but also unjustly, considering the huge cost and potential adverse effects. However, the lipid-lowering therapy is still elusive. As I'll talk to you later on, you'll see why it is so. With all this background, as I told that CSI proposed to have this clinical practice guideline for dyslipidemia management, and most statin-treated patients were receiving low to moderate intensity of drugs. LDL threshold attainment was low among patients receiving lipid-lowering therapy. On this alarming background, it was long time overdue that India-specific guidelines should have been coming a long time back. It is imperative that we adhere to the recommendations and do justice clinically and ethically for the overall improvement of patient care and outcomes. This was the guideline of which I was, of course, the part. Dr. Sani was the convener of the study. Now, there is no doubt about the beautiful beneficial effect of lower LDL therapy to coronary artery disease. These are already evidenced with the different trials and different aspects of the coronary artery atherosclerosis which have been highlighted. But chasing LDL cholesterol has started long time back, way back in 1938, and it is still going on. And latest is, of course, the inclisiran, then the ivermectin, alirocumab, and all these are going on and going on. But fact is, half of the world can't even afford statins. Can't even afford statins. We have to be a little bit realistic. And we are not aware of this UCARB, and we are not told that even lowering to a further level can have deleterious effect in the form of impaired immunity, increased risk of cancer, and sensory impairment. And that's why we should not jump upon the level of the coronary artery, level of the LDL cholesterol to an unrealistic level. Now, how low should be the LDL cholesterol levels as per the different guidelines? As per the American College and American Heart Association, the LDL level should maybe taken up to 55 milligram of deciliter. Now, this is for the ACS and well applicable for the stable coronary artery disease also, as I'll tell you later on. And for all patients with atherosclerotic cardiovascular disease, CAD with or without PCI, LDL goal should be less than 55 mg/cent. Same is with the ESC, less than 55, but you are to lower it further as per the recommendation up to 40 millimeter or low if there are recurrent events. And what about the Indian guidelines? In ACS, it should be taken below 55, and in very high risk patients and recurrent events, it should be below 40 or up to 40. Now, there should be some recommended prescriptions of the reporting system, and we have not yet forwarded it to the different laboratories. But these are some of the things which we should try from our CSI as well as the branches to all the laboratories, that these are all well documented evidences based guidelines. That is why the different levels have been mentioned in the down panel: low, moderate risk, high risk, very high risk, and extremely high risk, which has been mentioned here. And this risk assessment should be done in all patients, and according to the high risk or very high risk or extremely high risk or moderate risk or even low risk, we should attempt to lower the LDL cholesterol level, whether below 70 mg/cent or up to 40 mg/cent. We should take care of the LP also. I'll come to it in a little bit of detailed way with some slides later on. These are anticipated lowering of LDL cholesterol by different molecules, and that's why the differences in the definition: low intensity, moderate intensity, high intensity, and 45 to 50% with the high intensity, and low intensity 20 to 25%. And with the PCSK9, we can reduce it to further level of 75%. And if we combine all these drugs, we can decrease the LDL cholesterol level by 85%. So for the guideline by CSI on lipid lowering therapy, this is the algorithm, and you should target it by giving a high dose of the high intensity statin to the level of 40 milligram and 80 milligram or 80 milligram of atorvastatin, 40 milligram of rosuvastatin plus ezetimibe, and then you should titrate as per the lipid level after 4 weeks, after 8 weeks, and after 12 weeks. If after 3 months of therapy there is recurrent evidence of acute coronary syndrome and the goal has not been achieved, then or achieved below 55 milligram, then in that case you should lower it below 40 milligram, or you should lower the non-HDL cholesterol below 70 milligram. When should you start the statins or PCSK9? As per the various meta-analysis, it should be tried within the first 1 to 2 days. For the stable coronary artery disease, the target is a little bit on the higher side. That is, you should take it up to 70 milligram %. And these are the various guidelines or algorithm. You should add, if one drug does not take care of it, with ezetimibe. If not, then you add bempedoic acid. If not, then only you should try with the other drugs like inclisiran or PCSK9 inhibitors. And so for the triglycerides is concerned, you should treat it when it is more than 150 gram percent. This is again the algorithm for hypertriglyceridemia. If it is more than 150, definitely the lifestyle measures and the various risk factors should be taken care of. If it is between 150 to 499, then all atherosclerotic prevention, including the drug, should be done. If it is more than 500 to 1000, then intensive lifestyle measurement, control, then very low fat diet, fibrate, saroglitazide should be attempted, and if not controlled, then we should try with some experimental drug like NGPTL3, then evinacumab, and all these are all experimental. So with all these, the guidelines also highlighted some of the features with the dyslipidemia in elderly and dyslipidemia in young. I'm not going into the detail of it in the interest of the time, but what I will highlight that in the dyslipidemia in pediatric age group, the recommendation is the screening of children should be done at 2 to 9 years of age when there are high risk of family history. The drugs are best avoided in children less than 10 years, and ezetimibe can be given to children above the age of 10 years. So these are some of the important highlights of the dyslipidemia in the pediatric age group. So for the familial hypercholesterolemia is concerned, it is a very, very important concern, and it is quite being detected more and more, and you should detect it as early as possible, and then you treat it as per the guideline that has been put over here. Here, you should try to lower the LDL level to below 55 milligram percent, and you should use all the combinations with the highest dose of the drugs, and if they fail, then only you should try with the other methods like ivoriculumab or elicumab, and if still unstable, the apheresis, LDL apheresis is a mode of treatment. This is a very important concern. Many of us are very much concerned about the statin-associated muscle symptom, but there are guidelines, and you should follow those guidelines. If the symptoms are present with high level of CPK, more than 4 times, then you stop statin for 4 weeks. Try with the lesser dose. Try with other drugs. If they are not correctable after the challenge with the lesser dose and other drugs, then you should try other methods or other drugs to lower the therapy to LDL level with the bempedoic acid or ezetimibe and even the elicumab and other drugs. So you should try to lower the level so that the complications and the adverse effects of the high cholesterol in the form of coronary artery disease are not there. Even after doing all this, you may be facing with the residual risk, and these residual risks are not only due to the lipid level, it might be associated with the residual inflammatory reactions, and they can be taken care of by the high intensity statin and other medications, that is the evricumab or elicumab, and recently in SCAS, even the colchicine has been attempted. LPA is another research product which has come highly from our country, and it is high in some of the populations, and this should be taken care of by exercise mostly. Apart from exercise, some of the approved lipid lowering therapies are to be continued, and LPA directed therapies like pelacarsen, oliparisen, and SLN 360 should be continued. And this is a warning from the BMJ that PCSK9 is not without side effects. There can be increased mortality if we lower the cholesterol level, LDL cholesterol level to below, say, 20 milligram percent. This is the paradox. I am not going into the detail of it, but definitely I will go to the straightway to the conclusion. For the treating physicians, the executive summary is expected to be adequate for the purposes of providing the best of care to their patients. We have tried to cover each and every aspect of dyslipidemia management specific to Indian population. However, in many areas we have used the experience of experts for developing these practice guidelines because of lack of Indian data. These guidelines have focused on the dictum: earlier the better, lower the better, longer the better, and together the better. And these consensus guidelines cannot replace the individual clinician judgment, who remains the sole arbiter in the management of the patient. Thank you very much for patient hearing.
Thank you, Dr. Das, for excellent explanation. Since no question answer is allowed due to paucity of time, for the benefit of audience, I would like to ask one question. How often do you achieve the goal of 40 milligram without using PCSK9 or Nicloceran?
Actually, this is a very important question. In fact, with all the combinations of the statin, ezetimibe, and bempiridic acid, we can achieve even LDL cholesterol lowering to below 24 milligram %. Mind it, below 25. But percentage-wise, possibly around 30 to 40% only can achieve this. Rest of the persons will have to take resort of the other kinds of medications, including apheresis.
Thank you.
Our next speaker is Dr. Yuvan Singh from PMCH Patna. He is going to speak on 2024 ESC guidelines on hypertension. Dr. Ajay sir, can you join the dais, please?
Hello. Good morning, respected chairpersons, faculties and delegates. So my topic is ESC guidelines on hypertension that was recently published just now, 1.5 months back. So we know that hypertension is a risk factor for so many diseases: coronary artery diseases, CVA, peripheral artery disease, congestive heart failure, atrial fibrillation, CKD, atrial fibrillation, dementia, and many more. And you know, the prevalence of hypertension in India is very, very high. This study, ICMR, conducted by ICMR in 4 states, particularly Tamil Nadu, Jharkhand, Chandigarh, and Maharashtra. So the prevalence of hypertension, it varies from 20 to 32%, and hypertension is more prevalent in the urban India than in rural India. So for the diagnosis and management of hypertension, the first step and for most important step is get the correct number, that is the correct blood pressure, and that can be done by measuring blood pressure by a validated and the calibrated device, and following the correct measurement techniques, and apply a consistent approach, application of a consistent approach for the BP management for the each patient. We can get the list of the validated BP equipment on a website. Various websites are present. One of the important is the www.validatebp.org. We can get the list of validated BP equipments. Nowadays, more emphasis is given on the out of BP measurement because it is more closely related with the target organ damage. So it's recommended for the diagnostic purposes as well as treatment purposes also, because it can detect both white coat hypertension as well as mass hypertension. So whenever, because there are logistic issue or economical issue, just like in our part of the country, in India, we cannot go for the home due to several reasons. The diagnosis of hypertension should be confirmed by a repeated blood pressure measurement using the correct standardized measurement techniques. And automated oscillometric monitors what we get in the market, that is are the electronic machines, are not validated for the BP measurement in atrial fibrillation. We have to rely upon the manual auscultatory method in these circumstances. So whenever we see the patient for the patient for the first time, we should measure the blood pressure in the both arm, and the arm showing the higher blood pressure should be the reference arm for the measuring blood pressure for the further measurements. And those who have blood pressure difference in the both arm is more than 10 carries a high cardiovascular risk and may indicate arterial stenosis. So now, in contrast to 2018 guidelines, the recent guidelines recommend the BP categorization into 3 classes, namely non-elevated blood pressure, elevated blood pressure, and hypertension. This is based on the fact that the blood pressure is a continuous exposure variable and it's not a binary variable. So that hypertension or non-hypertension, this is continuous, just like the diabetes, because as the HbA1c level increases right from the 4.5, the risk of the cardiovascular disease increases. This is the case also with the blood pressure. And we not only have to treat the number, we have to take several factors in the account that are the risk factors, like whether the patient is having the moderate to severe CKD, CVD, hypertension-mediated organ diabetes, or familial hypercholesterolemia. But in those patients who are not having these parameters, we have to go for the SCO2, or assessment of 10-year risk of the fetal and non-fetal cardiovascular risk among the individual who are the 40 to 69 years of age. Similarly, in the older patient, a SCO2 OP for the older patient is recommended for the assessment of risk who don't have the baseline risk of moderate CKD, CVD, HMOD, diabetes, or the familial hypercholesterolemia. So this is the blood pressure is categorized into non-elevated blood pressure, elevated blood pressure, and hypertension. So non-elevated blood pressure when the systolic is less than 120 and diastolic is less than 70, whereas the hypertension is diagnosed when the systolic blood pressure is more than or equal to 140 and diastolic is more than or equal to 90. And the hypertensive crisis should be excluded when the systolic blood pressure is more than 180 or equal to 180 and diastolic more than 100 or equal to 110. And this classification is based on the average of 2 or more properly measured seated blood pressure in the office. So now I have told that the more emphasis is given on the out-of-office BP measurement, that is the home-based blood pressure monitoring, and the ABPM, that is ambulatory blood pressure monitoring. So you can, in the home BP, the BP is recorded in the morning and evenings. Several data are taken, and we calculate the average. And hypertension is diagnosed when the systolic blood pressure is more than or equal to 135, and the diastolic more than or equal to 85. While in ABPM calculate 3 set of data. The blood pressure is monitored round the clock by ABPM machines. It calculates daytime average, nighttime average, and 24-hour average. So daytime average is slightly higher than nighttime. As you all know, the blood pressure dips during the night time. So due to normal dipping pattern, nighttime normal blood pressure is usually lower. So if the daytime blood pressure is more than or equal to 130 by 85, it is diagnosed as hypertension. Whereas for night time, when the systolic blood pressure is more than 120 and diastolic is more than 170, it is classified as hypertension. So these are the guidelines for the diagnosis and treatment for the investigation of the several causes of the hypertensions. So whenever we get blood pressure in the range of 140 to 159 and diastolic 90 to 9, it recommended to get the diagnosis of hypertension by the out-of-office BP measurement. But again, when not logistically feasible, also due to economic reasons, we can go. Diagnosis should be made on the repeated office measurement for more than one office visit. And when the blood pressure is more than 160 by 100, it is recommended that the blood pressure in the range of 160 to 179 and diastolic in the range of 100 to 109 should be confirmed preferably by out-of-office measurements. And when the blood pressure is more than 180 and 110, we should always rule hypertensive emergency by several investigations. So we have to also look for the target end organ damage, and for the assessment of renal hypertension mediated organ damage, we have to see for the serum creatinine, eGFR, urine ACR in all patients with hypertension. If the patient has moderate or severe CKD, you have to go for the repeated measurement of the serum creatinine, eGFR and ACR at least annually. And the renal ultrasound and the Doppler examination should be considered in the hypertensive patient to assess with the CKD to assess kidney structure and determine the causes of the CKD and exclude the renal parenchymal and the renovascular hypertension. CT or magnetic resonance angiography is alternative testing option. For the assessment of cardiac hypertension mediated organ damage, a 12-bit ECG is recommended in all patients with the hypertension, and echocardiography is recommended in hypertension who have the ECG abnormalities or the sign and symptom of cardiac disease. Echocardiography may be considered in patients with elevated hypertension, particularly when it is likely to change the patient management. And fundoscopy is recommended when the blood pressure is more than or equal to 180 by 100 in the workup of hypertensive emergency and the malignant hypertension, as well as hypertensive patient with diabetes. Fundoscopy for detecting the hypertensive retinopathy may be considered with the patient with elevated hypertension. This is class 2B indication. The ultrasonographic examination of carotid and the femoral artery for detecting plaque and the coronary CT calcium scoring may be considered in the patient with elevated blood pressure or hypertension when it is likely to change the patient management. Routine genetic testing for the hypertension is not routinely recommended, and genetic testing may be considered in a specialized center for the treatment who have suspected to have rare monogenic causes of secondary hypertension or those with pheochromocytoma or paraganglioma. So regarding the management of the hypertension, so moderate intensity exercise more than 150 per minute is recommended, and along with the low or moderate intensity dynamic or isometric resistant training exercises to reduce the BP and the CVDs is recommended. So ideal BP measurement, BMI should be maintained in the range of 20 to 25, and waist circumference should be less than 94 in men and less than 80 in women is recommended. Adopting a healthy and balanced diet such as Mediterranean or Dutch diet is recommended to reduce the blood pressure and the CVD risk. Alcohol should be restricted. The upper limit of use of alcohol is 100 grams per week. But for the it is recommended to avoid alcohol to achieve the best health outcomes. So regarding the blood treatment drugs, among the all BP lowering drugs like AC inhibitor, ARB, dihydropyridines and diuretics, that all the drugs have shown and demonstrated the most effective reduction in the blood pressure as well as cardiovascular events, therefore recommended as the first line of drug to lower the blood pressures. And if the blood pressure is not supposed controlled by 3 drugs, then comes the role of spironolactone, and if the patient is intolerant to a spironolactone, then we can go for eplerenone. And beta blocker can be combined at any of stages, particularly if the patient has compelling indication like heart failure, angina, MI like that, so can be added. But if not added earlier, can be added at this stage. Other drugs should be added only after that are centrally acting BP lowering medication, alpha blocker, hydrogen, potassium sparing diuretics should be added. And what should be the goal of the treatment? So to reduce the CVD risk, it is based on the guidelines. it should be the treated blood pressure, systolic blood pressure,
Dr. Singh, you have to summarize.
Okay, sir. 120 to 129, and in some categories, only lenient approach can be applied. Those who are pre-symptomatic, orthostatic hypotension and elderly patient more than 85 of year of age are having moderate to severe frailty or limited predicted lifespan less than 3 years. So, as I have already discussed these slides. So, those patients who have blood pressure more than 140 by actual, usually combination of 2 drugs in the low dosage in a single pill is class 1 indication, not the only single monotherapy should be used.
So can you summarize, Dr. Evan Singh?
Yes, sir, sure.
Yeah, just summarize. That's
Okay,
all.
okay. So the blood pressure is categorized in the 3 categories: non-elevated, elevated, and hypertension. And out of office BP measurement should be done to confirm the diagnosis of hypertension. The target in the range for the most of the patient is 120 to 129, and diastolic in the range of 70 to 79 for the most of the patient. There are some exceptions that has been already discussed. And the single pill combination therapy, the combination of 2 different classes should be used as the first line. Those having the blood pressure for more than 140, then triple drug combination, then triple drug combination in the full range, then comes the role of spironolactone and eplerenone. Beta blocker can be added to any of the tests if they are compelling indication. Then comes the role of directly acting vasodilators, sympatholytic, alpha blockers, and interventional therapy like denervation for the selected patients, those who are refractory hypertension or want to go for it. Thank you.
Thank you very much, Dr. Evan Singh. Wonderful talk. The best part of your talk was that hypertension management is a dynamic process. It's not that one value you take and then you're done.
Okay.
So, it's a dynamic process, so you have to be careful at any time and consider all the risk factor and dynamicity of blood pressure. What is happening about nocturnal blood pressure? What drugs are using? So thank you very much. Any comment, Dr. Bharti?
Thank you, sir.
That this guideline is totally different from previous guidelines, that we should be more aggressive in management of hypertension. First message is this is you can use the combination therapy in half of the doses of drug. Even you can use the four drug in combination. This is a new guidelines according to this is important.
We have been,
this pattern is very important.
We have been told by the organizers that one question can be allowed. So any question from the audience? No. No question from the audience. Floor participation. Oh, Dr. Chatterjee.
So before I close this session, I think one comment I deserve one comment.
Yeah, there's one comment. Now that we are treating the hypertension, consensus is coming that initial part we had that you start one drug, then you add another drug, then you add another drug. Now it's coming that if you use 3 or 4 drugs in a 1/3 of the dosage, start it with 1/3 or 1/4, go up to half the dose, and then you make it to complete dose. And in this way, the same combination in a very small dose may give a better result than the other dose. Means the 1/4 of the usual 4 drugs that you are using most of the time. Thank you.
One of the other important issue, you can be given a non-morning, evening, any time patient convenience is most important. You can take according to patient convenience, a night, afternoon, morning, as a patient convenience. Concept has gone, the morning is better than the evening.
One issue I want to highlight over here is that in most of the situations, as we see in our day-to-day practice, most clinicians, they are busy enough not to focus on achieving the goals.
So it is not only important to treat the hypertension, it is very, very important to achieve the recommended goals. So that will ultimately prevent the organ damage. So that is very important, which is often ignored in day-to-day clinical practice. And these goals can only be achieved by combination of drugs, not by single drugs. Thank you. And we close this session and call the next speaker, please.
Thank you, sir. May I request the presence of Dr. R.D. Yadve, sir, from Delhi to join us as the chairperson for this session. Also requesting Dr. Abhinav Bhagat to kindly join us on stage as the chairperson. Over to you, sir. We move.
Thank you, Dr. Yuvan Singh. And the next speaker is Dr. Vipin Kumar. He'll be talking about 2024 ESC guidelines on aortic diseases and PVD, peripheral vascular disease.
Thank you, sir. Respected chairpersons, seniors and colleagues. I am here to talk about 2024 ESC guidelines for management of peripheral and arterial and aortic diseases. And this ESC document involves lower limb PAD diagnosis treatment, chronic limb threatening ischemia, and PAD beyond legs, and then aortic diseases. So as per time permits, I will talk on PAD, lower limb diagnosis and treatment, and ischemia, and then if time permits, we'll go on further. So I'll start with introducing this central illustration of this document. As you can see, while managing PAD and aortic diseases, complexity in managing these patients, and also this slide highlights the multidimensional approach needed to diagnose and treat these diseases. And while managing these patients, it starts with early prevention, then goes to screening and diagnosis, and then patient-tailored treatment and specific management approaches. And also important, not to, after treatment, it is not over, and frequent follow-up is required to prevent further deterioration in these patients. So this is recommended that when managing these patients, to adopt a comprehensive approach that addresses the entirety of arterial circulation. So when you start diagnosing these patients, it is non-invasive testing is recommended, and it is diagnosed by ankle brachial index ABI, and when it is less than 0.9, it is suggestive of PAD. While diagnosing this with ABI, which we also have to keep in mind, in patients with diabetes or CKD, there is a medial calcification, and in presence of medial calcification, this can lead to falsely high ABI. So in these patients, other than ABI, that like toe brachial index or ankle pressure or toe pressure is recommended. So after diagnosis, PAD is categorized according to clinical presentation, and many of you must be knowing Rutherford classification and Fontaine classification. This ESC guidelines has simplified the categorization, and it has categorized into 3 groups. One of those patients who are diagnosed by screening only with no symptoms are asymptomatic PAD, with typical effort-related symptoms are symptomatic PAD, and the third group is chronic limb-threatening ischemia. And also, while managing these patients, we have to see that these patients are at advanced stage of atherosclerosis, and these are the patients who are at higher risk of cardiovascular events, also major cerebrovascular events, and major lower limb, major adverse limb events. And so the central therapeutic aims are to reduce the risk of MACE, to reduce risk of major adverse limb events, and to improve the quality of life. And to achieve these goals, multi-modal treatment of PAD is recommended. So there are many optimal medical treatment involves medical management, non-medical management, and then revascularization if needed. So among the medical management, we have to tailor antithrombotic treatment. So patient with a chronic symptomatic PAD who are presented with a non-high risk presentation or a non-high risk comorbidities, the single antiplatelet therapy, either aspirin or clopidogrel is recommended. Those patients who are at high risk or high risk comorbidities without high bleeding risk, dual pathway inhibition with aspirin and low dose rivaroxaban is recommended. And those patients who require long-term anticoagulation, full dose single oral anticoagulation monotherapy is recommended. Again, following revascularization, antithrombotic therapy depends on the presence of bleeding risk and whether the long-term anticoagulation is required or not. So with the patient with no bleeding risk, aspirin and low dose rivaroxaban recommended, and additionally one antiplatelet for 1 to 3 months is recommended following revascularization. And those who require long-term anticoagulation, single antiplatelet plus anticoagulation for 1 to 3 months followed by oral anticoagulation monotherapy is recommended. Antihypertensive therapy in peripheral arterial disease, systolic blood pressure target should be 120 to 129 millimeter of mercury if tolerated. And to achieve this SBP goal, the first drug of choice will be AC inhibitor or ARB in all the patients, except more lenient BP goal should be targeted in elderly patient or a frail patient or a symptomatic orthostatic hypotensive patients. Lipid lowering therapy, again, it is recommended to achieve LDL level less than 55 milligram per deciliter or more than 50% reduction in LDL versus baseline. And to achieve this goal, either statins, high dose statins or combination of statins and ezetimibe is recommended. If it is not achieved with this, either PCSK9 inhibitor or bempedoic acid addition can be given. Other than medical treatment, non-medical treatment involves multiple things like smoking cessation, weight reduction, diet management. The most important thing I want to highlight here is what they recommend is exercise training. So supervised hospital-based exercise program or supervised home-based exercise program is recommended, and which improves quality of life, improves walking distance and improves symptoms. And the time of training frequency is 3 times per week, 30 minutes for 3 months is recommended for these patients. So this is an algorithm for management of PAD syndrome, and there is a little difference between patients with wounds or without wounds, and all asymptomatic patients or symptomatic PAD patients, first of all, optimal medical treatment should be given, while supervised structural home-based exercise training plays a central role in this management. And if after home-based exercise training and OMT after 3 months, if the patient doesn't have improvement in symptoms, then the second thing I want to highlight here, the vascular team assessment. So before revascularization is contemplated, vascular team assessment is must before this thing. And chronic limb threatening ischemia, little different, I will come later. So with wound, again, the same thing, vascular team assessment and exercise-based training, this is a new thing which is recommended by ESC. Chronic limb threatening ischemia, again, all the patients have a high risk of cardiovascular event and cerebrovascular events, but these particularly chronic limb threatening ischemia patients have a higher risk of amputation and death. And these patients are diagnosed with a hemodynamic measurement, and in these patients mostly they have a medial calcification and they need ankle pressure, toe pressure or transcutaneous PO2 measurement for diagnosing these patients. And this is the group of chronic limb threatening ischemia with a rest pain or tissue loss or ischemic ulceration or gangrene. So these patients with chronic wounds, Wi-Fi classification system is considered to estimate individual risk of amputation, and this classification depends on wound categorization, type of wounds, ischemia based on hemodynamic measurements and type of foot infection. So as you can see here, as the risk score increases, the risk of amputation increases. So this treatment algorithm in patient with CLTI or chronic limb threatening ischemia is different. Here from the initial part itself, after diagnosis, optimal medical treatment is initiated and vascular team assessment should be done immediately with no exercise training, and revascularization is indicated and reasonable if feasible. So for limb salvage in patient with CLTI, revascularization is recommended, and early recognition and referral to vascular team are recommended for these patients. So I'll come to PAD beyond legs, other than the lower limbs, renal artery disease, then visceral artery disease, and subclavian artery disease. So renal artery disease, you can see the clinical signs suggestive of renal artery stenosis, early onset of hypertension or severe hypertension, resistant hypertension, or a patient with a flash pulmonary edema, unexplained atrophic kidney or discrepancy in kidney size, or unexplained renal failure. So these patients are initially screened by a duplex ultrasound, and if the ultrasound, renal Doppler ultrasound is suggestive of renal artery stenosis, the morphological diagnosis is done by MRA or CT angiography. And if MRA CT angiography is diagnostic, the further treatment depends on whether one kidney is involved or two kidneys involved, kidney viability, and the presence of high-risk features. So the presence of high-risk features like rapidly progressive treatment, despite rapidly progressive treatment, resistant hypertension, rapid decline in renal function, flash pulmonary edema, and solitary kidney, these are the group of patients who require revascularization, either in a unilateral RAS or a bilateral RAS, or other patients are treated by OMT. And when you have planned for a revascularization, you go for a catheter angiography, and then you can see hemodynamically significant renal artery stenosis, or more than 70% renal artery stenosis is indicated for revascularization. And after revascularization, follow-up is recommended. Again, acute mesenteric ischemia can be caused by embolic or thrombotic episodes, and this CT angiography is gold standard for diagnosis. There is no lab test which is reliable for diagnosis for mesenteric ischemia. High index of clinical suspicion is required, and these patients require urgent revascularization. And endovascular revascularization is superior to surgical intervention in terms of in-hospital mortality and rates of bowel rejection. And in some centers where endovascular treatment is not available or complex anatomy surgery can be considered. Chronic mesenteric artery disease mostly may be asymptomatic because of presence of collaterals. Again, this is also diagnosed with high index of suspicion, CT angiography gold standard. And in chronic mesenteric ischemia patients, again the patient is symptomatic, then only a vascular team assessment is done, and then revascularization can be considered. Again, in the subclavian artery disease, in atherosclerotic upper limb artery disease is most frequently located in subclavian artery, and Doppler ultrasound assessment or a flow reversal in ipsilateral extracranial vertebral artery by hyperemia testing and transcranial Doppler, and can be suggestive, and then CT angiography is diagnostic. I will come to highlights of my presentation. And this ESC guidelines, multidisciplinary approach and multimodal treatment with vascular team involvement is a requirement for diagnosing and management of peripheral vascular disease. One thing they have emphasized is exercise training, that is hospital-based or home-based supervised exercise training in symptomatic PAD patient. And in those patients who are having chronic limb-threatening ischemia, they need revascularization as soon as possible after diagnosis. And atherosclerotic unilateral RAS or bilateral RAS, or RAS in a solitary kidney with high-risk features and sign of kidney viability will need renal artery revascularization. Acute mesenteric ischemia needs endovascular revascularization, and chronic mesenteric ischemia, if symptomatic, endovascular treatment can be done. Subclavian disease, again, revascularization only in symptomatic patient, and in some of the selected patient of asymptomatic patient, like patient requiring hemodialysis, the same side, those patient SCA disease also can be revascularized. Thank you.
Excellent overview of the guidelines, 2024 guideline, ESC guideline on peripheral vascular disease. I have to just comment one thing. Acute superior mesenteric artery thrombosis, either in situ or embolism induced ischemia, acute mesenteric artery ischemia, superior mesenteric artery ischemia is lethal. Yes. The death rate is almost 100%. and it is associated with severe acidosis. And any abdominal pain which is resistant to pain-killing drugs, whatever you give, morphine, Fortwin, it will not respond till you relieve the ischemia. And these patients are very high risk of death. So immediate CT angio is the diagnostic, and then intervention. We prefer acute intervention by using self-expanding stent in thrombus-containing lesion, along with the we give papaverine. And no thrombolytics works. Only we have treated and saved the patient. And otherwise you have to do surgery also, because those gut tissue which was dead, you have to take out. Otherwise, this patient won't survive. Or if your full ischemia occurs, all small bowel gone, then the patient has to be on TPN.
Yes,
So,
survival will depend on the timing of revascularization and the extent of bowel rejection.
early diagnosis, suspicion of diagnosis is like pulmonary embolism. Until you will suspect, you will not able to diagnose. So acute mesenteric ischemia in any pain abdomen, you have to suspect. So you have to coordinate with your gastroenterology colleague to detect this disease and treat immediately, diagnose it immediately by CT angio, as well as CT angio will give, CT will also give the gut ischemia, that is edematous bowel with gas inside the bowel. So all these are diagnosed by CT. That is the only two comment. Thank you.
Thank you, sir.
Thank you. Due to paucity of time, no question allowed. Our next speaker is Dr. D.S. Chadda. His talk has been postponed because he has to leave early. He is going to speak on management of. His topic is image-guided management of classified coronary artery lesions. Dr. Chadda, please.
Thank you, Dr. Anupam in particular. She's the reason I'm here actually, and multiple reasons not to be here. Can I have my slides, please? That's it. Yep. All right. For the next 15 minutes, I'll run you through management of calcific disease. Well, treating calcium in the coronary arteries is a big challenge because the lesions are complex. They have high syntax score. You have left main triple vessel disease. You have tight angulated lesions. You have chronic total occlusions. You have solitary surviving vessels. The lesions have complex morphology. There are nodules, long, thick calcific plates are there. Invariably, these patients are elderly and they have multiple comorbidities, COPD, CKD, diabetes, and this is the subset which you are dealing with. Now, plaque modification is very important because it restores the compliance of the vessel, and if you restore the compliance, then only the stent will expand. You will be able to deliver and expand the stent. If you've not expanded a regulating stent, you have failed miserably because this stent is going to fail any time. And if you achieve good MLDs, that is what is going to assure you of good long-term results, because if you see the prognosis very poor, almost 24% failure rates at the end of 1 year in severely calcific disease. So the simple algorithm which we follow while treating these patients is that we first check whether the lesion is balloon crossable or not. If the lesion is balloon crossable, more than half the job is done. If not, then you need either laser or rota, and thereafter you need to pass an imaging catheter. Now, imaging occupies the central stage. It's going to tell you about the severity and distribution of calcium, and if you notice that the lesion is severely calcified and there are big nodules, then you need orbital atherectomy. This tool is invaluable in this regard. Thereafter, once you've done the plaque modification, you can use cutting, scoring balloons, OPN, IVL. It's a spectrum of devices which you get. It is just to ensure that you achieve optimal stent expansion. So what I'm trying to say is that imaging occupies the central stage, and it's very important that you image. Now, plaque modification requires imaging both pre and post. A lot of people believe that only post is enough. Pre strategizes and post optimizes the stent. And these are the tools from which you can select. Let's look at the balloon crossable lesions. You can use balloons as sole device, or you can use these balloons post atherectomy. Now, what's important is using them as a sole device, your calcium thickness has to be less than 240 micron or less than 0.24 millimeters, and the arc has to be more than 200. If you have a good arc, the balloon is going to work. You can choose between Wolverine, angiosculpt, OPN-NC, and Apartha. Now all of these balloons are 5 French compatible. Now we don't use 5 French for treating calcium, we use 7 French. What I'm trying to tell you is that the profile of the balloons has come down tremendously and they are easily deliverable and usable. They are pretty safe. Each indication is given on the slide. I'm not going to run through it. Apartha is the bulkiest of the devices. There are certain balloons like Wolverine which you can't use in a kissing manner, where the others can be used for kissing, and they all induce dissection and there is always a risk of perforation at high pressures. OPNNC invaluable in post-stent under expanded stents, whereas for highly calcific lesion all of them work uniformly well. Well, case examples, one of the circumflex disease, OM had a disease. We just used the Wolverine and see the cuts. This is the amount of calcium which was there in the lesion. There was the osteum was spared and there was calcium all over. All what we did was we cut this lesion and put a stent, and if you use a cutting balloon, these are the kind of cuts which you get, and the calcium is absolutely broken. This is how a superficial calcific plate is treated. You get tremendous luminal gain. You put a stent in the OM branch and the procedure ends. Now the next case is, it's not scrolling down. Can you help scroll down the slides? Reload. I was just running through slides to keep pace with time. They're not working. Yeah. Murphy's law. So it's stuck at the same slide.
Next slide. What happened?
All right, I can continue without slides also. That be so. So, okay. So if you have lesions which are not balloon crossable, then you need to have some of the atherectomy devices, and the most important device in this segment is rotablation, because this is a front cutting device. This is the device which has got atherotomes, the diamond burrs which are there at the front of the device, and it cuts through. The only prerequisite here is that the wire has to cross the lesion, and once your wire has gone through, it's going to cut the lesion and you get access. So this is an invaluable device in this regard. Are we getting there? We also have for the same line the other atherectomy tool which is now available and is being marketed by Abbott, the orbital atherectomy. Now orbital atherectomy has a eccentrically mounted burr which is 1.25 millimeters. It's got diamond chips which are located on top. Now how it works is that it orbits, it generates centrifugal forces which cuts through the lesion. Okay, fine.
Yeah.
No, I can't scroll up and down. I would have shown you some very interesting images and case examples. This presentation is studded with case examples of calcium. This what you just saw was IVUS NIRS. IVUS NIRS is a new imaging modality which we have. Now NIRS is near infrared spectroscopy which penetrates through the calcium plate, and it can tell you what this calcific plaque is sitting on. So if this calcific plaque is sitting on a lipid pool, you can easily break this with using NC or cutting balloons. You don't need specific, big atherectomy tools for dealing with this calcium. So you can easily push it back. It implies that the calcium is sitting on a very soft plaque and it can easily be pushed back. And the stents in this milieu expand very well. They absolutely become circular. So you can skip all this if it is not working. Can I have it on the screen?
Yeah.
Okay.
Now it's working.
Fine. Can I go into the slide presentation mode? Does it go into the slide? No, it doesn't go. Okay, fine. So this is a nurse image. This is nothing but a co-registered near-red infraspectroscopy with IVUS. IVUS gives you the morphology. And if you can see this yellow ring means that there is lipid behind this calcium plate. So this is how it looks. So this was a calcific plate which had almost circumferential lipid pool. You grade this lipid as LCBI, lipid core burden index. And wherever the score is more than 400, it's considered to be significant. And this is how you take the prescription out of the cath lab to the OPD. Anyone having more than 400 score, you have to give statins for a little longer period of time. So this lesion was just dilated, and the image has got inward. Okay. And we had slow flow. This was post-NIS. I'll skip all this. And this was the final angiogram. So this case, we didn't use any specialized tools. Let's come to the uncrossable lesions. We have a direct comparison, couple of slides between OA and RA. This is the question which I am invariably asked. Both of them work almost in a similar mechanism. The one does differential sanding, the other cutting. The OA moves in a bidirectional phase. That means it's going to cut in the both directions, forward and backward. It's got an orbital path of motion. It's very easy to set up orbital atherectomy. It doesn't require big pumps or compressors in the lab, and it needs only 6 French guide because it's 1.25 burr. But if you use a larger burr in the rotablation, you need bigger guides. And of course, Viper slide solution is required for OA because without that you can't do. Rotaglide we have not been using. Burr sizes I've already mentioned. Now the Viper wire is a 012 wire which you use for orbital atherectomy. It's a nitinol wire which is kink resistant. It's a very user friendly wire, very easily handleable, so you can do direct wiring with the orbital atherectomy procedure. Whereas for the rota we use a 09 steel wire which can develop kinks. Never ever do rotablation when you have kinks because it's an ideal recipe for a stuck burr. We generally do a step burr approach for the rota. That means if the larger burr is not passing, we step down. If the smaller burr has created passage where we get dog boning of the balloon, we have to step up the burr. Now stuck burr, bradycardia, slow flows are seen essentially with rotablation because it generates particle size to the tune of 8 to 10 micron, whereas orbital atherectomy produces a 2 micron size particles. Now these do not cause slow flow and the incidence is very, very low. But orbital does lead to more dissection and there is more risk of perforation if you go aggressive at higher speeds. Well, where do I use rota? I use it for CTOs, aortoosteal lesions, and long segment disease. I don't prefer orbital because it's going to occlude the vessel for a very long time and it causes chest pains. Tortuous lesions, there is an IFU by the company itself. A lot of people say that orbital is better in tortuous vessels. No, it is not. There is high risk of perforations in the tortuous segments. Small vessels have not been tested less than 2.5 because there is again a risk of dissection and perforation with orbital. So all these setups and stent ablation, of course, rota works. In all these settings, orbital works rota works much better. Orbital is essentially reserved for debulking calcium. When you have a lot of calcium and you want other tools, you can use orbital in larger vessels. You can go to higher speeds at 120 RPMs. And it cuts the nodules which no other device cuts. It is a tool to be used in severe LV dysfunction. As per the IFUs, it's a device which is safe up to 25% EF, whereas you have to be really, really careful using rotablation. Well, where nothing goes, as I mentioned, rota goes. So this is an anomalous RCA which was rotablated by keeping the guide just hanging in the aorta. We did the ostial RCA. You have tortuous vessels, one of the circumflex and the LAD. You can see the amount of bends and turns which the rota burr is taking. There are lesions where we go ahead and dilate thinking that it's a very simple lesion. This was one such case which won't give way. There was dog boning of the balloon and there was dissection which was induced. Now rotablation can be done in large vessels with dissection without any problem. So we rotablated this and stented this vessel. In CTOs, rota is absolutely must if you have calcific CTOs. We started with the CTO, we couldn't cross, so first segment, and thereafter we had to change the guide to the AL with adequate support. We did the complete segment and we got good results. Well, uncrossable lesions is another subset where rota is invaluable. I'll take 2 or 3 minutes more. All right, so you need to cross these with the lesion. Sorry. All right, so we cross this, and the basic principle is that if you have uncrossable lesion, put the guide catheter, jam the guide catheter there, then exchange the wire. You can put the rota wire, and once the rota wire goes through, like was done in this case, you can rotablate the distal segment and then stent it. So the protocol here is that is the lesion crossable? If not, you change the wire, you use a slippery wire or a CTO wire. If that goes through, you can push the microcatheter. If the microcatheter is not going through, then either you need laser, very expensive, not available. You can use granuloplasty, that means 0.75 balloon. You burst these balloons and you create a passage, put the microcatheter, and then change the wire. So what I'm trying to tell is a combination of guide wires, small balloons are required when you're dealing with calcium, and which is especially not allowing your burst to go through. So I'll skip this. I mean, most important message here is that use larger guides, use guide extensions when you're doing calcium. It's very important. If your rota burr is not crossing, doing the complete job, do a half rota and don't do very prolonged rotablation. And if it is prolonged, then change the burr. Orbital atherectomy, it's an invaluable device when you're dealing with nodular calcium, calcific nodule in the ostium of the RCA. We did the orbital atherectomy. The only precaution with orbital atherectomy is that you need to go very slow. If you go fast, you will not get the kind of luminal gains. And you must try to do multiple passes with orbital atherectomy. These are the two key messages. Go slow and do multiple passages. You will get good luminal gain. And we stented this RCA with Megatron stent with very good results. Well, the limitation of atherectomy tools are that there's a longer learning curve. You can't do them with two wires in place. So there's need for another tool which IVL fills up that gap. It works for both superficial and deep calcium, and it cracks the calcium in the deeper plane, which no other tool does. And the fragments have to be separated. A lot of people use IVL and then directly put a stent. Please don't do that. You expand. Once you expand, these fragments will move away. Nice OCT pictures illustrating the same. The fragments have moved away. You get good luminal gain, and the luminal gain is unmatched. Where do I use IVL? I use it in small calcific vessels, dissected vessels, in ACS presenting with calcium, in patients who have severe LV systolic dysfunction, for underexpanded stents and tortuous vessels. Now, this is the subset in which IVL should be used. I personally feel that IVL is one of the most abused tools in the calcific milieu, because if you have an access and you want to use a device, you use it, but kindly reserve it for such patients. And if you're not able to deliver, use either orbital or rotablation and then do the IVL. Well, laser penetration is very, very poor. It's not available. It works with the mechanism which is mentioned on the slide. I'll not go through it. Essentially reserved for CTOs and ISRs. We used it in this CTO case. Again, the principle of laser is that you have to go very slow. You have to let the laser work. In calcific milieus, you can give small contrast injections and increase the penetration of the laser beam. This was pre and this was, this was, it's not playing, okay. This was post of the same vessel. Well, the challenges with ROTA and OA are that, as I mentioned, you need additional device. There is always a risk of MI, slow flow perforation. IVL is very expensive, even though available universally. Laser is, the equipment is expensive, but it's not available everywhere. So optimal plaque modification generally requires not a single tool. You can't say that if I have this tool, my work is going to be done. So I'll quickly run through this case. You need combination of tools. You see the calcific nodules in the distal left vein of this sole surviving vessel. This was supplying almost everything. Circ was CTO, and this was supplying the RCA. Wiring was very, very difficult. And when you have nodules, the wiring becomes very, very difficult. We wired, then the microcatheter won't go, so we did granuloplasty. Then we did a step burr, 1.5, 1.25, 1.5, IVL, OPN, NC. We fractured the calcium. Now, this is very important for you to illustrate that you fractured and displaced the calcium, because then only will you get luminal gain and you will get result like this. So this kind of now is filling the RCA very well. As you can see, the circles as it is not filling. To summarize, I would say that management of calcific disease is very, very important. Invariably, the patients are elderly with LV dysfunction. They have comorbidities. So have a heart team discussion in true spirit, not on the paper, but have a heart team discussion. Have your surgeons on board. These lesions are very complex with high syntax. Achieve as low a syntax score as possible. That means target complete revascularization. These lesions are very complex, so you'll need combination of tools. So to conclude, I would say that there is no medical therapy available for calcium. An unplanned intervention in calcific milieu can lead to suboptimal results, and the stents will thrombose. If you've attempted a calcium and you feel that the lesion is not dilated, don't put a stent. You can come out by just plain balloon, and even with dissection, this vessel is not going to close. I can give you this assurance. But if you put a stent, you are committing a major blunder there. Heart team has to be involved, and you need to do image-guided intervention in these patients. You need to restore the compliance and then optimize the stent. this is the only thing which is going to give you good results. Thank you very much.
Excellent talk with practical demonstration. Only one question from the audience.
So if you have used the IVL and still the lesion is not expanding, fracture is seen but still not expanding.
So I have mentioned that in my talk. Whenever you use IVL is a device which just cracks the calcium. The remaining part of the job has to be done with the balloons which I mentioned. So you have to pick up either the NC balloon or the cutting balloons, and you have to do the job. A lot of people, yesterday I was in Jaipur for a meeting, I saw an operator who did IVL and then put a stent, and then he used another balloon to post dilate. Now IVL is not meant to dilate your lesion. It is a device with just lithotripsy. It just cracks the calcium. Yes. Thereafter, you have to prepare the bed using. In my practice, 70% of the balloons which I use are 2.5 millimeter IVL because the disease segment is very tight and narrow. If you use oversized balloons, they rupture. I have not had even a single IVL balloon rupture, and I have more than 100 balloons under my belt. So use a 2.5. Thereafter, take an NC balloon which matches the distal vessel diameter. You crack it open. You do whatever you have to. Cutting devices, if the patient can afford, are invaluable because both fractures and dissections, these are two things which predict stent expansion. So if the patient can afford, you must cut the lesion also because it takes care of the fibrotic element there. These are two most important things post-IVL. You can't just do IVL and put a stent. It's like rota. You don't do rota and put stent.
Dilated with the NC balloon, it expanded, but when you put the stent, there is still some dent on the stent. Then what?
So that's because you've not used a cutting balloon.
Again, you want to
no, now you can't use
another IVL or what to do?
No, I don't think so. Then imaging is going to play a role. See, the first image which you've acquired, if you've done IVUS, and if IVUS shows you multiple layer of reverberation, that means it's a very thick plate calcium. If you've done OCT, you can easily measure the thickness of the calcium plate. Correct? And if you've not done these steps, then of course there's going to be a little bit of regret.
What I found that if even IVL fails, say if C2 plus even used 120 pulses, but it still fails, I found OPN adequately sized and go high pressure, it breaks.
So Dr. Yadav, all these tools are similar. You know, similar. I mean, OPN is invaluable. I mentioned that. Yeah. If even in under-expanded stents, but the trick with OPN is you go up to 20, check in orthogonal views, there should be no dog boning, thereafter go up slow. Now, the important thing with OPN is avoid dog boning, and the other important clue for OPN usage is when you go to high pressures, please wait there. Yeah. I always say when you're using high pressure balloons, it's like running a marathon. It's not a relay race. You can't go to 2, 4, 6, 8, 20, 24 and then deflate. No. Wait there. If I'm trying to push this table, one jerk is not going to move it. I have to be persistent. So if you've gone to 24, 28, stay there for 10 seconds at least. Yeah. Then deflate, go to 28 and stay for 10 seconds. I can tell you 95 or 98% of the times the stent will expand and the calcium will give way.
So it is what I call this is OPN as a poor man's IVL.
Absolutely. Agreed. Fully agree. Fully agree.
Thank you.
Thank you.
Now I must congratulate and thank Prof. D.S. Chadda for his exciting talk. Now I will like to invite Dr. Ashish Kumar Jha from Heart Hospital, Patna to talk on ESC guideline on atrial flutter. Dr. Ashish.
Good morning, everyone. Warm regards to esteemed seniors and my chairperson. I'll be deliberating on 2024 guideline for AF management. So, whenever we are talking about AF management, now we all know the prevalence of AF is increasing, and the lifetime risk has increased from 1 in 5 to 1 in 3. And by 2060, the prevalence will double, and it will take almost 1 to 2% of healthcare expenditure. The 2024 guidelines started with the 4 pillars, that is care management for the atrial fibrillation. C stands for comorbidity and risk factor management. A for the avoid stroke and atheroembolism. R for reduce risk, reduce symptoms by rate and rhythm control, and evaluation and dynamic reassessment, and that reassessment has to be every 3 to 6 months. And at each reassessment, you need to calculate, you need to see all other development of any new comorbidities, or you have to calculate the AF score. So the guideline is now equality in healthcare provision, gender, ethnicity, socioeconomic, whatever the guideline applies for all of these people, and that is a class 1 recommendation. Education, patient-centric approach is a class 2A recommendation. When we are talking about comorbidity, it's very important to control all optimal management of all the risk factors, that is risk factor management, and all risk factor has class 1 recommendation, except bariatric surgery for rhythm control, which has a class 2B recommendation. Management of OSA is very important now, and that has a class 2B recommendation. So when we are talking about avoid stroke and thromboembolism, the first thing is you need to calculate the risk of thromboembolism, start oral anticoagulate on the basis of that, and that is a class 1 recommendation. Temporal pattern of AF is not relevant. Whatever the AF is, whether it is paroxysmal, permanent, persistent AF, you need to start OAC. And antiplatelet therapy is not an alternative to OAC, and that is a class 3 recommendation. The ESC has given a guideline, the score which we all know, CHATS 2 VAS score, but it has removed the gender from it. So that S has been removed, and that score has been modified to CHATS 2, CHA2, DS2, VA. So if the score is 2 or more, it's a class 1 recommendation for OAC. If the score is 1 or more, it's a class 2A recommendation for OAC. Now what is the choice of anticoagulant? DOAC is the first choice, except for mechanical valve or mitral stenosis. Mitral stenosis, moderate to severe mitral stenosis, which they defined as less than 2 square centimeter. Don't use DOAC. If you are using VKA, then the target INR should be 2 to 3. TTR should be more than 70%, and that is a class 2A recommendation. And even after optimal OAC, that vitamin K antagonist, whatever, warfarin or acetrom, if you are not able to maintain a TTR of more than 70%, then switch to a DOAC, and that is a class 1 recommendation. At each step, you have to assess the bleeding risk, and that is a class 1 recommendation. The most important thing is that these bleeding scores are not an excuse to stop or withdraw OAC, and that is a class 3 recommendation. You need not stop this OAC. You have to modify all the modifiable risk factors associated with bleeding. Then whenever your patient comes to bleed with bleeding, the important thing is that you have to stop, you have to prevent that bleeding. That is the more important thing. Do not combine antiplatelet and OAC for stroke prevention. That is a class 3 recommendation. And whenever we are using for chronic coronary syndrome or peripheral vascular disease, whenever we are using antiplatelet, don't use it beyond 12 months. That is a class 3 recommendation. When we are talking about reduced symptoms by rate and rhythm control, the important thing is that the first diagnosed AF, a patient comes to you, he is hemodynamically unstable, go for electrical cardioversion. If he is hemodynamically stable, the first important thing is the rate control, and that depends upon the ejection fraction. EF less than 40, beta blocker or lanoxin class 1 recommendation. Not controlled, combination therapy is class 2A recommendation. EF more than 40%, diltiazem or verapamil can be given, and that is a class 1 recommendation. Not controlled, class 2A recommendation for combination therapy. If still patient is symptomatic, wait for 48 hours, and that is a wait and see approach. If sinus rhythm is restored spontaneously, that is a class 2A recommendation. If even after 48 hours, patient is symptomatic and the patient is persistently having the AF, then cardioversion of symptomatic persistent AF, that is a class 1 recommendation. Paroxysmal AF rate control is similar as we have discussed earlier. The rhythm control again depends upon when patient comes to you with a paroxysmal AF or persistent AF or permanent AF. The important thing is to go for a rhythm control management. Now rhythm control also depends upon ejection fraction. What drugs to be used? EF less than 40%, amiodarone has a class 1 recommendation. 41 to 49% amiodarone or dronabinol is class 1 recommendation, with sotalol being the class 2B. No heart disease, flecainide propafenone is a very good drug, that is a class 1 recommendation. If patient is still symptomatic, go for catheter ablation. And if failed antiarrhythmic drug therapy, catheter ablation is class 1. If failed catheter ablation, then redo catheter ablation is a class 2A recommendation. Surgical or hybrid ablation is class 2B recommendation, and optimizing antiarrhythmic drug therapy is advised. So for a persistent AF, again, rate and rhythm control is similar as we have discussed earlier. The role comes for electrical cardioversion. As we have seen that hemodynamically unstable patient, electrical cardioversion has a class 1 recommendation. But again, now when a patient is having a persistent AF, whether rhythm control is going to give a symptomatic benefit or not, that also we can see in a hospitalized patient by doing a cardioversion, and that has a class 2A recommendation. Permanent AF, the rate and rhythm control is same. The only thing which is added in this, that if a patient with a permanent AF is severely symptomatic and history of heart failure hospitalization is there, rate control is not achieved, then we can go for AV nodal ablation and then go for a CRT. That is a class 2A recommendation in patient with LV dysfunction. Without LV dysfunction, even after optimal rate control, that is less than 110 beats, that is a lenient control is preferred. Even after this patient is symptomatic, then we can go for a AV nodal ablation in combination with pacemaker. Now conduction system pacing is very much recommended in this, and that has a class 2A recommendation. So whenever we are managing a patient for of atrial fibrillation, behavioral change with focus on key risk factors, shared decision making, achievable target should be tried, and provide information without overloading. All the risk factors should be controlled, which we have already discussed. Now when a patient comes to you with a bleeding, what should be done? In all patients on OAC, they should be evaluated for a bleeding. And do not use this bleeding risk scores, as I have told earlier, to withdraw or start OAC. Don't stop OAC. Means if the patient is not having bleeding. The optimal thing is that you have to control the risk factor, optimize the BP lowering medicines, avoid NSAIDs. PPI is a very good agent if the patient is at high risk for GI bleed. Reduce alcohol to less than 3 drinks. Keep INR between 2 to 3. Switch to DOAC if eligible, and fail to maintain TTR on VKA, and minimize the duration of heparin bridging therapy. Moreover, avoid restrictive, advise restricting hazardous hobbies and occupation, because it is associated with fall, and that can cause intracranial hemorrhage or even bleed. So the risk factor has to be controlled, and then even after optimal control of all bleeding risk factor, if there is a clear contraindication for OAC, consider for a left atrial appendage occlusion, and that has a class 2B recommendation. So how do we manage a patient with bleed? Compress the bleeding site. If the patient is on VKA, if the bleeding is minor, you just delay VKA until INR is less than 2. If it's a major bleed, non-life threatening, then go for a fluid replacement, blood transfusion, vitamin K antagonist. If it is a life-threatening bleeding, then PCC is a class 2A recommendation, and it is preferred over FFP. If it is a DOAC, then interruption of, if it's a minor bleed, delay DOAC for 1 to 2 doses, that will suffice. If it's a major bleed which is non-life-threatening, again, fluid replacement, blood transfusion. The only thing, if it's a life-threatening bleeding, then specific antidotes, we know idursulumab or indexanet for factor 10A inhibitor should be used, and that has a class 2A recommendation. Now patients for atrial fibrillation going for electrical cardioversion. Unstable, you have to do the electrical cardioversion. What should be the duration of OAC after cardioversion? For all the patients, irrespective of CHATS 2 VA score, OAC should be given for at least 4 weeks. And thereafter, you have to continue it depending upon CHATS 2 VA score. That is the very important thing. And if the patient, if electrical cardioversion can wait, then put the patient on OAC, or either it is DOAC or vitamin K antagonist for 3 weeks, and then do the cardioversion. If patient can't wait for that much of time, then if it is more than 24 hours, ideally T-guided cardioversion should be done, and that has a class 1 recommendation. If it is less than 24 hours, they can go for pharmacological or electrical cardioversion. So this is the relevance of echocardiography, and in the AF care management, at each step, echocardiography is important. For comorbidity, for example, cardiac amyloidosis, or when we are talking about risk factor for a stroke or thrombolism, there is a clot in LA. When we are talking about symptoms, reduced symptoms by rate and rhythm control, you have to look for EF, because all the rate and rhythm control agents use depends upon the LV ejection fraction. And then you will have to see for the what are the causes of atrial fibrillation for mixed mitral valve disease or rheumatic heart disease, mitral valve prolapse. So what are the different causes of atrial fibrillation? This is a very important slide which I would like to say, because we are getting many patients with acute coronary syndrome or chronic coronary syndrome who are on triple oral antithrombotic therapy. The first thing is that DOAC should not be given at half dose in these patients, and that is a class 3 recommendation. DOAC should be used or in preference to vitamin K antagonist, that is a class 1 recommendation. But whenever we are using acetrom or warfarin, till 12 months the target INR should be 2 to 2.5. After 12 months it should be target INR should be 2 to 3 months. And then the 3 timelines are very important, that is 1 week, 1 month, 6 months and 12 months. These timelines are very important. ACS undergoing PCI, uncomplicated PCI, triple oral antithrombotic therapy for 1 week, 1 year dual antithrombotic therapy with clopidogrel, means P2Y12 inhibitor plus OAC, and then after 1 year only OAC. ACS with high ischemic risk, then the triple oral therapy should be for 1 month, then dual for 1 year, and then only OAC for dual for 1 year, and thereafter OAC only. ACS medically managed, only dual antithrombotic therapy for first 6 months, thereafter OAC only. CCS, chronic coronary syndrome, uncomplicated PCI, again 1 week of triple oral antithrombotic therapy, and then 6 months of dual therapy, and then OAC only. And CCS with high ischemic risk, 1 month of triple therapy, 6 months of double therapy, and then OAC only, and that has class 1 recommendation. So multimodality imaging is must. I will skip this, and this is one slide which I would like to say that when we need to half the dose, apixaban when 2 of the 3, age more than 80, weight less than 60, and creatinine more than 1.5. So rivaroxaban only when the creatinine is less than 50. This catheter ablation, I would like to say 3 indications only. Yeah, we'll go for the last slide. So primary prevention, maintaining optimal BP with ACE inhibitor or ARB. And the important thing is for diabetes, metformin or SGLT2 inhibitor should be given. That is a class 2A indication, and weight reduction should be done. So with this, I would like to continue.
Thank you, Dr. Jha. Excellent. Only thing I would like to ask is what is the scenario in our country? Because, we were against the ablation. Now ablation after 2014, guidelines, recent ESC and all, it is 1A now in most of the conditions, most of the caveats.
Catheter ablation has set 3 indications. For AF causing tachycardiomyopathy is a class 1 recommendation. In AF who doesn't have a tachycardiomyopathy, to reduce heart failure hospitalization and prolong survival, it is a class 2A recommendation. It has also class 2A recommendation for SND, tachybrady syndrome, to prevent the development, to prevent the implantation of pacemaker. And for patient who has already undergone catheter ablation, we can go for a redo catheter ablation if the first treatment was relatively successful for more than 5 years. That also has a class 2A recommendation.
I'd like comment of Dr. Yadav, who has been doing this.
Actually, nowadays even paroxysmal AF, first time paroxysmal AF, it's now, instead of drug therapy, it requires ablation as a choice. So nowadays it's a choice of, ablation is the choice. Now which modality of ablation you want, it depends upon the availability. Like RF is available in our place, somewhere cryo is available, although PFA has not yet reached in our country, but pulse field ablation, that is the PFA, will revolutionize the treatment, because within 1 hour, within 60 minutes you will finish one ablation. And PVI is the crux, pulmonary vein isolation is the crux of the ablation nowadays. No other treatment required, like posterior wall isolation, SBC ablation or TIVC stomach ablation doesn't require. Only require is the pulmonary vein isolation, PVI. And if you read the Advent trial, where they compared the cryoablation, RF ablation, as well as the your PFA, all 3 are equivalent. So nowadays ablation is the choice, first choice, but availability is the problem. And RF, if I have to do with the RF, the cost is around 5 lakhs and recurrence rate is 40%. So they have to accept that recurrence. So these are the problems.
Yeah, recurrence rate is relatively higher in AF, and
I feel in first proximal AF ablation may not be choice because of the always the look for the reversible risk factor. Many of the time you have seen the one episode of AF not sufficient to send the patient for any intervention, invasive intervention.
Guideline wise, it is indicated only you have failed after drug therapy. That is, means after guideline, you are persistently symptomatic. Means that is guideline wise.
Now with the most of the thing focus on the lifestyle management in newer guidelines.
Yeah.
And invasive therapy only should be given in the patient is resistant to drug. One of the question, if after ablation, how long you have to give the anticoagulant? Lifelong or the only for short period? Even patient asymptomatic and sinus leak.
There was one slide I skipped it. After ablation, irrespective of CHATS2 VAS score, you have to give for 2 months. That is must. After 2 months, it depends upon CHATS2 VAS score. If it is 2 or more, means it's the same. But for 2 months, you have to give irrespective of CHATS2 VAS score.
Thank you. Now we conclude the session.
Thank you so much, sir. May I request our honorable chairpersons and the panelists to kindly present a memento as a token of appreciation to Dr. Jha. May I request Dr. D.S. Chadda to kindly come on stage. Requesting Dr. Vipin Kumar, Dr. UN Singh and Dr. Mrinal Kanti Das. So request you to kindly come on stage and accept this as a token of our love and appreciation for your wonderful presentations. We once again thank you for your presence here. Yes, please. To Dr. D.S. Chadda. To Dr. Vipin. To Dr. UN Singh. To Dr. Mrinal Kanti Das. To Dr. Das. Thank you so much, everyone, once again, for your honorable presence on the dais. Moving on to the next, for the third session on coronary artery disease, may I request the following dignitaries to kindly come on stage as the chairpersons, requesting the presence of Dr. R.P. Srivastav, past Secretary CSI and Senior Consultant Physician and Cardiologist from Patna and Sivan. Requesting Dr. Poonam Kumari, Associate Professor, Cardiac Anesthesia, AIIMS Patna, to kindly come on stage and join us as the chairperson. Requesting Dr. Rajiv Ranjan, Senior Consultant Physician and Cardiologist from Chhapra, to kindly join us. Requesting the presence of Dr. Ashutosh Kumar Sinha, Senior Consultant Physician from Patna. My apologies, Senior Consultant Physician from Sivan, to please join us as the chairperson. Requesting the presence of Dr. E. Haq, Senior Consultant Cardiologist from Patna. Requesting the presence of Dr. Pragati Kapoor, Senior Cardiothoracic Surgeon from AIIMS Patna. Ma'am, could you please join us as the chairperson? Also requesting Dr. Abhinav Bhagat to please join us for this session. Dr. Abhinav Bhagat. Requesting Dr. Jayamala Kamal from IGIC Patna. Ma'am, could you please join us for the session? I guess she is not available. Okay. Now for the panelists, may I have the following esteemed dignitaries on the stage. Dr. Nishant Kumar Abhishek, who is an interventional cardiologist from IGIC Patna. Dr. Nitish Kumar Ranjan, Senior Interventional Cardiologist from IGIC Patna. Dr. Bhanu Pratap Singh, Senior Consultant Physician from Sivan. And Dr. Amit Jaiswal, who is also a Senior Consultant Cardiologist from ARA. Sir, could you please join us on stage? We'll quickly begin the third session, which is on the coronary artery disease. There is a small reschedule of the sessions in this session. It may kindly be noted. Instead of Dr. Ashok, Dr. Soumitra will be starting the session and Dr. Ashok will be presenting in the last. So in the seriatim, Dr. Soumitra, Dr. Surendra, Dr. Chirag and Dr. Ashok. Dr. D.S. Chadda has already presented his presentation in the second session. Also, adhering to the guidelines and the timings of the session, we should not lag behind. I have just few requests. All the speakers will have 12 minutes for the presentation. 3 minutes could be kept for their question and answers and the comments, not to exceed that. Otherwise, we'll run short of time. Thank you so much. Hope to have a smooth endurance of the sessions. Over to you, sir.
Requesting Dr. Professor Soumitra Rai sir, please come. Sir is a consultant cardiologist at Woodlands Hospital, Kolkata. Sir, we welcome you to AIIMS Patna and to Patna to Cardicon. Thank you for coming.
He is also our executive committee member in Central CSI. A very prolific speaker. Give him a big hand.
Thank you. Thank you, Bihar Chapter of CSI. Thank you, AIIMS Bihar. Usually we do program in the Moria Hotel in Patna, and this is the first time in AIIMS. So it's a big change and it's a huge hall. So thank you all the chairpersons and the panelists. My talk today is exploring LDLC management challenges in very high-risk ASCVD patient. I'm a very small fish in the ocean of cardiologists. So I'll start in a very humble way, but I will end up with reference to the biggest whale existing in the cardiology field internationally. Indian real-world experience shows there is a huge unmet need for LDL goal that we know, and we are making our life tougher ourselves by reducing the goal from 70 to 50 to 30 to 20, what not. Dr. Das has very clearly explained that we should stop somewhere by reducing the goal more and more and increasing the frustration that we are not reaching the goal. But there is something realistic that 50-55 should be the goal for all secondary prevention, and only 20% of our eligible candidates reach or achieve that goal. I'll give you examples of 3 patients. One is a very young person, Mr. Abhay of 40 years, who is overweight, on atorvastatin and ezetimibe combination with controlled blood pressure, but LDLC is 154. Why is he taking this? Because he's a young, successful software engineer, he's very irregular lifestyle, has got hypertension, and he had non-STEMI and underwent a drug-eluting stent in his RCA. He's struggling to adhere to his treatment due to his busy schedule and professional demands. And of course, being an early successful executive, he doesn't think that doctors know much. Second is an elderly person, Mr. Ramesh. He is overweight. He's a retired banker and enjoys spending time with family. He is hypertensive and diabetic, reasonably controlled. 2 angioplasty over last 3 years. So recurrence of ischemic heart disease or acute coronary syndrome. And he is on rosuvastatin and evolocumab every 2 weeks. He can afford that. Blood pressure is still scope for control. LDLC is 80. We know it has to be at least below 55, if not 40 by European guideline. But his problem is too difficult to adhere to treatment due to the high treatment burden, because evolocumab twice a month is expensive, about 40,000 per month. And there's another lady, middle-aged lady. He is really overweight, obese. Kalpana is a trained classical dancer. I think she has stopped dancing, otherwise she won't have been obese. All dancers, when they stop dancing, they become obese. Now she is a teacher and she is obese, but she is still active. She has hypertension and obesity. She has experienced non-STEMI and underwent angioplasty, multivessel angioplasty, true stents. And she is on rosuvastatin, ezetimibe, pressure controlled. LDLC is far above the goal of 40 or 55. She is concerned about having another cardiovascular event. So there's different profile and walks of life people have come who are not satisfied with the treatment going on with them. And they are very high risk patient. Dr. Dash has very adequately explained it a few lectures back, that these are extremely high risk group, and there are categorization by CSI, extremely high risk, very high risk, and low risk. and the LDL target is accordingly 40, 55, 70 and 100. And we assume that non-HDLC should be 30 milligram higher, but it's not always true. If your VLDL is very high, your LDL non-HDLC gap is not 30, it could be 40, 50 or 60. So that is a common mistake we make. Guidelines unanimous in recommending aggressive lowering of LDLC level, and lower the better. Lower the better, and very important nowadays, as like smoking year, we are talking about cholesterol year. How many years you are living in your life with that high cholesterol? So you are living with 100 milligram LDL for 5 years, and you are living 200 milligram LDL with 5 years, and not the same. And 100 milligram with 5 years and 100 milligram with 10 years, again not the same. So we have to start treatment early. As quickly as possible, we need to achieve the goal. And the ESC guideline also, which is almost same to CSI guidelines, CSI has got certain Indianized insertion into that, which I think has been very finely explained by Dr. Dash before. I won't go into the details for lack of time. But what the ESC guideline is now well accepted, that we give for high dose statin, then ezetimibe. Bempedoic acid was not there in Europe at that time, so it was not included. Then we go for evolocumab and perhaps inclisiran. It was not there again at that time. So approach consideration based on 23 guideline, early escalation with combination therapy. So as soon as the patient comes, nowadays we don't waste time by increasing the dose of statin and see the effect of every 4 to 6 weeks. We give a combination, and usually the combination is the highest tolerated dose of statin with ezetimibe, and you keep the bempedoic acid in stock just to add as a third medicine. So if we see these patients, one is struggling because of non-compliance, he don't get time, one cannot afford, and one is skeptic about another event. So, and they don't, all of them don't achieve the LDL level. So long-term LDLC reduction leads to proportionally greater reduction in the lifetime risk. And this is a going on paper from Oxford by Dr. Kaushik Ray and groups, that this cholesterol year life is very important, total burden of cholesterol. So each millimole L reduction, that is about 40 milligram for Indian, about 40 milligram reduces the relative risk of ASCVD by 10% within first year, 16% within second year, 20% in third year, and 50% after 40 years of long treatment. So currently available lipid lowering treatment and upcoming novel therapy, we have the traditional therapy. Recent therapy are PCSK9 inhibitor, new therapies are bempedoic acid and inclisiran, and emerging therapies are gene-based. Combination therapy is needed to achieve lower LDL, and this is a very fantastic slide by ESC, what percentage you expect. So it's like mathematics. On day 1, if you see your LDL is 200 and your target is 50, you means you need to reduce 75%. Simple mathematics. If you are not savvy at that, just go to Google, they will calculate for you, or the calculator will calculate for you. And you know exactly from the chart what combination you need to achieve a 75% reduction. So this is very interesting. Though biology is not mathematics, but it is similar in as long as cholesterol is concerned. More intensive lipid lowering therapy associated with lower LDL and lower risk of MACE. So does it translate that lowering LDL actually translate into lowering MACE? Yes, it translates. There is no doubt in today's world. And early benefit, it has been shown that within a few months, the curves separate and become statistically significant. So you don't have to wait for 10 years to get the benefit. You actually can achieve very quick benefit. Early addition of PCSK9 inhibitor reduces mean LDL level within a month. That is the EVOPAX trial. And that is translated into clinical benefit. Cardiovascular outcomes with early initiation is improve IT. You see, though the reduction is modest, the p-value is 0.01. Still, I would say that if you see it's within 3 years, 4 years, it has become significant. So of course, it is not overnight. So there is always a controversy to what is happening within first 7 days with the lipid lowering therapy. I think it is still controversial, but still we push for aggressive treatment immediately for better compliance. That is also very important. The patient is captive at that time. And if you can achieve and show that, look, your cholesterol is 40 today, so she is more motivated and encouraged to stick to the medication. So that is also very important. Impact of PCSK9 inhibitor on patients with prior PCI at 48 weeks. And you have shown PCSK9 at the time of randomization, you reduce about 60% LDL. About 20% major coronary event is reduced. Additional PCI is reduced by 20%, 20% of de novo PCI, 25% of stented PCI. So in our cases, all these three cases, which of your patient can benefit from the addition of inclisiran? Now, evolocumab is there in the market for last 10 years. What about the inclisiran? Now, inclisiran is the Serina, small RNA. And you know, this time also there is a Nobel Prize in biology with similar line of investigation. So this is a very expanding field of to tackle with the RNA. This time the Nobel Prize went into microRNA. So RNA is now the focus of biology. Inclisiran benefits versus existing therapy. We call it encounter. Statin, you have 365 encounter. On leap year, 366 encounters. PCSK9, 26 encounters. Inclisiran, 2 encounter. So if the encounter is less, the chance of facing that encounter is much, much more. You are much more likely to stick to 2 injections a day rather than 365 tablets, 2 injections a year rather than 365 tablets a year. So that is very, very important for compliance. And you know, there is almost 60% fall of cholesterol after the first injection of inclisiran. And Orion 19, there are multiple Orion trials which showed the safety and the reduction of MACE, as well as benefit and as well as the safety, both have been now established. Efficacy, as you see, 80% patient achieved their target. Orion 8 showed a favorable safety profile. And 2 doses a year, maybe even 1 dose a year. So what does the addition of inclisiran mean for patient is this. 1, it is cost effective. It is less cumbersome for a busy person. And it ensures that your LDL is there. So all the 3 purposes served. And this is our CSI own guideline of acute coronary syndrome. Very important is do a non-fasting lipid. This is very, very important. Do a random lipid profile. Don't wait for next day morning. And then you see accordingly we have given it. It has already been shown. So key takeaways is ACS patients like we have seen, very high risk patient. Goal is at least below 55. PCSK9 and high intensity statin is now established. Inclisiran is now coming up. And I will end with the whale, the giant I was talking about, and what he said. Not a small fish like me. It was in 2018 in Munich, Germany, ESC, and I was privileged to actually witness this speech of Braunwald. CAD remains the most important arterial disorder responsible for an enormous number of deaths and morbidity. So it almost goes without saying that efforts to reduce its incidence are incredibly important. I can see advances in the 3 main areas, each a soldier in the battle against CAD, that will really improve the way we go about tackling this disorder. He went on saying, the first approach concerns the development of non-invasive coronary artery imaging. Dr. Chadda was exploring that a few lectures back. The second area is the use of genomics to ascertain and define the risk of CAD with greater precision. The last approach, which in my opinion, Braunwald's opinion, is the most interesting, has to do with new drugs developed. PCSK9 inhibitor has attracted great attention, but need to be injected every 2 to 4 weeks and very expensive. Scientists have now developed a new drug, inclisiran. The real advantage to be administered only every 6 months or even yearly to lower cholesterol. Then you read what he is saying. I would propose that such a drug be administered on a regular once or twice yearly basis to everyone over the age of 30 years. It's not coming from me or CSI. This approach would have a profound effect on reducing the development of CAD in population. The cost of delivering such a drug would be outweighed by the reduction in healthcare costs associated with treating people with established coronary artery disease. The future for CAD prevention and management is bright. And then after the chat session, he said, perhaps you cardiologists will lose your job and all the cath labs will be closed because there will be no CAD. Thank you.
Thank you, sir. Just this side. You spoke a lot about LDL. We have a lot of diabetic population undergoing acute coronary syndrome and PCI. So what level you see for triglyceride? How much we should give the level?
Look, we are focused on LDL cholesterol because that perhaps accounts for 95% of atherosclerosis. But we have non-LDL cholesterol, non-HDL cholesterol, which includes a VLDL, IDL, triglyceride, chylomicron. So triglyceride is coming and going. HDL is coming and going. Nowadays we are thinking again HDL. And I would also say, if your cholesterol is 40, LDL 40, and you are still having coronaries, don't rather push LDL further down. You look into other things you are missing. Whether you are missing a homocysteine, whether you are missing factor V Leiden, whether you are missing protein C, protein S, whether you are missing something else. So we sometimes gets very myopic about LDL cholesterol. So my view is that with a reasonably down LDL, if you have recurrence, you look into other non-LDL particle as well as non-lipid risk factors, which are important in diabetes.
What level of TG we should keep?
TG I think 150 is still standard. Somebody says 130. But 150 should be the target.
We have to keep below 150.
Below 150, yes, 150. For diabetic, 150. Absolutely.
Thank you, sir, for this. And I think we'll take up the other questions during the lunchtime. Thank you, sir.
Thank you. Thank you.
Next speaker is Dr. Surendra Devra. Requesting Dr. Devra to come and deliver his lecture on post-PCI antiplatelet therapy, SAPT or DAPT. Sir is Associate Professor, Additional Professor at AIIMS, Jodhpur. Welcome to Patna, sir.
Thank you. Very good afternoon to all of you. I am thankful to Chairpersons, CSI Bihar Chapter and Dr. Anupam for inviting me to deliver talk on post-PCI antiplatelet therapy. Single antiplatelet, short DAPT, these now the things are going on continuously in the research field. So I will start from how the antiplatelets came, how it started in patients of coronary artery disease, then how the concept of short DAPT arise, then initially it was tried in high bleeding risk patients, then now it is being tried in all comers patients, and what are the current guidelines which are there. Next slide, please. So the first mention of use of salicylic acid in coronary thrombosis was by the Paul Gibson, which was published in the Lancet. And since this 1950, this paper was there, aspirin was used in all patients of coronary artery disease till we reached PCI of doing managing these patients. So in the PCI, two landmarks were there. First was the coronary balloon angioplasty by Grundzig and the first coronary stenting by the Jacques Puel. Then the use of BMS was quite often, but there was a restenosis of around 30%. Then first generation of DES came. They also had some problems. Then newer generation of DES, what we are using with thinner stents and polymer free. Now how the DAPT started actually. So this is the timeline where the dual antiplatelets were started, and there were two focuses. One was strategies which were focusing on the ischemic events. This was the earlier part when the first generation of DES were used. Then gradually when the DES technology has improved, then the focus was shifting towards the reducing the bleeding events. So now most of the trials are focused on shortening of the DAPT, de-escalation of the DAPT, or aspirin free. Then initially when the bare metal stent was used, there was need for, because of high restenosis, there was a need for to increase the anticoagulation. So initially complex regimens were used, aspirin, dipyridamole with heparin and then warfarin. So during the early era of the stenting, warfarin was used along with the aspirin for initial 1 to 3 months. But the problem was that it was associated with a high major bleeding and vascular complications. So then gradually the second antiplatelet P2Y12 inhibitors were used. Now what we have seen earlier was the use of ticlopidine, which was the first generation thienopyridine, then followed by clopidogrel. But ticlopidine, clopidogrel, the problem with the clopidogrel was it has a variable effect. So in the last 1 decade, we are using prasugrel and ticagrelor in patients of post-PCI. Ticlopidine had a problems with the GI and hematological side effects, and similarly the clopidogrel, because of its delayed onset and resistance, variable response in many group of patients. So it was also not means it was replaced by prasugrel and ticagrelor. And these trials we all know about Triton, TIMI 38 and Plateau. Now the duration of the DAPT. As I said earlier, because in the mid 2000s and early 2010, with the first generation of the drug-eluting stents, because there was increase in the late stent thrombosis because of the delayed healing, because of the drug-eluting stents. So there was an intensification of the DAPT. So in the first century, first 10 years of this century, there was an intensification of the DAPT. But since the 2010, because of the improved DES technology, because of use of inert fluoropolymers, strut thickness less, or polymer-free stents also, the emphasis was on short DAPT and now on very short DAPT also. So approach to DAPT should, first we should always think of ischemic risk factors and bleeding risk factors, then risk stratifications by various scores, and then if according to that we should go further. So risk stratification tools, we have many scores, but Academic Research Consortium ARC bleeding score is well approved. It has been, this white paper was published in circulation in 2019. This ARC score was validated in more than 10,000 of patients, and it has one, if you have one major or two minor criteria, the patient is in high bleeding risk, and if the patient is in high bleeding risk, there is a threefold increase in the risk of bleeding, and it increases the rate of mortality, increased rate of 1 year mortality. Even if the patient is stepwise, there is increase, if the ARC is increasing, if it is one time increasing, twofold increased risk of bleeding, and if it is 4 time, then 12-fold increase in risk of bleeding. So there is a method that by ARC you can find out whether the patients are in the high bleeding risk group or not. So how to manage these patients of high bleeding risk? HBR patients, initially it was dealt with in a bare metal stents with a short DAPT. If you are suspecting that your patient is going to bleed, initially bare metal stents were deployed. But now it has been proved, 3 randomized trials which has compared DES with the BMS for these patients of high bleeding risk. So these are the 3 trials which has compared bare metal stents with drug-eluting stents. The leaders free trial, we all know about the BioLimus polymer-free stents by biosensors. Then it was a sub-study of Zeus study. Both were in 2015, it were published, and they have adequate number of patients with ACS also. The senior trials, which was in more than 75 years of patients, they have used 1 to 6 months of DAPT, and it has also 50% of ACS patients. So all these trials have shown that DES has performed better than BMS in patients with high bleeding risk and 1 month DAPT. Then very short DAPT, it means less than 1 month. So we have till now 6 trials which have been published. All were superiority, inferiority, non-inferiority trials with regard to ischemic and bleeding outcomes. And because many of these trials were published after 2020, they have not been incorporated in the guidelines. And the control patients in almost all of these trials were from the earlier trials, the earlier standard trials. So they have compared it with those patients. So these 6 trials are the leaders free trial, which part 2 which was published in 2020, again with the stents of polymer free from biosensors. And then Onyx group of stents, they have published their data in 2020. Then Zymes short DAPT program, where they have used the Zymes stent. SkyPoint stent was there, Zymes SkyPoint. Then Master DAPT with Terumo, from Terumo. Ultimaster stent was used, and then Poem in 2022, which was Synergy. So Synergy and Ultimasters have bioabsorbable polymers, and almost all of the problem, ACS patients were adequately there in these trials, but STEMI patients were very less, and in the Zymes short DAPT program, almost no patients were there from STEMI group. But you can see around 12% patients in Master DAPT program, they were STEMI group. So then, after high bleeding risk, these were the trials in patients, those who had a high risk of bleeding. The short DAPT then was tried in all comers patients. Now, all patients who are coming for PCI, they have attempted a short DAPT. So, before the 2018, all stable ischemic heart disease patients, they have been found to be significant benefit with short DAPT of around 6 months, and that's why the guidelines now recommend 6 months of DAPT in a stable ischemic heart disease patients who have undergone PCI. But after 2018, 8 additional trials of DAPT have been there with a 3 or 1 month of DAPT, in which 2 trials were there with aspirin monotherapy once you stop DAPT, and 6 trials were there with P2Y12 inhibitor, clopidogrel, ticagrelor or prasugrel. So these are the total trials, 8 trials. With the, you can see almost all of these trials have a STEMI population also, but Twilight, which was a very famous trial published in NEJM in 2019, with ticagrelor, it has no patients with STEMI. So 1 month DAPT trial, patients P2Y12 inhibitors, global leaders, stop DAPT2, stop DAPT2 ACS. Now almost the global leaders and stop DAPT2 ACS both were negative trials. Means it has, the global leader trials was a superiority design trial, and it has not shown benefit with short DAPT. And stop DAPT2 ACS was a non-inferiority design with clopidogrel. Again, it has not shown any benefit with 1 month DAPT. 3 month DAPT trials were Smart Choice, Twilight and TICO trial, and almost all of them have shown a positive results. Means like Smart Choice, it was a non-inferiority design. P2Y12 inhibitor was used as clopidogrel once you stop a DAPT, and it was non-inferior to standard practice. Similarly, in Twilight, it was a superiority design trial. Ticagrelor was found to be, use of ticagrelor after this was found to be superior. Similarly, TICO trial was also there. So this was a meta-analysis which was published this month only. So about the short-term dual antiplatelet, and what this meta-analysis has concluded that 1 month of DAPT followed by potent P2Y12 like prasugrel and ticagrelor is associated with reduction in the MACE when compared with 12-month DAPT, but they have advised for 3-month DAPT followed by prasugrel or ticagrelor as the best option if you want to reduce MACE. And because most patients in these trials have received ticagrelor, the safety of stopping aspirin in those taking clopidogrel remains unclear. So what these trials have suggested is use of ticagrelor once you stop a DAPT. What the guidelines says? Guidelines, they say still the class 1 indication for stable ischemic heart disease patient, it is a class 1 indication, and in ACS patient it is a, for 12 months you have to give DAPT, it is a class 1 indication. You can stop at around 3 months, which is a class 2A indication in both stable and ACS patients, but in high risk bleeding patients it is a 2B indication of stopping DAPT. And similarly, if you look at the ESA guidelines in ACC says it is a 2B indication, and ESC says it is a 2A indication. The stents which have been approved by FDA is the Zymes group of stents and Resolus Onyx, especially Zymes SkyPoint stent was there. So they have been approved for 1 month DAPT. So this is about the ESC. It has a class 2A indication in a high bleeding risk patient if you want to stop it. So these are the guidelines which have been a short DAPT. So in summary, ACC HA says it is a class 2B indication still if you want to use a short DAPT, and ESC says it is a 2A indication. Thank you very much.
Hello. Thank you, sir, for your nice presentation. Can we take one or two questions?
Yeah, please.
Thank you so much.
Sir? After 1 year it is, if the after 1 year if the patient
Post ACS or chronic stable angina, which drug you are preferring?
So after ACS, use of a single antiplatelet has been advised. It is a class 2 indication. Use of DAPT is a 2B indication. So if the patient, because it has to be tailored according to the complexity of the case, individual case has to be, because if the multiple stents have been used, diabetic patients, LV dysfunction patients, complex coronary, high syntax score, DAPT can be used. But it's a class 2B indication.
Thank you so much, sir. May I request our honorable chairpersons and the panelists to kindly hand over the memento to Dr. S. Deora as he has his flight to catch. Also requesting the presence of Dr. Soumitra. Request Dr. Soumitra Ray to kindly come on stage.
May I request Arvind sir and Sanjeev sir to please join us on stage with the former office bearers of National CSI on stage.
To Dr. Soumitra. Thank you so much, sir, for your kind presence. We are honored to have you here. Thank you so much, sir. Now we'll continue with the rest of the speakers in the session. May I request Dr. Rajiv Ranjan, Senior Consultant Physician and Cardiologist from Chhapra. Sir, could you please join us for this session to chair the session? Dr. Rajiv Ranjan from Chhapra. All the chairpersons, we request you to kindly stay back as we have two other speakers in the session. This session has yet not been concluded. I'm sorry for the confusion. Since Dr. Deora had a flight to catch, so we had to present the memento. Requesting all the existing chairpersons for the session third to continue. Additionally, I would request Dr. Rajiv Ranjan from Chhapra, if you are around, could you please join us for the session? Okay, so we'll continue as scheduled. The third speaker is Dr. Chirag Parekh, followed by Dr. Ashok Kumar. Over to you, sir and madam. Thank you. Dr. Chirag Parekh.
Welcome Dr. Chirag to Patna. He will be speaking on role of intracoronary imaging in PCI for bifurcation region.
Good afternoon, everybody. It's a pre-lunch session, so I will not take much time. Thank you to the organizers for the kind invitation. I will be speaking on the role of intracoronary imaging in PCI for bifurcation lesions. So these are my disclosures. So why this topic was assigned to me? Because coronary bifurcation lesions are very common and they account for about 15 to 20% of all PCI. The common bifurcation lesions which we encounter in our practice are the left main LAD, LCX bifurcation, the LAD diagonal bifurcation, circumflex OM, and PD-PLV bifurcations. And these bifurcations provide additional challenges as compared to a regular PCI. The stenting procedure for a bifurcation PCI can vary from a simple crossover provisional stenting to complex two stents procedures which can be done in multiple techniques like Coulott, decay crush, mini crush. And these two imaging modalities, that is the IVUS and the OCT, they play a pivotal role in optimizing the results. So why angiography is not sufficient in doing bifurcation PCI is because angiography is limited in providing the information in bifurcation lesions, and that is due to multifactorial reasons, due to overlapping of the branches and due to the tapering in the vessel size. So I will be discussing 10 points about why bifurcation is important in imaging is important in bifurcation lesions. The first part is before stenting. So Dr. Chadda was also stressing on this, that whenever we are opening the imaging catheter, we must make full use of it, and we must do imaging before stenting, during stenting and after stenting. So this is an 49-year-old male who has come with positive stress test, and you can see his angiography showing a very critical ostial left main stenosis, and there is another significant stenosis in the proximal circumflex. So angiographically, the bifurcation lesions are classified by Medina classification, wherein the proximal main vessel, the distal main vessel and the side branch are given 1 score or 0 score, depending on if there is a more than 50% or less than 50% stenosis. So this left main bifurcation lesion is actually on angiography, it's a 100, because only the ostial left main is involved, the LAD and circumflex are not involved. So the plan for this patient would be to do a focal stenting of the ostial left main and another short stent in the circumflex. But when we do an imaging run, which is IVUS from the circumflex, we can see that there is a start of the plaque which is already happening, and this plaque is contiguous all along the length of the circumflex, and when we measure the lumen areas at the ostium of the circumflex, it is only 3.8 mm square, and that is significantly narrowed, and the plaque burden at the ostium is 67%. So that means that angiography was not showing this plaque in the circumflex ostium, and actually what appeared as a Medina 100 is a 101 stenosis, and the stenting strategy will completely change. We will need to now stent from the left main into the circumflex using inverted provisional technique. So this is very beautifully illustrated by Dr. Gary Mintz in the EBC consensus paper, where he actually says that it is very rare that the plaque will be present just in the proximal vessel. It is very common in almost 65% of cases that the plaque will extend both into the side branch and into the main branch. There are other patterns of distribution, and it is very important that in the last line, actually this is, the pointer is not working. This one. So if you see in the last line, the Medina 000, which means angiographically the stenosis is less than 50% in all the branches, still the plaque burden is present in almost 50% on imaging. So we are grossly underestimating the plaque distribution in bifurcation lesions on angiography. The next thing where imaging will help is to decide whether it actually needs stenting or not. So FFR still remains the gold standard in predicting myocardial ischemia, but if the left main IVUS is more than 6 mm square, then we can very safely leave this, and this has been proved by multiple studies. The third thing where imaging will help us is to understand the morphology of the plaque. So bifurcation lesions are very prone for developing an increased fibrous load and an increased calcific load because of the shear stress. And as Dr. Chadda explained in his lectures, we have multiple tools which are balloons, atherectomy and IVL. So which tool should be used for which patient will also be guided by the imaging. So this is an 81-year-old patient who has come with an NSTEMI Wellens, and you can see he has got a critical calcific stenosis in the ostial LAD, and there is an extension of plaque in the distal left main. So angiographically this is a Medina 110 calcific stenosis. And when we do the IVUS pullback from the LAD into the left main, you can appreciate this heavy burden of calcium starting from the proximal LAD, and at the ostium of the LAD, as we come back, there is a 360-degree concentric arc of calcium. And this calcium is present over a very short segment of the LAD. So these cases are actually ideal for intravascular lithotripsy, where there is a 360-degree calcium. It is present in a localized segment of the vessel. So this patient was treated with a 3O IVL balloon and then provisional stenting from the left main into the LAD. This is a very young patient. He is a 41-year-old who has come with anterior MI, who received thrombolysis, and you can see he has got a very critical ostial LAD stenosis. Now we are going to put a stent from the left main into the LAD in a 41-year-old, so we need to give the perfect result. And when we do the imaging, the IVAS run from the LAD into the left main, we can actually visualize the fibrous plaque and we can visualize the TICFA, which is seen as a hypodense region here with the lipid content. And that is what has ruptured, led to the plaque rupture and led to the ACS. So imaging is helping us to identify the morphology of the lesion. The fourth thing where imaging is going to help us is to size our stents and balloons. So in a bifurcation, the vessel is tapering. So it's not going to be the same size vessel proximally and distally. So first thing which we need to do is we need to measure the vessel size in the distal vessel, and we have to size the stent based on this. Also we need to measure the size of the balloon. So in the previous case, the distal reference was 2.5 millimeters. Then we need to measure the proximal landing, which is in the left main, which is the pot balloon. And then we need to measure the stent length. Now it is very important because in this case, the left main is 5.5 millimeters and the distal LAD is 2.5 millimeters. One stent is not going to expand. A 2.5 millimeter stent cannot go to 5.5 millimeters. So we are going to need two stents. Secondly, we need to identify the length of the stent which is going to be used. And in a two-stent strategy or in a crossover stenting, if we are planning to do the kissing balloon inflation, then we need to measure the size of the balloons in the LAD and the circumflex. So in this case, the distal reference was 2.5, pot is 5.5, proximal LAD is 4, and circumflex is 3 millimeters. So all this information we are getting on just one IVAS run. And this is the latest thing which is now available, where we can actually co-register the angiography with the imaging. So we know exactly at what point in the angiography the imaging is being done. And in this we can also measure the length. So in this patient we measured that the length of the lesion is going to be 56 millimeters. So we ended up putting a 2.538 stent and then a 3.520 stent. And we can also measure the length of the pot balloon, which is 13 millimeters. So imaging is helping us to size the stent, to size the balloons. The fifth thing where imaging is helping us is to predict the side branch occlusion. So this may be a spotter in your quiz. This is very common. This is known as the eyebrow sign on IVAS. And if this is present, then there is a high likelihood of shifting of this carina into the side branch and causing a obstruction of the side branch. And on OCT, there are parameters like the CT angle if it is less than 50 degrees, so narrow angle bifurcations, or if the measurement is less than 1.7, then this predicts the occlusion of the side branch. So this is a 63-year-old lady, it's a circumflex OM bifurcation, and when we do the IVAS run, we can see that there is a very high plaque burden at the level of the bifurcation, and this is very beautifully seen on the longitudinal view, where we can see that there is a plaque at the bifurcation, at the carina. And presence of plaque at the carina causes plaque shift, and when we put a stent in this patient, we lost the side branch, and that had to be bailed out by putting a second stent. So it is always important to see not only the cross-sectional views, but to also see the longitudinal views. Now once we have put the stent, then again imaging helps us. The first thing where imaging helps us is to cross the optimal stent, optimal cell of the stent. So whenever we are doing a provisional strategy, we want to cross through the distal stent. So where OCT is very useful in this. When we do the 3D OCT reconstruction, we can beautifully see that in this case, the wire is going through the proximal cell. So we rewire and we go through the distal cell. This is also possible on IVAS, but it is a little tricky, wherein we need to do a pullback from the distal main vessel into the proximal main vessel. And we can see that if the side branch wire is entering in the proximal frames or in the later frames. So it is possible on IVAS, but it is very easily seen on 3D OCT. The next thing is, after we have put the stents, we must assess for post-stent complications. So the three common complications are stent malapposition, tissue prolapse, stent dissection. So dissection is significant if it is more than 60 degrees, if the length is more than 3 millimeters, or if it causes a luminal obstruction. In this case, we must cover it with another stent. So this is a patient who had undergone a primary PCI to the RCA and who has now again got a ostial LAD lesion, and he underwent a PCI from the LAD into the left main, followed by a distal recross and a kissing balloon inflation. After the kissing balloon inflation, patient started complaining of chest pain. The angiography did not show anything, but when we do the OCT run, we are pulling back the catheter from the LAD into the left main. We can actually appreciate that there is a big dissection at the ostium of the circumflex, which is not very visible on the initial angiographic shoots. So when we come to the ostium of the circumflex here, you can see the dissection which is seen here, and that is extending downwards, and that later became apparent on the angiography, and then it had to be bailed out by putting another stent using a tap technique. The next thing we need to do is to look for stent expansion. So after the Excel criteria, it is now well defined that we need to aim for these targets where we need a ostial LAD MSA of at least 7, circ of 6, and a left main of more than 10. So it is very important that we post-dilate with bigger balloons or go at higher pressures if we are not able to reach these areas. Stent apposition is very important in a bifurcation lesion, especially in the proximal main vessel, because if your stent is not well opposed to the vessel wall, there is going to be a space. And when you recross to do the kissing balloon inflation, this wire may go between the vessel wall and the stent, that it may be abluminal wiring, and that can lead to stent deformation, and that is associated with poorer outcomes. So doing a pot with a properly sized balloon is very important to prevent stent malapposition. So after doing all this, we are spending so much time, we are spending additional cost. Does it actually improve outcomes? So now we have conclusive proof that image-guided bifurcation PCI actually improves outcomes both with IVUS in the left main and non-left main, and also now with the October trial with the OCT, where they compare...
Dr. Chirag, please conclude in 2 slides.
Yeah, this is my last slide, ma'am. With the OCT, where the angiography versus OCT-guided bifurcation PCI, the image-guided bifurcation had significantly reduced MACE rate. So to summarize, whenever we are doing imaging in a bifurcation lesion, we have to assess the plaque composition and the plaque distribution. We have to assess for the plaque morphology. We have to identify the landing zones, not just in the length, but also in the diameters. We have to size the balloons, that is the pot balloon, the distal optimization balloon, and the kissing balloon based on imaging. We have to assess the risk of side branch occlusion. And in post-stenting, we have to use imaging for optimal rewiring to detect post-stent complications like dissections, malappositions, and underexpansion, and also to rule out any side branch complications. Thank you so much. If there are any questions.
Thank you, Dr. Chirag. Such a wonderful presentation. Any questions from audience side? Any questions? Okay, thank you.
We'll call the next speaker, ma'am. May I request Dr. Ashok Kumar, Director Cardiology, SDNA Arogyam, for his presentation.
Good afternoon, respected chairperson, panelists, and august audience. So, without wasting much time, as Dr. Deora has already made the platform for my talk of discussion is antiplatelet therapy expecting a radical change? Subcutaneous or parenteral P2Y12 inhibitor, GP2B3A inhibitor, and GP6 inhibitor. So, my topic will be confined in this following subheading. I will like to go with the case, hypothetical case per se. So this is a 72-year-old woman having history of peripheral arterial disease and diabetes with diffuse T-wave changes and having chest pain intermittent. And she was treated with aspirin by emergency medical staff. And then question arises, should we start a P2Y12 inhibitor or not? coming to the pre-treatment expert analysis, in particularly anastomy, routine pre-treatment is not recommended. And why so? Because about 12% of patients land up in CABG, and nowadays, even in our own practice, we have most potent antiplatelet in forms of prasugrel that is also being advocated to give on the table after seeing the coronary anatomy. So in this scenario, it is always better to wait for giving antiplatelet therapy. So consideration for the antiplatelet therapy: high suspicious of diffuse severe disease, patient will be taken directly to cath lab, and we will give, if required, Cangrelor, that is IV P2Y12 inhibitor or GP2V3 inhibitor. So patient was not treated with additional antiplatelet, and angiogram was done. If the PCI is next step, then problem arises again, because we have to give potent antithrombotic therapy. So here we need potent, rapidly acting, as well as short acting therapy also. So what are the benefit and drawback of pre-treatment with antiplatelet therapy? So benefit are many, because we are using since last many years giving pre-treatment with clopidogrel. So it reduces pre-procedural MI, early stent thrombosis incidence less, and having ischemic event less when waiting for invasive management, as well as need for bail out GP2B3 inhibitor requirement is very less. But there are certain disadvantages in forms of risk of bleeding and periprocedural bleeding, and it increases the number of days of hospitalization. So assessment of coronary anatomy before administration of P2Y12 inhibitor appears to be the most reasonable strategy in ACS setting. And Dr. Deora has already mentioned, but in this slide, I would like to emphasize mainly on Cangrelor. Why so? Because among all oral or as well as IV GP2B3 inhibitor, Cangrelor is reversible, IV use, and having immediate onset of actions with shorter duration of effect, and its effect fed up within 30 minutes to 60 minutes, and half-life is very short. So we can use and we can switch to the other oral antiplatelet agent during course of therapy, and we can immediately achieve the platelet inhibition with IV Cangrelor. So in clinical practice, at present, Cangrelor is the best suited options, particularly in sick ACH patients. So now reversible agent could solve the problem. These are the champion trial, and in this champion trial, clopidogrel has proven this his credential irrespective of GPI inhibitor. GP inhibitor used treatment with Cangrelor reduces ischemic complication, 48-hour randomization in patient undergoing PCI. So now coming to the case proper. Patient was trials to surgery, so she did not receive additional antiplatelet therapy, and PCI was not done due to high likelihood of disease based on the therapy. Now, why so? These are the mechanism of actions. Delayed onset and delayed GI absorption, particularly in when the patients came with cardiogenic shock. So now in our practice we have two options, ticagrelor and Cangrelor. These both are direct acting, but ticagrelor requires intestinal absorption. So it requires about 30 minutes to 1 hour for its inhibition of platelet by more than 50%, whereas Cangrelor acts immediately. But prasugrel and clopidogrel, being prasugrel is most potent, but it requires intestinal absorption, it requires hepatic metabolism, because these are prodrugs and it takes some time. So delayed onset of oral P2Y inhibitor, that's why we are looking for more rapid, more faster antiplatelets therapy. So these are data from Cameo registry, and I would like to skip. Yeah. Transition from IV to oral P2Y12 inhibitor is very easy with Cangrelor. clopidogrel and prasugrel are active metabolites cannot bind to P2Y12 with cangrelor. So avoid to use with cangrelor and start these clopidogrel or prasugrel just after stopping the infusion of cangrelor. But that is not the case with ticagrelor. We can start ticagrelor because its binding is not affected by cangrelor. So even in continuing injection of cangrelor, we can start ticagrelor. So the main indications are adjunct to PCI for reducing the risk of periprocedural MI, repeat coronary revascularization and stent thrombosis in patient in whom have not been treated with P2Y12 inhibitor and are not being given GPI. Dose is a bit simple. We have to load with 30 microgram per kg IV bolus followed by 4 microgram per kg per minute infusion for at least 2 hours. And if we require for switching or bridging for surgery, we can use even a lesser dose, 0.75 microgram per kg per minute IV cangrelor. So now I would like to scap. These are the guidelines. Okay. So yeah. So intravenous antiplatelet therapy can improve outcome in acute MI. Protocol should be established for facilitate effective use of cangrelor in acute MI, including all key stakeholders in developing protocol. In general, do not preload patients with acute MI who are going directly for PCI. So these are the advantages of cangrelor because it has short half-life, potent platelet inhibition, CKD friendly, and yeah. Now coming to some newer or upcoming antiplatelet. Why there are certain unmet need for STEMI? Because rapid reperfusion is the key to reducing infarct size and improving outcome in patients with STEMI. Oral P2Y12 inhibitor have a delayed onset of action, whereas the intravenous administration of GP inhibitor is inconvenient in the pre-hospital setting. So intravenous GPI also have a long duration of effect. If we are switching to the CABG, it will create a problem. So ideally there would be an agent that provides rapid platelet inhibition but does not last too long. So it does not interact with the oral P2Y12 inhibitor, which take effect within about 2 to 4 hours. So answer is RUC4. This is the code name of Jalunfiban. And phase 3 trial Celebrate is going on. In future, in upcoming 1 to 2 years, we will see the result of Jalunfiban. Is a novel investigational second generation glycoprotein TB3A inhibitor that has potent and broad antiplatelet activity when given subcutaneously. It essentially blocks the platelet from aggregating in less than 15 minutes, thus preventing further platelet mitigated clotting. And if we have to switch to other therapy, we can stop. We all know that 8 lakhs heart attack occur each year. It can take 1 hour to get to the hospital, whereas 50% of heart attack death occur prior to reaching the hospital. And this Jalunfiban has rapid onset within 15 minutes and quick offset. So it's fed off within 4 hours. These are the antiplatelet in pipeline. There are many targets that has been taken care. In recent past, we've seen Vadopaxar, but that was not come in our market due to increased intracranial bleeding and all. But in future, there are certain things like GP6 collagen interaction targeting molecules, and there are certain GP2B3A inhibitor is coming in market. And one more important thing, that is P2Y12 inhibitor, we will see in coming future as subcutaneous. So this is the glycoprotein 6 targeting is the major collagen receptor on platelet, and it inhibits binding of platelet to the nascent collagen or exposed collagen. That's why it doesn't interfere with the function of the platelet, and it does not directly binds to platelet. So there are less chance of reduction in platelet activity and less chances of thrombocytopenia. There are certain other molecule in forms of nanobodies that has been in investigation to target the GP6, whereas glengosumab, and that is being used mainly in stroke patients, and this is Fab-binding monoclonal antibody. And AIIMS trial has shown its promising result in stroke, but even in a phase 1, phase 2 trial, we don't have seen any phase 3 trial with this molecule. And this molecule has also been used, glengosumab, on and above aspirin and ticagrelor, hoping the additional beneficial effect without much increase in bleeding. So, and we don't have any trial of this molecule in ACS right now. This is the newer hope to us, selatogrel. This is new P2Y12 antagonist. It's a selective, potent, and reversible platelet P2Y12 antagonist with the advantage of subcutaneous administration, allowing self-dosing, and uses in the emergency setting for ACS, even in unconscious patients. A phase 3 clinical trial is ongoing. We will see result in coming future, and there are certain other highly potent is being investigated, but the trial of selatogrel is being done. And most problem with this molecule is the trial is being in general population, and asking the patient to self-medicate this molecule when they have 2 or more sign and symptom of heart failure. That has been already been doing in some European country. So again, I think this selatogrel will be game changer if phase 3 trial passes. And I think thanks, and I would like to give a special thank to my friend Dr. Abhinav, Dr. Satyajit Singh, and Jyoti Mukherjee. They have helped in making these slides. Thank you.
Thank you, sir, for such an enlightening and holistic and futuristic presentation that you enlightened us and helped us actually make our clinical guidelines. Sir, actually, as a senior, I like to extend thanks and ask you 2 of my personal queries, not totally being questions. So my personal queries to Ashok sir would be that what are the clinical indications of prolonging dual antiplatelet therapies in a patient, and how comfortable you are prolonging your dual antiplatelet therapy? And secondly, how you gauge the presence of convalescent hemorrhagic spots in discontinuing from that platelet therapy in your patients in clinical practice?
Actually, your queries has been already answered by Dr. Surendra Deora. They have already answered, like there is 2 apps. First thing is to go precise DAPT, and another is stop DAPT. So you can just calculate the risk. If the risk of bleeding is high, you can stop early dual antiplatelet therapy. And if the ischemic risk is high and bleeding risk is low, you can continue DAPT for long. So 30 months. Yeah.
Thank you, Ashok sir.
Second was how you actually gauge discontinuing dual antiplatelet therapy within the targeted time period, like within 6 months in a SIHT or within 1 year in an ACS background, when the patient repeatedly confronts you in clinic with convalescent hemorrhagic spots, like they are coming. Hemorrhagic spots,
actually, ecchymosis is not a major problem. What we see in newer stent, what we are using in our clinical practice, we particularly not in ACS patient. In CCS, we continue it for 1 month or 3 months. If there is large ecchymotic patches, then we stop aspirin and continue with ticagrelor. But in ACS, we try to continue even in all arms at least for 1 year. Only then we, if there is bleeding, then we can stop after 6 months. But if there is no obvious bleeding or no major risk of bleeding, it is always better to continue for at least 1 year dual antiplatelet therapy in ACS cases. But scenario is different in stable angina cases. We can stop even after 1 month. We can change to dual to single antiplatelet therapy without any problem.
Thank you, sir. Thank you once again.
Thank you, Ashok sir.
Thank you so much, sir. May I request our honorable chairpersons and the panelists to present the memento to Dr. Ashok? Also requesting Dr. Chirag Parekh to kindly come on stage. Now coming to almost the end of the Cardicon, to the fourth session of the day. That's Potpourri. May I request our honorable chairpersons to kindly join us on stage, requesting the presence of Dr. U.C. Samal sir, ex-president CSI Bihar. Sir, could you please join us and accept to chair the session? Dr. Ashok Kumar from PMCH Patna. Sir, could you please humbly accept to chair the session? Dr. Jyoti Ranjan Pandey, who's physician from Patna. Sir, could you please join us? Dr. Ram Sagar Roy from Patna. Sir, could you please join us? Requesting the presence of Dr. D.K. Singh, who's from ex-IGIC Patna. Also requesting the presence of Dr. U.C. Jha, head of the Department of Medicine, DMCH Darbhanga, to please join us to chair the session. Requesting Dr. S.K. Bhosinka, Senior Consultant Physician and Cardiologist from Sitamarhi. Sir, could you please join us for the session? Dr. Birendra Kumar, Senior Interventional Cardiologist from Bhagalpur. And requesting Dr. Ashish Ranjan, Senior Interventional Cardiologist from Bhagalpur. If you are around, could you please join us for the session? Since this is the last session, but it's not that we come to the end of the Cardicon. We still have the quiz to go, and the valedictory function and the GB. So we do not have much time. We are already running 45 minutes behind the schedule. I'll request all the chairpersons to kindly adhere to the timing. Also requesting the speakers to please wrap up in 12 minutes. If allowed, if permitted, we can have 3 minutes for the questions and interactions, allowing to only 2 questions per speakers. Also, drawing the attention of our honorable chairpersons and the panelists here, for this session on the Potpourri, sir, for this session of the Potpourri, we have a little change in the schedule. Dr. Manish Bansal will be presenting as the first speaker, and then we'll have Dr. R.D. Yadve, and then again Dr. Daljit Kaur, and then again Dr. R.D. Yadve. Just a small change. Dr. Manish Bansal will be speaking first. Over to you, sir. Thank you.
Hello. Hello. I'll request Mr. Manish Bansal to please have his presentation.
Good afternoon, everyone. First of all, I thank Dr. Anupam Bhamani for inviting me to speak in this very important meeting. I'm supposed to cover 2 topics, TER and PTMC. I'll be focusing more on TER because this is a new procedure. PTMC, I'm sure all of you are aware how to select patients for it. So, TER means transcatheter edge-to-edge repair, popularly known as mitral clip procedure, is a procedure which has been developed recently to treat mitral regurgitation by percutaneously placing a clip at the tips of the mitral leaflets to fuse them together so that the mitral regurgitation is treated. This procedure is done completely under fluoroscopic and TE guidance, and because it is a blind process, so to say, that there is no direct access to the mitral leaflets, very precise patient selection and precise imaging guidance are absolutely essential for this procedure. So this is an animation which shows how the procedure is done, how the clip is brought into the left atrium via transvenous route, and then septal puncture is done, atrial septal puncture. And then once the clip is in the left atrium, it is positioned right at the point where it is supposed to grasp the leaflets, and then it's taken into the left ventricle, gradually withdrawn towards the mitral leaflets to grasp both the leaflets, and MR is reduced. this procedure is currently recommended for two types of MR. One is degenerative or primary MR, which means flail or prolapsing mitral valve leaflets, and second is functional secondary MR. For functional MR, it has become more established treatment as compared to degenerative MR, for which surgery remains the dominant treatment modality. Now, as I mentioned, proper patient selection is absolutely crucial for this. But before we come to actual anatomic suitability assessment, we have to first make sure that the patient is having severe MR, which is the cause of symptoms. Mere presence of severe MR is not an indication for this procedure. Then the patient should be high risk for surgery, and surgery should not be an option. Only then we contemplate this procedure. It should not happen that just because we can do it, we start offering it to everyone. And once we have met these two conditions, then we come to anatomic assessment of the mitral valve in terms of suitability for this procedure. So TE plays a very important role here. TE, as we know, provides excellent images of the mitral valve because of its close proximity to the structure, and only the left atrium, which is filled with blood, is in between the esophageal, transesophageal probe and the mitral leaflets. We can have excellent visualization of the mitral valve from all the different aspects. But T is not the first step. We first do a transthoracic echo, and in most of the cases where TER is not going to be feasible, we can make that out from transthoracic echo itself. When it appears that, okay, this patient could be suitable for mitral clip procedure, then we do a detailed transesophageal echo assessment. This is one of the recent publications where we try to describe all the steps of this procedure, and especially focusing on echo guidance. Now, there are certain criteria which define which patient is going to be suitable for this procedure, but with more and more experience, most of the operators are now dealing with more and more complex anatomy. So nothing is absolute, but there are certain things that we need to understand. So ideal is to have central mitral valve pathology which affects A2, P2 scallops, which means the center of the mitral valve. Perforation of clefts are contraindication. Ideally, we want that there should not be any calcification in the mitral leaflets, but certainly there should not be a chunk of calcium at the site where we want to grasp the leaflets. Then very important to make sure that there is no baseline mitral valve stenosis, because once the clip is positioned, it will reduce the mitral valve orifice size by at least 50%. So that we need to take care. And then depending on what we are dealing with, whether it is functional MR or degenerative MR, there are additional criteria. So I'll just show you some examples. So here we have a secondary MR. As we can see, the leaflets are normal, but the patient has severe LV systolic dysfunction and the mitral leaflets are tented, but structurally they are normal. So that's why this is secondary MR. And there is big central jet, severe MR, coming through the center of the mitral leaflet. So this is going to be an ideal case for this procedure. But here is another example. This patient also has secondary MR, but there is wide non-coaptation, and we can see a very big gap between AML and PML. So putting a clip in this case is going to be very challenging, and there will be a risk of causing tear of the leaflets once we try to pull them together. But unfortunately, this patient was very sick, going into recurrent pulmonary edema, so the procedure had to be done, and eventually by putting two clips, one after another, using the ziplock technique, in which we first put first clip close to the commissure, and then that reduces the coaptation gaps so that we can put the second clip in the center. This MR could be tackled very nicely. Another example, this patient also has secondary MR. We can see that there is tenting of the mitral leaflet. There is severe MR, no confusions about it, and this is a torrential MR, likely to benefit from the procedure. But when we did 3D, we could clearly see a big cleft in the PML. So then this patient was excluded. So this is a contraindication to this procedure. Now this example shows the utility of 3D TE for assessing the patients for this procedure. By looking at only the 2D images, we thought that this was an ideal case, but then it had to be excluded. Here we have an example of degenerative MR, in which we can see the posterior mitral leaflet has become flail, and because we are in this long axis view, this has to be the center of the valve. So P2 is flail, and this we can confirm on 3D also. The center part is flail, which is bulging towards the left atrium. So again, an ideal case, and underwent this procedure with one clip the mitral valve regurgitation was completely gone, and as we can see here, the mitral valve orifice has now become a double orifice valve. Another example, so here this time we can see that this flail segment is very close to the commissure. So it is P1 flail. This is going to be tricky, not that straightforward case. And here we had to use two clips to put the to treat this MR. So if the flail segment is in the center, it is relatively easier as compared to when it is close to the commissure. Another example, now this time again we can see that there is a flail segment, but this time it is AML. We can see the attached chordae also, and this again is in the center of the valve, should be suitable, but the problem is that the mitral leaflets are markedly thickened, will be difficult to grasp, and then when we try to measure the mitral valve area, it was only 2.9 centimeters square. So not a suitable candidate for this procedure, even though the anatomic defect is suitable for this procedure. Here we have another example. This patient had Barlow's disease. There was extensive bileaflet prolapse involving all the scallops, as we can see. So clearly unsuitable case. But again, in this patient also, the patient was very sick, very frail lady, hardly 35 kg weight, and she was not coming out of the ICU. So the procedure had to be attempted, and with two clips, actually quite remarkably, the MR could be treated. So this just shows that there are certain anatomies in which the procedure is very difficult, but with experience it can be performed. Those who are relatively new to this technique, they should be treating only the ideal pathologies to begin with, and as they gain experience, they can go on to dealing with more complex pathologies. Here is another example. Once again, it looks like a secondary MR, leaflet tenting, but when we looked at more images, it was evident that this patient had AML perforation because of previous endocarditis, and because of that there was MR through this also, and then LV dilatation had led to development of secondary MR also. So this was a double etiology of MR, and obviously not a suitable case for this procedure. So these are some of the examples. This is a field which is rapidly evolving. There are so many different scenarios, and there are so many different cases which I could show and discuss, but because of the paucity of time, I try to select only the classical examples of showing in what cases the procedure can be performed and in what cases it should be avoided. Now very briefly about PTMC. Now as I mentioned, this is a procedure which you are all very familiar with. We know that for PTMC we want the patient to be having severe symptomatic mitral stenosis, rheumatic MS. The leaflets, we want them to be pliable, there should not be any calcification or minimum calcification. Commissure fusion should be symmetrical. If one commissure is fused much more than the other one, then that is not a desirable situation. No minimal commissure calcification, because calcified commissures are a recipe for disaster, because then if we try to do BMV, we may lead to the rupture of the leaflets, because commissures will not split. Subvalvular apparatus should not be too deformed, and then we want that the MR either should not be there or it should not be more than mild, no LA, L appendage clot, favorable IAS anatomy. Now we are all familiar with various scoring systems available for assessing suitability for BMV. One of them is Wilkins score. It has some pros and cons. The main disadvantages are that it has equal weightage for all the different anatomic abnormalities which do not have equal bearing on the success of the outcome, and it does not look at the commissures. So there are other scoring systems also available which have been put forth. One of them is this score which looks at commissures, and commissural morphology assessment is absolutely important, as I mentioned earlier also, because if commissures are calcified, then there is a big problem. So here we have an example of an ideal case for BMV, nice pliable mitral valve leaflets. There is severe mitral stenosis, very high gradient, both commissures are fused and symmetrically fused, so good case. Now the next one is patient had commissural calcification and PTMC was attempted and led to complete tear of AML, and obviously the patient had to be taken up for surgery immediately. Another example here, this time also the mitral valve leaflets look very pliable, and valve area is 1.2 moderate MS, so appears to be a good case for BMV, but the gradient was very high, so that made us suspicious of the findings. And then when we looked at the mitral valve more closely, we realized that there was significant subvalvular thickening and calcification, which was bifurcating the mitral inflow, and that is why we had very high gradient despite the better valve area. So obviously this is not a desirable situation for BMV. Then LA appendage clot, LA clot will be obvious contraindications, and here we have some examples in which the interatrial septum is either split, or there is this pouch, all of which will create challenges during the procedure. And lastly, as I mentioned, this is a procedure that we use for rheumatic MS. We must not confuse it with degenerative MS, which occurs in elderly. In degenerative MS, there is pathology mainly at the annulus or the basis of the leaflets. Commissures are not affected. So in these cases, BMV is not going to be helpful, and we should be able to make that distinction. So just to summarize, echo plays an indispensable role in the evaluation of the patients undergoing mitral valve TER and PTMC. And TE is especially important because it can define the exact lesion anatomy, it can rule out potential contraindications, and in case of mitral valve TER, it provides a roadmap for the procedural planning and of course the subsequent imaging guidance during the procedure. Thank you so much.
Thank you, Dr. Bansal. Any questions from the audience? Any interaction? So paucity of, because of paucity of time. Okay. Now I'll call upon Dr. R.D. Jadhav, who is a friend of ours and is a prolific academician, and certainly impresses all of us for time and on and for the decades.
So, respected chairperson and dear friends, first of all, I want to thank the organizer of Cardicon, 30th Cardicon, to inviting me for the talk. And my talk is on HCM, drug versus intervention. So the first use of term cardiomyopathy was used by Wallace Brigden, is an English cardiologist, and first description of HCM was done in 1957 by Sir Russell Brock, British cardiac surgeon, and idiopathic hypertrophic subaortic stenosis term was used along with the clinical hemodynamic and angiographic manifestation by using Brownwall and Morrow in American Journal of Medicine 1960, and hypertrophic cardiomyopathy, which is the commonly used term is nowadays, is by Barry J. Maron and Epstein, American Journal of Cardiology 1979. So hypertrophic cardiomyopathy is an autosomal dominant genetic disorder due to mutations, most commonly one of the sarcomeric proteins, most commonly is the beta myosin heavy chain. Mutation prevalence is 1 in 500, but nowadays it is 1 in 200 to 300. So it's now incidence has increased, and the most common pathological findings is the myofibrillar disarray. Arrangements of the myofibril is disarranged, and marked otherwise unexplained hypertrophy without any hemodynamic stress, means hypertension or aortic stenosis, and the thickness is more than 15 millimeter. And if they have genetic variant present, then the thickness of 13 millimeter is enough to diagnose the hypertrophic cardiomyopathy. It is associated with replacement fibrosis. It is associated with electrical inhomogeneity, leading to electrical instability, ventricular arrhythmia, and sudden cardiac death. Abnormalities of the mitral valves are also common, associated with elongated mitral leaflets, entirely displaced papillary muscles. And this is the typical type of basal part of the asymmetric septal hypertrophy of the septum, and this is the structure of the sarcomeric arrangement of actin myosin, and the myosin beta chain is the most common protein which is mutations leading to HCM, and this is the normal myocardium, and this is the myocardium with fibrosis and disarray, the myocardial disarrangement of the fiber. And this is the echo showing the SAM associated with aseptal symmetric hypertrophy and LVH in the your ECG. So this is the apical HCM first described in 1979, where there is a spade separate heart at the end diastole associated with deep T wave inversion in the chest leads. This is the same patient having obliterated the apex of the LV associated with deep T wave inversions, and this is the mid cavity gradient showing lobster claw profile, and there is a mitral tissue Doppler defect in the form of premature scission of the S wave, and E prime wave was lower in amplitude. So this is the dagger type of your obstructive dynamic obstruction, more with the amyl nitrite, then the Valsalva, and then the resting gradient. So if you see now the treatment, availability of the treatment, beta blocker, calcium channel blocker, and although cardiac myosin inhibitor is not available in India, but we do alcohol septal ablation and surgical myectomy. Surgical myectomy is rarely done in India, but the most commonly we do the alcohol septal ablation, and now the mortality is as per the general population with the availability of new drugs. Now in 2024, just a few months back, the guideline has been changed, and some revision has been done. And the first revision is that there is no restriction of physical restriction of patient with HCM. So patient can do whatever required, and this is the live HCM study which showed there is no harm in doing exercise up to 9 minutes. Up to 9 minutes, vigorous exercise is avoided, but up to 9 competitive exercise, football and all should be avoided. Now, another recommendation in revised recommendation is that myosin inhibitor or disopyramide in combination with atrioventricular nodal blocking agents can be used. So, the first line therapy, those who are obstructive HCM is beta blockers and symptomatic. Obstructive with symptomatic is beta blocker and non-dihydropyridine calcium channel blockers. The class 1 indication. Advanced therapies, disopyramide, mavacamten, and septal reduction therapy is the class 1 indication. So all what I mean to say, whether you use disopyramide, mavacamten or septal, all are class 1. So those who are patients with non-obstructive HCM with preserved ejection fraction and valsartan should be used, and management of patients with HCM with advanced heart failure, cardiac myosin inhibitor, that is mavacamten, should be avoided, should not be used. And in pregnancy also mavacamten is contraindicated. And doses should be started with 5 milligram, maximum dose should be 15 milligram, and don't start if the ejection fraction is below 55%. Only if ejection fraction is more than 55% with obstruction, then you should start this drug. And in children, you should do the exercise test for the obstruction features, and if any one risk factor for sudden cardiac death is there, then discuss the patient with the ICD. So this is the gradient is mainly because increased myocardial contractility like post-ventricular contraction or exercise, decreased preload due to Valsalva maneuver or scar to stand, or decreased afterload due to eating because of the increased perfusion to the gut. So beta blocker, verapamil, diltiazem is class 1 indication, those who are symptomatic with the gradient. Myosin inhibitor, disopyramide, septal reduction therapy, all class 1. And though depending on the indications, septal reduction or myectomy can be done depending on the need. And the cardiac myosin inhibitor acts by decreasing the actin myosin cross bridge formation. Here, actin myosin cross bridge formation is less as compared to in untreated it is much more. Then excessive myosin actin cross bridge, this is normal actin myosin cross bridge. So this is the with same mechanism by reducing the actin myosin cross bridge formation. So how to start this drug mavacamten? It should be started if the gradient is more than 20 millimeter of mercury. Start with 5 milligram once daily. Ejection fraction should be more than 55 percent, and if it is less than 20 millimeter of mercury, start with 2.5 milligram once daily and maintain for 4 weeks, and at 8 weeks you check again the echo, and if the gradient is again more, continue with the 5 milligram. You can go on increasing till up to 15 milligram dose and check the ejection fraction every 4 weeks. There should not be fall in ejection fraction of this due to these drugs. And if say ejection fraction down below 50%, stop this drug. Many people stop it below 40% of the ejection fraction, and reduce the dose. If below 50%, they reduce the dose to 2.5 milligram. But it is better to stop this drug and recheck the echo after 4 weeks. If the ejection fraction improves, you restart this drug. So the same thing has been written here. So now the trial, Wheeler HCM trial, where is the evidence? Wheeler HCM trial is the trial which was presented in ACC 2022, and what it showed that it randomized those patients of hypertrophic obstructive cardiomyopathy divided into, they were listed for septal reduction therapy, either by surgery or by alcohol septal reduction. And then they were divided that we will give medical therapy, mavacamten, and see what happens, whether they come out of the list or not. And what they have found that after your 16 weeks of therapy, 82% were ineligible for septal reduction therapy. They were out of the list. Whereas those who are given placebo, 77% were remain on eligible list. And patients who were given mavacamten, there is 63% and 27% your improvement in New York Heart Association functional class, but 37% have no improvement, whereas in placebo 80% have no improvement. So it proves that this mavacamten is also reduces the gradient from 46 plus minus 29 to 14.9 plus minus 9 at resting LVOT, and at Valsalva the gradient is reduced from 78 plus minus 31 to 28 plus minus 21. And ejection fraction is reduced only 4%. KCCQ is improved by around 10 points. Anti-pro-BNP and prop-I is also decreased significantly. So non-sustained VT, there is no difference, but the limitation is that primary endpoint driven by reduction in guideline eligibility for SRT, but that is septal reduction therapy. Duration of randomization was only 16 weeks. Whether myosin inhibition can allow patients to avoid SRT long term, we don't know at the present moment, but the long term trial is going on. So Explore SCM trial is similar trial where the peak oxygen consumption was measured, and what it was found that in mavacamten improves the peak consumption by 1.5 ml per kilogram in 37% and 3 ml per kilogram in 20%. It also reduces the gradient, resting gradient, as well as the Valsalva induced gradient significantly at 84 weeks of use. Ejection fraction with mavacamten hardly reduced 4%, where Explore LTE also reduction up to 9% has been reduced at, and only 2 patients develop ejection fraction below 50%, where it has to be stopped. And there is a quality of life is also improved significantly with this. And as soon as the drugs you stop, regradient will also appear. So you have to continue the drug to get the result. In another drug came is the efficamten, and Redwood SCM trial has used that. It was shown that is a significant reduction in gradient both in resting and the Valsalva. And same thing, Forest SCM, again efficamten was used. There was significant reduction. Say from 40-50 to it comes down to 7-8, mean the peak gradient, both during Valsalva as well as during the resting condition. And in Redwood SCM and Forest SCM, the ejection fraction remained maintained, hardly any decrease in both. No patients had LV ejection fraction below 50%, whereas in Redwood 41 patients, 2 patients developed having ejection fraction below 50%. And they have in Redwood SCM long-acting trial, KCCQ has shown improvement. In Sequoia SCM trial, again efficamten was used, and what it showed that peak oxygen uptake is increased significantly. Okay.
Sir, please conclude.
Just one more minute. And so FDA has recommended this mavacamten, but aficamten is still on trial. So those patients having HCM without obstruction, whether this drug can be used mavacamten or not, Odyssey outcome trial will tell. Whether those having obstruction without using beta blocker and calcium channel blocker, whether mavacamten was used or not, MAPLE HCM trial will tell us whether to use directly the mavacamten, that is cardiac myosin inhibitor or not. So about the how to do it, just the septal artery is seen, sometimes may not seen, then you can give nitroglycerin and then occlude with the balloon and put the alcohol like this, and you can check in the echo, gradient comes down, there should not be heart block. Try to avoid you give alcohol only 1 to 2 ml depending on the thickness. If the thickness is 20 millimeter, give 2 ml of alcohol, absolute alcohol, 96%, and it will be look like this, and obstruction will go down and the gradient will go down like this. About the surgical alcohol septal ablation versus septal myectomy, only thing is that both are equally effective. Although gradient reduction is 10 millimeter of mercury less in alcohol, less in surgical, less in alcohol septal ablation. Pacemaker indication is more in alcohol septal ablation, and sudden cardiac death, no difference. Other things are no difference between the two. So this is the latest meta-analysis. So no difference between the two. Both you can use. Another procedure is called sesame, which can be done by catheter induced. This is the just I want to show. This is put a catheter, then put a stato wire, a stato 20 excess wire, and use electrocautery, and over the micro catheter goes inside the your septum, thickened septum, and then perforate it, and then snare it out, and then use cautery to clear the septum, and this is called sesame procedure, and this procedure also shown beneficial in reducing the gradient, and both in TMVR cases as well as in the hypertrophic cardiomyopathy, it has shown benefit in reducing the gradient. So to conclude, CMI are now treatment of choice in obstructive SCM, but cost of these drugs are prohibitive. In US also the cost is very high. ASA, the alcohol septal ablation and surgical myectomy will remain continue to use in those not responding to CMI and also in those who cannot afford. So still alcohol septal ablation we do a lot of them. Only symptomatic SCM patient needs treatment, non-obstructive SCM needs valsartan, and initial treatment remains beta blocker or non-dihydropyridine calcium channel blocker. Disoparamide may be needed over and above therapy. Sesame procedure is evolving, may obviate the need of surgical myectomy. And thank you. Sorry for the extra minute.
Thank you, sir. As time is not permitted, so we have lots of questions to you. We will discuss on lunch. So now I am calling next speaker, Dr. Daljit Kaur, consultant electrophysiologist, AIG Hospital, Hyderabad. Dr. Daljit Kaur, please.
Thank you, Cardicon, for having me here, especially Dr. Ajay and Dr. Shamshad. Because of them, I'm here. So my job for next 12 minutes or so is to talk about managing VT storm in patients with and without ICD. So what is VT storm? We should know that. So VT storm is hemodynamically unstable VT, at least 3 episodes which record shock over 24 hours in patients without ICD. In patients who are having ICD, require 2 shocks from the ICD within 24 hours. And we should talk about little bit about incessant VT as well. Incessant VT is hemodynamically stable VT. Patient may not be symptomatic, which is running for hours, maybe days, maybe week, and sometimes patient comes with the heart failure because it's a slow VT going on for longer duration. I'll cover my topic with few case example. This is 59-year-old lady, hypertensive, hypothyroid, had history of old antival myocardial infarction, and then severe LV dysfunction. She had VT for which ICD was given, previous AFib episodes, and that's why patient was on warfarin. This admission is referred from another center. Patient was on ventilator and was intubated when she came. Patient was in incessant VT since last 4 to 5 days duration and was on ventilator, and that's the ECG going on. You can see it's a monomorphic regular VT. The problem was first it was diagnosed with SVT because of this blip seen. People were thinking it's a supraventricular tachycardia atrial flutter. Patient was tried on multiple drugs and referred. Now the question is, this patient has an ICD and why the device didn't give shock, right? Because it's a slow VT. Many times you don't use this rate for giving the therapy. For example, 120, 130, 140 rate, device may not give the therapy. So now you have a device. How do you manage this case? Patient, you need not give multiple shocks for this kind of the VT. And these are the parameters you can see. Because of the incessant VT, they go into refractory heart failure. Patient had high INR, liver enzymes were deranged, platelet count dropped down, and EF dropped to 15 to 20% because of the incessant VT. The first most important thing you can do is, device doesn't even give not only the shock, you can give overdrive pacing from the ventricle. So that can be done, it's a painless therapy. So utilization of the overdrive pacing, that is anti-tachycardia pacing, can be utilized. Can you see simple ATP has reverted the VT. So are you happy now? If the patient, it reverses, it doesn't restarts, we are very happy in this patient. So now now each patient is different, right? So what are the therapies? We all know that in the ICD, you have 3 zones of therapy. Now this is a special case where patient is having slow rate of the VT. So what I did was, I modified. So VT1 zone is 105 to 150 beats, you can see that. And here we are giving just 6 ATP and no shocks, because this doesn't need shock. We know that patient reverted with overdrive pacing. And second zone is 150 to 200, where along with the ATP, you have started with the lower joule shocks. And then more than 206 rate, you are giving only shocks. So we are happy now, patient gets stabilized. And you go to this was done in the evening, late night, and next day morning you go for the rounds and the sister says patient is better, patient parameters improved, and if you see ECG, there's a sinus ECG. But if you see over 12 hours, can you see there were 255 episodes of VT over 12 hours. That means overdrive pacing is working, it's reverting and restarting. So the patients who was in incessant VT is reverting, but repeated episodes of VT is there, and patient required 255 plus 3 shocks in VT2 and 3 shocks delivered over 12 hours overnight. So this patient cannot be left like that, right? Because you have exhausted all of your therapies in this patient. So these are the cases, because it's a single morphology, monomorphic VT, which is a nuisance and causing heart failure in the patient. You take the patient for the ablation. I'm not going to go into the details of the ablation. Anyways, we did activation mapping because patient was in VT only. Activation mapping means you map the tachycardia, whole circuit of the tachycardia, and you ablate and patient comes in sinus rhythm. And there's a single site, like this, a septal scar was there. You ablated, did some substrate modification. And this is the X-ray when the patient came intubated and patient was in heart failure. That's the X-ray just before the discharge. Next day patient was extubated. And you can see that once patient is in sinus, the perfusion improves. And because of the improvement in the perfusion, there is improvement in all the parameters. Only hemoglobin has dropped a bit because you took the patient for the procedures. So you should know that when to go for the non-pharmacological interventions in the patients when your all other therapy fails. This is a next case example. So first was a patient having an ICD, incessant slow VT going on for many days, which is not responding to any pharmacological therapy. This is a next case, 53-year-old male, had an atrial myocardial infarction but reached late to the hospital. Patient reached on 3rd day, angiography showed single vessel disease, ostial LAD, and you revascularize the case. All good, and patient was shifted out. And you can see that anterior wall is completely gone because patient reached late to the hospital. And then you shift the patient outside and patient arrested. And this was the ECG. Patient had a VF arrest and then you give a shock. You can see almost 200 joule shock and patient recovers. So in the acute MI phase, or we can use the terminology of peri-infarct period, we know that sometimes you revascularize and patient goes into VT storms or multiple episodes of VT. What are the predictors? Larger infarct, like this patient had an ostial LAD involvement. Patient in the cardiogenic shock can have more chances of VT. Patient coming into heart failure, TIMI zero flow, incomplete revascularization, whatever is the reason, having the comorbidity, specifically CKD. Don't forget to rule out electrolyte imbalance in these patients. So you should try to revascularize these patients completely. So this patient coming back had again had a VF arrest, resuscitated. So what do you should be doing? If every 5 minutes this patient is going into VFA, what you should be doing? So always we have to give shock, right? We keep giving shock. The most important thing is the high sympathetic drive in these patients. That's why beta blocker in first 24 hours has a mortality benefit. Now you cannot keep giving shock in the awake patient. You are increasing the sympathetic drive. So most important is knocking down the patient completely. So you put a patient on ventilator, knock down, give general anesthesia to the patient. And we know that incomplete revascularization is the reason of VT storm. But you do the angio and then you know that the stent is flowing. What do you do next? So rule out electrolyte imbalance. You have already given general anesthesia, knock down the patient. What are the other modality of treatment? So most important is to how to decrease the sympathetic drive, and there are a lot of modalities. This is completely a different topic like neuromodulation. We know that it's not only in arrhythmias, supraventricular arrhythmias, AFib, VT, heart failure, there is a big role and there are different modalities. But these kind of patients, you can do bedside sympathetic denervation, left and the right side with the use of bupivacaine. So bedside sympathectomy was tried in this patient which failed. If bedside is not working, you can go for surgical sympathectomy, which is videoscopy guided sympathetic denervation. So we should know little bit limitations of when you talk about sympathetic denervation. You need a cardiac surgeon. There should be no lung disease. Lung adhesions should not be there. Ability to tolerate single lung ventilation, because they have to put a dual lumen and the side you are doing sympathectomy, that lung has to be collapsed. So if lungs are very bad, patient may not tolerate single lung ventilation. If there is a prior thoracic surgery or radiotherapy done for some cancers in the past, there will be a lot of adhesions. It will be difficult to do, and like a previous patient, if the patient you have stented and patient is on dual antiplatelet or anticoagulation, it becomes difficult. Complication rates are very rare. Pneumothorax can happen, Horner's can happen, hypotension can happen, specifically if you do bilateral in older patients with severe LV dysfunction, and patient may complain of lack of sweating in the face and hand. So there are two types of sympathectomy. One, as I said, bedside sympathectomy with the needle. Second, videoscopy assisted guided. Third is radiofrequency ablation can be done, sympathectomy. So here you should take the help of your neuroanesthetist, because they have a very thin catheter. And now data is going to come that the outcome of radiofrequency, which is also bedside, like 15 minutes procedure, no GA required, the outcome of radiofrequency ablation guided bilateral sympathectomy is similar to surgical sympathectomy. All the work is going on this. So anyways, coming back to our patient, we tried sympathectomy which didn't work. So what is the next? Patient is already intubated on multiple drug, whatever drug name you want to take, all drugs were tried on this patient. So other thing is you can pace A faster. So if I pace A faster, I may inhibit the chances of ventricular fibrillation. And where do you pace the A faster from? You can pace from coronary sinus. So you can see that 2-3 AVF is negative, pacing from coronary sinus. Despite of that, patient is having VF episodes. So here you should know the mechanism, because ablation for VF is very difficult. But ablation for VT you can do. So there is something called, whenever there is a late revascularization, there is something called Angry-Purkinje syndrome. Why does this happen? Because your myocardial cells, when they die, the Purkinje cells can survive. They can give automaticity. So if there is a single Purkinje fiber PVC which give rise to PVCs, which give rise to the VT or VF, if I target that for ablation, we can save our patient. You can see that we realize that the patient is a single PVC from the anterofascicle. So patient is taken up for ablation. This is all red is the scarred area. And the scar modification performed, and the place from where PVC is coming has been ablated. And you can see that post-ablation we stopped atrial pacing. And then 2-3 AVF is positive P waves. PVCs are, you can see the halter as well. PVCs are completely suppressed. You try to give extra, no VT is induced. But mind you, this patient doesn't go home without an ICD, because this ablation doesn't decrease the chances of out of hospital sudden cardiac death because of the huge scar. This is a third case, is a young guy, 17-year-old guy. He had a recurrent episodes of seizures actually. Many times seizures recovered at home. This time he came to hospital and they demonstrated that actually it was not seizures and it was a VF episode. He was in a VF storm. Electrolytes, everything, secondary causes are, and most important is the treatment going on for this patient was phenytoin, amiodarone and lignocaine infusion. No structural heart disease, otherwise no comorbidities, and that's the ECG. And I think many in the crowd would have identified it. It's what? It's a Brugada ECG. It's a type 1 Brugada pattern. This guy had a Brugada syndrome. And what is the treatment ideally? So you stop. So he had everything you talk about Brugada. He had a normal QT polymorphic VT. He had a multiple morphology PVC, short couple PVC VF. He had a monomorphic VT. Stop everything. Cool him down completely, give him GA, isoprelolene infusion was given, cold saline irrigation done, this guy settles completely, and then his genetic is positive for the Brugada syndrome. So the most important is we should know the reason why the VT is happening. I think my time is already getting over. So this is one of these sarcoid patient. I'll not go into the details. So the sarcoid is always a very big nuisance. So when you take these cases for ablation, you can see there are 18 different morphologies of VT. You should not going and ablating this. It's a zoo of VT. So here, treating the underlying disease is most important. So in this patient, everything was tried anyways. So ultimately, the only drug which was helpful, thyroidectomy was done because he had papillary carcinoma of the thyroid. The only thing which helped in this patient was adalimumab. So this patient got settled when the thyroid sarcoid activity got settled. I'll stop here. Thank you very much.
Thank you, ma'am, for your nice illustrations of the cases. And now again, I would like to invite Dr. R.D. Yadav sir again with some interesting cases.
Oh, 12 minutes. Okay, then 12 minutes I will show 2-3 cases then only. So which, 3 cases, which will of interest. Again, thank you for the inviting me. So this is 58-year-old patient with coronary artery disease, sinus node dysfunction, and put on DDDR pacemaker, complains about palpitations. So any patient comes with a pacemaker, dual chamber pacemaker, or single chamber pacemaker, whatever, comes with palpitation, we should think of 2, 3, 4 things. So pacemaker checkup was done. So sensing function normal, pacing function normal, heart rate histogram normal, no stored automatic mode switch, no relevant story memory data. But sometimes they show high atrial rate events, AHE. So what you will think of by seeing this ECG taken after the patient, and if you see atrial pacing, ventricular pacing is going on. So atrial pacing, ventricular sensing is going on, and after one VPC is here, the tachycardia starts. There is a atrial spikes, and then ventricular pacing, atrial spike, ventricular pacing going on. These ventricular ectopics gives rise to one retrograde atrial conducts retrogradely, which falls within the PVARP, which falls not beyond, within the PVARP, makes the atria non-depolarizable, means refractory. So after atrial ventricular escape interval, the atrial pacing spikes comes on, and which finds the atria refractory, and so there is no atrial spikes. The spikes is there, but there is no atrial capture. And then after AV interval, paced AV interval, ventricular pacing going on. So this tachycardia is going on. Which type of this tachycardia is called? You see, this is called 1 AR, 1 AP, atrial pacing, which is not captured, and then ventricular pacing. So after 2A, there is one ventricular pacing. If you get like this in your interrogation, it's called RNR VAS, repetitive non-reentrant ventricular synchrony. So this is the ECG of this patient, which is really complex. But what happens? say if there is a, okay. So if this ventricular ectopics occurs and if the retrograde that conducts retrograde and the AR occurs during the PVRP, which is not sensed by that, not tracked, and so the atrial pacing will occur after the VA interval, escape interval, and which will find it refractory, and then A pace, V pace going on. So this is called RN-RVAS. So how to prevent it? So RN-RVAS is a repetitive process characterized by functional atrial undersensing due to retrograde atrial activation falling within the PVRP with subsequent functional atrial non-capture as the pacing stimulus occurs during the absolute refractory period of the atrium. Same thing. And this repetitive pattern becomes established when the non-capture atrial pacing is tracked by the ventricular pacing, which results in retrograde atrial conduction. And during ELT, endless loop tachycardia, a similar phenomenon occurs, except that the retrograde atrial activation is sensed outside the PVRP, resulting in P-synchronous ventricular pacing. So this is called RN-RVAS. So I will go the same patient, similar patient, atrial pacing, no capture, and then ventricular pacing going on. This is RN-RVAS. How to manage this patient? You decrease the rate of the pacing, avoid what is called, decrease the lower rate limit, and decrease the what is called rate drop response pacing, avoid rate drop response pacing, avoid overdrive pacing algorithms like atrial overdrive pacing algorithm, and avoid high sensor rate, make the sensor rate off, and shorten the AV delay. So this is the way you can prevent this. So this is the endless loop tachycardia, where PVC will be conducted retrogradely, and that retrograde P will be beyond PVRP, which was sensed and which was tracked, is called ELT, endless loop tachycardia. So this is the device programming. I'm not going to go detail about this. So what are the causes of patient having put on pacemaker and complaining of palpitation? This may be endless loop tachycardia, runaway pacemaker, RN-RVAS, sensor-driven tachycardia, MRI-induced modification of the pacemaker, MRI-induced tachycardia, myopotential tracking, and atrial arrhythmias. So these are the atrial tachycardia, atrial fibrillation, flutter, whatever can cause. So those patients on pacemaker, these are the causes where high rate is there. Now this is another patient, a patient with paroxysmal complete heart block was implanted with a dual chamber pacemaker, and at follow-up, this is the strip. So if you see atrial sensing, atrial pacing, ventricular pacing with a pace AV interval. Atrial sensing and ventricular pacing when occurs, it's not tracked. There is no tracking of atrial sensed event. But if atrial pacing is occurring after paced AV interval, there is a ventricular pacing. So this type of rhythm, if this is occurring, what is the mechanism? So here, if this occurs, it's called DDDDI mode, where the baseline rhythm is in sinus. So DDDDIR mode, where baseline rhythm is sinus with complete AV block, atrial pacing is occurring, so the VDI and VDD modes cannot be occur. So VDDI and VDD mode cannot occur because its atrial pacing is there. So it excludes that. The device was programmed in DDDDI mode with a baseline rate of 60 beats per minute. So atrial pacing, ventricular pacing will occur if there is no atrial sensing events at 60 beats per minute. And there is loss of AV synchrony with the atrial sensed events at a constant ventricular pacing beats of 60 beats per minute. BP interval is around 1000 milliseconds due to cycles. So some variation because of the device clock. This excludes DDDD and VDD pacing modes. Because atrial sensing is not tracked. So it cannot be DDDD mode and VDD mode. So what is left is DDDDI mode. So this is the way you should discuss this case. So I will go to case number 13. Can I go 13? How to go? Yeah. No, 13. Okay. Sorry, I am. No, I will go DJ. Case number 13. So I will. Okay. Okay, touch screen? Okay. Yeah. So, a patient was implanted with a dual chamber pacemaker of symptomatic Wenke-back AV block, and a halter was performed and shown like he was having this. So here, if you see, the halter showed that there is a missing bits, there is a atrial capture, but there is no ventricular capture at two places. Here, atrial capture. Okay. So here you see atrial capture, but there is no ventricular capture. That means here also there is atrial capture, no ventricular capture. That means what? Ventricle is either oversensing and so it's not giving. That's not true. Everyone will diagnose because its ventricle is oversensing something. So you have to increase the number, make it less sensitive. But that's not here. Here, if you see one beat lost and thereafter there is a pacing, spikes, and next spikes after the loss, first loss, the another beat comes in 80 milliseconds. Quick succession. So this is called managed ventricular pacing, and that the term is used is called ADI DDDDI switch or AIR DDDR switch. So it is because of a managed ventricular pacing algorithm, and this is all about the managed ventricular pacing algorithm, how to avoid it. But dangerous, this managed ventricular pacing can cause sometimes VF and can cause sudden death. So be careful in using this algorithm. Now, third case which I am going to show, these are the evidences which I am not going to show you. 19th. Okay. So this is the patient 19th. 72-year-old patient underwent another 2 minutes. A 72-year-old patient underwent implantation of DDDD pacemaker for paroxysmal complete AV block. The patient experienced syncope on what? 30 minutes after the intervention. Means something has been wrong during the implantation. Otherwise, why this patient will go immediately into syncope? And rhythm strip during syncopal event is shown this one. There is a ventricular pacing, then there is a spikes after the ventricular pacing, and this goes on, and then there is a AAA or PPP without. So you will say it's a ventricular oversensing. Yes. But why the pacing occurs? So what problem has occurred? Is the atrial lead dislodged into the ventricle? No, it's the atrial ventricular lead switch on the header. Here, atrial ventricular lead has been switched. So even during implantation of the pacemaker, slight distraction may lead to the implanter may put atrial lead into the ventricle and ventricular lead into the atria. So please, during pacemaker implantation, don't get distracted even for a moment during the period. So here, the first spike delivered by the atrial channel entrain the ventricle, and this may only result in atrial, that is the ventricular capture. Ventricular pacing is inhibited by the P waves, ruling out your here in 2. The P waves are sensed in the ventricular channel at a rate that is faster than the pacing rate, thereby repeatedly inhibiting the pacing in both the in the atria and the ventricle. So patient gets no pacing occurs and patient gets into asystole. So during pacemaker implantation, check clearly that it does not switch the atrial ventricular lead. And this is the last one. This is the last one. So here dual chamber pacemaker, here pacing, those dual chamber pacemaker on complete heart block patient. You cannot check atrial capture on AAI mode. You have to do atrial capture testing on dual chamber mode only. You cannot do in AAI mode. So you did it, and what happens when the atrial capture gone? Atria is not able to say, atria failed to capture here because threshold, you have lowered the threshold, you are checking the atrial threshold, and then the ventricular pacing occurs, and retrogradely it conducts because atria is free to capture the retrograde atria P wave, and this is inless loop tachycardia continue. So inless loop tachycardia needs to be detected. So this is called inless loop tachycardia, and most common cause is the PVC induced. So in dual chamber device set in tracking mode, it can occur only DDDD or VDDD mode. It cannot occur in DDI mode. And with ventricular capture and sensing retrograde P wave, the presence of VA conduction should be there. A retrograde conduction interval greater than PVARP should be there. So that retrograde conducts A goes beyond the PVRP, which is tracked. It is favored by short PVRP, slow retrograde conduction, so the VA interval is more, high atrial sensitivity, so that even retrograde P wave can be sensed, low safety margin for atrial capture, like some are captured, some are not captured, long program AV intervals, and VDD programming with a sinus rate slower than the baseline. It may be initiated by atrial non-capture, most commonly is by ventricular premature beat, atrial undersensing, oversensing, and atrial premature beat. All can promote, can be terminated by magnet application, and retrograde block by adenosine or carotid sinus massage, or undersensing of the retrograde P wave. So make the pacemaker retrograde P wave and antigrade P wave different. Sensing ability different. Make the ventricular non-capture, atrial premature beat falling in the PVRP, VPB, ventricular premature beat means there is extension of PVRP on sensing the ventricular premature beat, and that is called PVRP extension. And then there are PVC algorithm, which a different company has different algorithm. By extension or after 8 beats of sensing, they give one, they fail to sense that beats or extend the PVRP so that that beat is not sensed. So these are the
Thank you, Dr. Jadhav. I think
maneuvers to prevent the inless loop tachycardia. Actually, I have 30 cases to show. Cannot show within 15 minutes. But all few interesting one I have shown. Thank you.
May I request our honorable chairpersons present
The
and the
session
panelists
is
to kindly
concluded.
present the memento to Dr. Yadve. May I request Dr. Manish Bansal to kindly come on stage, sir. Requesting Dr. Daljit Kaur also to please join us. To Dr. Daljit Kaur. Thank you so much, ma'am, for being here. Thank you so much, sir. And and ma'am for the session. With this, we formally conclude the technical session for the day. Quickly, we'll take 5 minutes break to rearrange. My apologies. We'll take just a 5 minutes break to rearrange the tables for the quiz B, and we'll quickly begin the session. Thank you.
Just put the mics and buzzer, that's all. Nothing else.
Judges को invite.
So sound भी करना कर सकते हैं.
Hello. Yeah. So for the cardio B, we have the following judges, and I'll request them to kindly grace the sofa in the front line. Requesting Dr. Arvind Kumar, CSI President. Requesting Dr. B.B. Bharti, Chairman Scientific Committee. Requesting presence of Dr. Manish Bansal sir from Medanta, Gurugram. Dr. Vipin Kumar sir from Reuben Hospital. Dr. Ravi Vishnu Prasad, who's head of the cardiology from AIIMS, and Dr. Adil Ahmed Khan, who's Associate Professor Cardiology, AIIMS, Patna. These will be the judges panel for our cardio B. We'll begin the quiz shortly, maybe in around 4-5 minutes. Thank you.
Sir, audio check कीजिए. हाँ.
Hello.
Hello, hello. Buzzers है? 3. Hello, hello. Okay, yeah, okay. Welcome back. We are ready to begin the Cardio B, the quiz participants, which is the teams of DM and the DNB trainings. I request Dr. Professor S. Ramakrishnan to kindly begin with the quiz. He'll be the quiz master for the session. Over to you, sir. Once again, I'll request the presence of the honorable judges, who are Dr. Arvind Kumar, Dr. B.B. Bharti, Dr. Manish Bansal sir, Dr. Vipin Kumar, Dr. Ravi Vishnu Prasad and Dr. Adil Ahmed Khan from IJAMS. Thank you.
Thank you. I think let's get started. I think our stomach is calling, but I think before that, let's give something that will really fulfill our hearts and our brains. So let's give a big round of applause to the three teams who are going to join. So team number 1, 2, 3 can take their respective positions. It needs a lot of courage to sit in front of everybody and expose yourself. So if you do very well, you get a lot of things, a lot of appreciation. But if you don't do well, it's a real big thing. Like, we give them a big round of applause. Okay, so since we are running short of time, so let's not waste time, so we just get started. So first and foremost is like, please introduce yourself, team number 1.
Excuse me, sir.
Team number 1.
Team number 1.
You can't see.
Yes, sir. Yes, sir. This one. And this is the.
So team number 1, introduce yourself, please.
I am Dr. Praveen, second year DM resident from AIIMS Patna.
Myself, Dr. Neeraj Kumar, DM resident, AIIMS Patna, second year.
So team 2 is from AIIMS Patna.
Myself, Dr. Gautam Reddy, first year resident in AIIMS Patna.
Dr. Rajat Bhatt, first year resident AIIMS Patna.
यार होम सपोर्ट के लिए और लोग लेके आना था ना, SR इंटर्न सबको लेके आना था.
Dr. Anshu Kumar Jha from MKCG Medical College, Baharampur, Odisha.
Myself, Dr. Biraja Prasad Beura, MKCG Medical College, Baharampur, Odisha.
बस जीतोगे तो ध्यान रखना कैसे घर पहुंचना है, सोच के रखना. Okay, so we are going to have 5 rounds. Can we have the, yeah. So we are going to have 5 rounds. So back to basics, we have X-rays and ECGs, enigmatic echoes. We want to image everything. And curious coronaries followed by Are You the Brave, the buzzer round. So let us get started and try to cover as much as possible in 30 minutes. So are you all ready? There is no negative marking for this, 10 marks plus 10 for this. Team 1. So you have 45 seconds to go. One clue, this is a 15-year-old boy. You have nothing to lose, no negative marks. Go on, your time is up.
Sir, most likely a left main stenosis.
I told you it's a 15-year-old boy. So what is happening? Like, it's very interesting ECG.
Sir,
there is ST elevation, but what is happening to the next beat?
So that is, sir, most likely, sir, acute pericarditis.
No, I'm afraid that's a wrong answer. But can any other team identify?
Al Kappa?
No.
15-year-old.
So you have to pick up one thing. That is, one is ST up and the other one is ST down. ST up, ST down. ST up, ST down. ST up, ST down. So what is this? It's a long QT with ST alternance. It's a long QT with ST alternance. So next one. Where is the dual chamber pacemaker? Answer please.
Sir, dual chamber pacemaker with septal perforation, sir.
I'm afraid that's a wrong answer. Anybody else wants to attempt? Please use the mic.
LSVC.
So that's the right answer. LSVC, you have but they can't get the marks. This is not a passing round, so they can't get the marks. So this is an LSVC. The lead is coming from here, LSVC into CS, into RA, and going into RV. So team 2, your question is going to come. So what is this sign known as?
South African flag sign.
How many of you think this is the right answer? Both the teams tell whether it's the right answer or wrong answer. Should we give them a mark or not? This is the right answer. Give them full marks, 10 marks to them. So what is the South African sign, South African flag sign?
It's a proximal diagonal occlusion, sir.
Okay. So generally, we have been taught to interpret ECGs with 2 contiguous leads. So this is one sign where you pick up signs in very, very different leads. So that is why to remember them, 1, 3, AVL and B2 shows the signs, these changes. So this indicates diagonal occlusion. So this is why this is specifically have to be remembered as a South African flag sign. So this is generally a diagonal occlusion. It almost indicates a ST elevation myocardial infarction of just involving the diagonal. Very good, excellent. Give them a big hand. So next question. So by the way, somebody may get a slightly difficult question, somebody may get a slightly easier question. They all pick their choice. A lot has been chosen by them. They pick their own luck. Identify the intervention done.
Left atrial appendage closure, transcatheter.
I'm afraid that's not the right answer. It looks like something like a stent, larger stent type thing. Something like a big stent is there, but something must have been inside stent, so it cannot be early appendage occlusion. It's not in the border.
It's in the pulmonary artery.
You're closer.
This PDA closure.
No, it's not looking like an occluded device. No? It is looking like a large bore stent. It was actually a my valve placed in pulmonary position. There's a pulmonary valve TPVI, transcutaneous pulmonary valve implantation. Maybe a melody, I think. So team 3, your question, your answers.
Atrial flutter with fixed block.
Very good. It's a fibrillation with a weight has become fixed. You're right. What is the reason then? What do you suspect like? You're right. It is a AF with regular heart rate, fixed block. That's what you're saying. But you didn't say that, I think. This is AF with fixed rate. Yeah, even if you tell us, then we'll accept it. This is AF. Clearly it's AF. It's not a flutter. It's AF. AF with fixed block means its fixed rates are fixed. You have picked it right. But what is the reason? If you tell that, we'll give you the full marks. When AF gets the regular rate, what do you mean by that? Like, what do you understand by that? In a patient known case of AF, now the rate is regular. What do you think? I'm afraid I think we cannot give it. Maybe the judges we can't give. They said atrial flutter with fixed block. This is AF with complete heart block. When you get a complete heart block, then the rate gets fixed. So it used to be observed as a marker of digitalis toxicity. So I think we can't give marks to you. So what is this X-ray? One clue is that patient was wearing this and he was removed after a few months.
Wearable defib.
Wearable? Wearable? What did you say? I didn't hear like wearable?
Wearable defibrillator.
Excellent, that's the right answer. It's a wearable ICD, which has now become available in India. So you should consider in very high risk patients whom you have to wait till the time they develop this. This is how it looks like. This is the wearable ICD. That's the right answer. So let's have the scores first. Scores. Can have a mic, ma'am, like. Yeah, you can come here. So I think team 2 and team 3 have got 10 marks each. Am I right? So okay, we go on like. So we go to the echo round. So the question is for team 1. So again the same thing, plus 10 and minus, no negative marking, no passing. Not hypercholesterolemia.
So this is a case of tuberous sclerosis with fibroblastoma on AML. Sir.
Anything more common in our parts of the country? Why there are something in the back also shown?
Neurofibromatosis. Sir.
This was simple rheumatic fever with subcutaneous nodules, extensive subcutaneous nodules along with rheumatic nodules on the mitral valve. Very uncommon to find that, but I think this is reported. We go to team 2.
RSOV.
So keep on running it like. There is no rupture, you can't see any rupture like. Yeah, are you seeing any continuous jet that is going? You can see a small VSD here, but what is that large structure? You are closer.
Submitral aneurysm.
It's not submitral, no? It is in that there only. You are close, we are very close. You said it's ruptured sinus of ulcer valve. What else it can be? Can you see a rupture? Can you see a jet going into RA, RV or RVOT? Then what do you call this? I'm afraid I think we have to move on. This is an unruptured sinus of ulcer valve aneurysm. It's an unruptured sinus of ulcer valve aneurysm. It's a large aneurysm. Maybe judges can decide whether we should give it or not. 5 marks to them. Okay, this was a large unruptured sinus of ulcer valve aneurysm which is projecting into the RVOT, and there is a small tiny VSD that you can see. Identify the procedure done. Team 3.
The stenting of the RVOT.
So how many in the audience think that they are right? Raise your hands. Only Bharti boss is saying. They are absolutely right. It's an RVOT stenting that has been placed in a patient with tetralogy of Fallot. So it's an RVOT stenting that has been done. So can we have the scores now? Mike.
Round 2, team 2 and team 2 has 5, team 3 has 10 and team 1 is yet to open the account.
We have plenty to go. So now we go to the imaging round, where the question is going to pass from 1 to 2, 2 to 3. And they are now going into the negative mark zone. Okay, are you all ready? So it's going to be plus 20 marks for a right answer and minus 10 marks for a wrong answer. And the question to team number 1, IGMC. You have 30 seconds more. You want to attempt or you want to pass? Pass. 15 seconds. You want to attempt or pass? Pass. The question goes to team 2 from AIIMS Patna. You want to attempt or pass? Attempt or pass?
We want to attempt.
You want to attempt?
Yes, sir.
Yeah, what is your answer? You can't now see like.
Epstein's anomaly.
So that's a wrong answer. The question, if you want to answer, you can go there. Go to team number 3.
Pass. Pass.
Pass. Anybody from the audience? Very good. It is very common in Bihar. I thought you will easily pick it up. Endomyocardial fibrosis used to be very common. You can see a classical, the whole thing is scarred. The RV apex is obliterated and it's scarred. The attachment is here. Sorry, I can't use a pointer. You can see the trigeminal attachment is normal. You can see the other image of showing a late scarring with a total scarring with all those things are seen. So this is typical of endomyocardial fibrosis. This is otherwise known as B sign. This kind of a pattern of fibrosis that is seen is classically described as B sign. So this is your question for AIIMS Patna. Multimodality imaging.
Sarcoidosis.
Absolutely right. This is cardiac sarcoidosis. Why did you say this is sarcoidosis?
Because there is diffuse delayed enhancement of mid myocardium, and in the this image B there is a Garland sign also. Multiple lymphadenopathy.
So basically, there's a mid-wall LG is seen, which is not subscribing to any vascular territory, and then you have uptake on. What is the scan that is commonly done for picking up sarcoid nowadays? These Dotanox scans are done. These are Dotanox scans which have shown active picking up. But what is the sign shown on the echo? Which I think all of you should be aware. Can I have a pointer? So that sign that is shown on the echo is commonly seen in advanced cardiac sarcoidosis, where you see that kind of a septal thinning. The septum, there is a portion of the septum gets thinned out. That's very considered reasonably good sign for picking up a sarcoidosis. So give them a big hand. Those who are clapping will get 2 lunches today. So the third team this is the third team.
Epstein.
Huh?
Epstein.
Epstein. That's the right answer. So what do you grade? How do you grade Epstein's?
Sir, Great Ormond.
What is GO score?
That's
Anybody
a
aware
Great
of GO
Ormond
score?
Street
So GO score,
echocardiography score.
it will be a very advanced Epstein where it has really gone there and the functional RV is slightly smaller. So all those things you can see. So can we get the scores?
Team 1 is yet to open the account. Team 2 has minus 10 and plus 20, so aggregate is plus 10. And team 3 has plus 20 in round 3.
Okay. So now we have at least eight questions to go, and 20 and minus 10 all on the buzzer. Whoever is first on the buzzer will be showing. Maybe this kind of buzzer I can't see who is pressed first, and immediately raise the buzzer so the judges can tell who pressed it faster. Okay? So raise your buzzer. Once you press and then raise your buzzer. Got it? Yeah. So we go to the curious coronaries. So plus 20 and minus 10. Nobody is pressing the buzzer. I thought everybody will jump on this. Okay, with the permission of judges, no negative marking. So team 3.
Recanalized thrombus.
So what is this sign known as? That is the right answer. Maybe we'll give half the mark to them. This sign is known as honeycomb sign. So maybe we'll give them half the mark because we said no for, or if you want to give them full mark also fine. This is a recanalized thrombus. This is for judges to decide. Full mark or half mark? 10 marks to them. So this is the recanalized thrombus known as the honeycomb sign. So are you ready? यार आप लोगों की भूख लग रही है क्या? चलो. Like ready? चलो. Team 3.
Constrictive pericarditis.
Why am I showing now? Coronaries? This is fantastic. This is phenomenal pick. This is actually a constrictive pericarditis with normal coronaries. This is very good. This is actually a calcific constrictive pericarditis with normal coronaries. Fantastic. Are you all ready? This is a patient with acute inferior wall MI. Anybody wants? इतना डरना नहीं यार कार्डियोलॉजिस्ट को आंसर पता है तो अटेम्प्ट करो. This is a patient with inferior wall MI. What has been done? Simple. I thought this. I think everybody will be on the buzzer. Okay, sir. No negative marking. No negative marking. So, AIIMS Patna? AIIMS Patna? Half-heartedly they raised it to half.
Like, wiring has been done and...
So, we know that wiring has been done. From what wiring, where from it started? That is the question. Do you think I am going to give something for wiring coronaries in a quiz program?
Actually, the location...
Of a state chapter?
The location of the origin could be anomalous, sir. It is it's arising from the left sinus.
That is the right answer. ना थोड़ा सा फोल्डर खुलता नहीं आजकल की जनरेशन में फोल्डर में सब कुछ स्टोर्ड होता है फोल्डर खुलता नहीं है. So this is actually an anomalous RCA arising from the left sinus with who presented with inferior wall MI. Now if you go back and see, so this is the first angio. You can see that it's an anomalous RCA which is totally blocked. Anomalous RCA which is totally blocked, which is coming from the left sinus, and now that has been opened through a left guiding. Clear? Okay. So can I have the sound of my laptop? Okay. So can we have the scores?
In the last round, Team 2 has plus 20 and Team 3 has 30.
So there's a final score, 20 and 30. Final
the
score?
Last round. For
no,
the
final
last
score.
round.
Total
okay.
score?
Okay, just let me see.
Because we have 5 questions to go, then we are well on time, so I have 10 more minutes to go. Started at 2:30. So we have 5 questions to go, so you can plan your strategies. Even now you can win. There are 100 marks to win and 50 marks to lose. So this is anybody's game. So we are into the last over of T20, and are you all ready?
So far, team 2 has scored 65 and team 3 has scored 70.
So it's such a close race, 70 and 65. So we have 100 marks to gain and 50 marks to lose. So they are doing phenomenally well. Let's see who is going to do. I think you all agree with the marks. There is no confusion in marks. There is no confusion in marks.
You have some confusion?
Team 2, 65.
Yeah. See, in round 1, they had plus 10. You also had plus 10. Okay. Round 2, they got 5. Half mark was given. And, 5. You got 10. Right? So here 5 marks difference. And round 3, they got minus 10 and 20 plus 20. 30. No, how can it be 30? It is minus 10.
Minus 10 and 20.
It is minus 10
I think
and
you
20.
added everything.
It is 10, 10, 10. It is 10.
That's why I always ask
10.
in between marks, so that otherwise it gets confusing.
It is 10. And team 3 got 20. They got 20. Okay. So then after that, right. So you have 10 plus 5 and 10. 25 here and 20 here. So 45. 45. And this team 3 got 10 plus 10, 20 and 20 and 30. 50. Yeah, you got 70.
So what are the final marks, ma'am? Like?
45 for team 2, 70 for team 3.
यार अपना मार्क ना आए तो दूसरे का मार्क कम हो जाना चाहिए ये तो बचपन से हम यही करते आ रहे हैं ना गुड गुड यार इट्स फाइन जस्ट फॉर जोक्स आर यू ऑल रेडी टू द फाइनल बजर राउंड $60 seconds, sir. I think time is going to be up. Anybody wants to attempt? There is a clue given here also. You can look at this clue also. So carefully concentrate on how the LB is moving, how each wall is moving. So is it moving with your heartbeat? I can't give more clue than this. So I'm afraid we have to move on. So this is actually a septal bounce recorded on MRI. With a calcific pericarditis, you can see a septal bounce. You can see the septal shudder and the septal bounce here.
This round has negative also, right?
Huh?
This round has negative also.
No.
No negative.
No negative. Nobody attempted.
No. But this
No,
round,
minus
if
10,
they
minus 10.
attempt,
Anybody
then it's
attempts it
minus.
is minus 10. Yeah. So you can see that like nicely it's a septal bounce which is nicely seen now. So identify the device closure that has been done. This is question number 2. You can see it's a very small little neonate it seems. I don't know whether it is preterm or term. I can't give more clue than this. Did you listen to the clue? Please listen to the clue. So my clue was, look at this, some looks like a neonate. I don't know whether it is preterm or term. What is the craze in pediatric cardiology now? Everybody wants to close sinus stenosis with a covered stent. what they want to do in preterm PDAs. This is a preterm PDA closure. Okay, anybody tells me the device name, I will give you 10 marks. Anybody tells me the device name, I will give you 10 marks. What device is placed in this? This is a preterm PDA closure. Generally, they all undergo surgery. This was actually a 800 grammer where we did a PDA device with this device. So what is the device? You tell me the device name, you get 10 marks.
No negative.
No negative.
M-Plads.
It is made by Amplatzer company, but that makes so many devices. So this is known as Piccolo device. So this is a Piccolo device, very beautiful device, very small, tiny little device. So that's what it is. Okay, we go to question number 3. So all of you do PVBDs, BPVs, pulmonary valve balloon dilatation. You have taken a patient for pulmonary valve balloon dilatation, and you do the RV angio. This is a surprise you find. What is the surprise? There seems to be valvular PS, but what else is there? Anybody wants to attempt? यार ये तो मैं सोचा कि T20 की तरफ जाएगा तो टेस्ट मैच का ड्रा की तरफ जा रहा है. Nobody wants to attempt anything. So concentrate on the levo phase. This is actually a valvular PS. That's fairly good enough. That's well nicely seen. RV function is normal. This is a pigtail catheter in the RV. But what else is seen in the levo phase? Want to attempt? Yeah, team 2 wants to attempt. AIIMS Patna.
VSD with PS. Like,
no, that's the wrong answer. Anybody wants to attempt? No. So now concentrate now. The question is over. Now see what is there. What is happening to that levo phase? Is the blood supposed to go like this and come down like this? This is the levo phase. Blood is supposed to go from pulmonary vein into LA. Where is the blood going? This is PAPVC. Partial anomalous pulmonary venous connection along with PS. Now you see running also, you can see. That's why I was telling you, concentrate on the levo phase. So the blood is going from PA, now entering into the pulmonary vein. So this part is coming here, the left side is going up. Okay. We have last two rounds left, so we'll go to what is the cause of this MR? So many images are given just to show that LV function is normal, the speckle strain is normal. That's what is shown. And what is the reason for this MR? What do you call this MR? So rest of the congenital things you don't know, it's not a problem, but it's now coming up. These are all diseases that are coming up that you should be aware of.
AFMR.
What is this AFMR? Atrial fibrillation in MR?
No, sorry. Atrial secondary MR.
Atrial functional MR.
Sorry.
Give them a big hand. This is what is now recognized as atrial functional MR. So you can see almost a severe MR happening. The speckles, everything is normal. You have a normal ejection fraction. You can see everything is normal. The leaflets are normal. There is no leaflet problem. So it is like a secondary MR. It is because of atrial dilatation. So our atrial tethering. Like for example, we understand ventricular functional MR. So ventricle keeps on dilating, you get MR. That we are all used to. But now this is emerging as a very important entity in two group of patients. One is in patients with atrial fibrillation and another one is patients with HPF. So in patients, when you are doing echo, oftentimes we write moderate MR without looking at what is the cause of MR. So this is a very important entity that if you start picking up, in a year you will pick up at least 20 patients with AFMR in any BC lab. So that is how common it is. Okay, very good, excellent. Give them another round of applause. Okay, so finally we are coming to we can have the scores because there's only one question is left, so they can strategize. Team 2 is in?
Team 2 has 55 and Team 3 has 70.
So still it is anybody's game, 70 and 55. I think let us see what is going to happen. So कोई बेट लगा दे एम्स पढ़ने के लिए हाथ उठाइए जो एम्स पढ़ने के लिए यार तुम्हारा तो कम है यार फोम टीम एडवांटेज ही नहीं है चलो so this is the last one in a patient with MVP and BT this is the MRI finding shows this is a patient with MVP and BT what has been shown
disjunction mitral disjunction
क्यों यार छोड़ सकते थे ना हाँ लॉक कर दिया आंसर श्योर this is in fact mitral annular disjunction give them a big hand so this is another emerging entity that all of us should be looking for show that please show that thing so this is actually the disjunction that unfortunately I didn't have a echo loop I had somewhere else but I didn't show in this so this is the disjunction this myocardium and the mitral valve structural apparatus there is a small gap where there is no muscle. So this is another entity that is emerging that all of us see so many mitral valve prolapse patients like. So in some of them you should start picking up. In echo also it is nicely seen. These patients are at higher risk of VT and sudden cardiac death. So you should be all looking for it. This is known as mitral annular disjunction or MAD, M-A-D. So a lot of things are coming up about it. So I think let's have the final scores.
Team 2 has 75, Team 3 has 70.
So they win by 5 marks in the last ball. Last ball chakka. Okay? So hope you all enjoyed it. Thank you for your patient listening. Yeah.
I'll request all the teams to kindly come forward for the prize distribution. You did well. Requesting Dr. Arvind sir and Dr. Bibi Bharti to please join us on the stage. Dr. UN Singh also and Dr. Adil Ahmed Khan also. Team 3. Hello. Okay, Dr. Neeraj Kumar and Dr. Praveen Kumar from AIIMS. Team 3. I won't announce the marks, don't worry. The third team, third runner-up, Team 1.
Cash prize, how much? So, Team 3, hearty congratulations for receiving a prize, and it was really remarkable that you came and participated. That itself means that you deserve a lot. So, congratulations to you. And medals have already been given, so they get a cash prize also, which they can of 5,000, which they can share among themselves.
A big round of applause for Dr. Praveen and Dr. Neeraj, second runner-up for the quiz. Calling on our first runner-up, Dr. Anshu Kumar Jha and Dr. Birja Kumar Jha. Birja Prasad Beora, I'm so sorry. Dr. Anshu and Dr. Birja. The first runner-up for this quiz B. Ma'am, could you please announce the cash prize?
So the first runner-up team, hearty congratulations, and you also get a cash prize of 7,000 from CSI Bihar Chapter. So now is the time for the gold medalist and team 2. Big hand to you. Hearty congratulations. Yeah. So
Dr. Rajat Bhatt and
Congratulations
Dr.
goes to their mentor, Dr. Anupam Bambani. Kudos to AIIMS Patna.
No, it's their hard work. So really, really very proud of you, Dr. Rajat Bhatt and Dr. Gautam N. Reddy. So they get a cash award from CSI Bihar Chapter of 10,000. May I request Secretary to present the award to the winners? Dr. Ramakrishnan. And the quiz winners are very, very eager. Just a minute. Dr. Ramakrishnan, quiz winners are very eager to have a picture with you alone. Only you and the winners. Please come, all of you. It's a very interesting quiz. Please.
Now it's time for general body meeting, GBM, for CSI Bihar Chapter. Now I hand over the command to our secretary, Dr. Upendra Narayan Singh. He will conduct the general body meeting.
So all the respected members of the CSI should stay back here, and rest of can go. All the office bearer and members are requested to stay. Yeah.
नहीं बुक हमको हाथ में दिए हम दे देंगे बुक यहाँ रखिए ना हाथ में